We are live, sir.
Dr. Smita.
Yes. So, okay. Good afternoon, everyone. And now today we are going to celebrate IAP Delhi, annual day. So welcome. This was now this year is going to complete. We are at the fag end of our tenure. I would like to call our president, IAP Delhi, Dr. R.K. Nav. Everybody knows Dr. R.K. Nav. He is president of IAP Delhi. Besides, he has been working with at various posts in Delhi IAP. He was vice president of Delhi IAP and co-op member, executive board member. He is also having a long experience in the working in the military and army, and he actually worked for charitable cause. He treats free the children from the army people, and this he is doing for last 30 years. So I invite Dr. R.K. Nav to tell his experience as the IAP Delhi president in the pandemic of COVID-19 and how actually he got over his depression about the whole thing, how he fought his fight with the COVID in the ICU, and how he still was able to sail through this all difficulties and was able to lead from front. So welcome, Dr. Nav.
Thank you very much, Dr. Sabitha. I welcome all of you, all the dignitaries who are in front of me. I can see Dr. Bhargav sir. Good afternoon to you, and Dr. Sangeeta Yadav madam, all of my office bearers, and all the IAP members. We welcome you for this. After successful completion of our prestigious conference of Pediatric Conference of North India and NIPID 2020, which we had on 2nd December to 5th of December. It was 4 days of absolute scientific feast, and on top of it, there was a great cultural evening yesterday, and in the mornings we had, every day we had a morning session as talk shows were there. The first day it was a spiritual talk, second day adolescent talk, third day it was digital talk, and the fourth day we had financial talk, which was very important. And for this conference, we were blessed by our chief guest, Kailash Satyarthi ji, the Nobel Laureate Peace 2014, and he gave the messages also to the pediatricians of Delhi and across India. Today we have assembled here to celebrate our annual day program of IAP Delhi. Dear friends, IAP Delhi is a strong body of 1556 pediatricians across Delhi with its 5 strong and vibrant city branches. Now a little bit of history. In 1954, the Association of Pediatricians of India was questioned and established its central office at Bombay. The Delhi State branch came into being in 1964. The first department of pediatrics was created at the Irvin LNJP Hospital, and Dr. P.N. Taneja joined as the head of department in 1952. Kalavati Children's Hospital came up in 1956, and Dr. Sheila Singh Paul was HOD. Next came Safdarjung Hospital Pediatrics Department 1957 to 1959. Dr. A.K. Basu was its head. Pediatric department at AIMS started in 1958. Meetings of late 50s were held in these hospitals, and they were held on Thursdays. That is the reason why we conduct our clinical meetings even today on Thursdays. In 1996, IAP Delhi registered under Society Act of 1986, and we purchased our office premises at Ansari Road, Daryaganj. But currently the office is at flat 114, first floor of Punjab and Sindh Bank building at Rajendra Place. IAP Delhi works for the wholesome development of children, prevention, treatment of disease, growth and development issues, mental disorders, and child sexual abuse and other crime against children through advocacy and academic activities. We also carry out several school health programs in various issues. IAP Delhi is working relentlessly for the welfare of children in all spheres. Friends, as you are all aware, we are still in the thick of pandemic of COVID-19. It has literally thrown life out of gears, and all our carefully made out plan in the beginning of years, they went out of the window. Even it has changed the terminologies, it is going to change the terminology in the history. BC earlier, which was called as before Christ, will be known as in coming time before COVID. The year 2020 will go down as a defining year in human history. Because of the COVID lockdown was brought on in initial phase, there were the first reactions to it. The lockdown was a sigh of relief. Once again, the mountain ranges were visible from the plains of Punjab, fresh air, clean sky, chirping of birds, an occasional visit of peacock at the balconies, and it was well appreciated. But the harsh reality is different. We cannot survive on love and fresh air for a long time. So we have to come out to work, but with full safety for our survival and survival of the economy. During unlockdown period, the process of COVID-19 pandemic continued, and now it has literally taken the shape of a tsunami of COVID, which has brought in a lot of COVID morbidities and mortalities, not only in Delhi, but across India. The worst affected lot is doctors, nurses, and healthcare workers. Dear friends, we have lost several precious lives of our colleagues, doctors all across India. At this same time, I'll tell you that this year, in the beginning of the year only, we had lost our two luminaries of pediatric fraternity, Dr. M.K. Bhan, who was HOD of pediatrics at AIMS. He was a great pediatrician, a great scholar, a great scientist, and above all, a great human being. And Dr. Tarsem Jindal, HOD of pediatrics of Jaipur Golden Hospital, and he was also a great pediatrician and again a great human being. We'll observe 1 minute silence to pay our homage to the departed souls. Om Shanti. As our secretary told you, I have also undergone this trauma about 2 weeks back, for 3 weeks, and for 15 days I was in the hospital. Dear friends, we have to take utmost precautions for this. The problem of this disease is the unpredictability part. What you are in the morning, you never know what is going to be the outcome in the evening. And once you come to know about the next door, in the next door room, the other person is shifted to ICU, you again start having palpitation, and there's the uncertainty which looms over your head. And on top of that, once you are left alone in this kind of situation, there is a loneliness feeling. And I'm very sure, once this epidemic of COVID-19 is over, there's going to be a pandemic of mental health problems. So we have to be very, very careful. Let's take all precautions so that we don't suffer. Our dynamic secretary, Dr. Samita Mishra, also got affected, but now recovering and performing her duties from hospital bed. Today also she is in the hospital only, and she is attending from there. Hats off to you, madam, for this. Pandemic also introduced to some good things, like it brought us the digital platform. Life has to go on. We have to work. IAP Delhi, we have tried to convert this pandemic adversity into opportunity, problem into possibilities, misfortune into blessing, and we never look back. IAP Delhi, with all its 5 strong and vibrant branches, were buzzing with activities throughout the year. Worked in unison, came out with several memorable activities, which will be told to you in Secretary's report in short while. Our IT team deserves full appreciation for keeping IAP Delhi media platform, website, Twitter, and Facebook fully active. IAP Delhi carried out more than 105 activities of different types throughout the year. Monthly clinical meetings were carried out on digital platform. To our surprise, the attendance over there was far better than what we used to have in physical meetings. IAP Delhi, in the beginning of pandemic, proactively came out with the advisories for Delhi government for prevention of spread of COVID-19 and carried out several meetings with the Delhi government officials and Ministry of Health. IAP Delhi also issued advisories for fellow pediatricians and for the pediatric clinics, which were very well appreciated. IAP Delhi celebrated several days, Daughters' Day with 47 schools pan India in collaboration with ST Public School Pitampura and ASGS Dream Welfare Society in the presence of Chief Guest, Honorable Member of Parliament Padam Shri Hema Malini ji, and guest of honor, social activist Mrs. Sumedha Satyarthi ji, and Mrs. India International Tourism Elegance, Ms. Surbhi Tiwari. And this was very well appreciated by everyone. We also celebrated World Heart Day, then Teenage Day, Child and Adolescent Health Week, and many more activities which will be told to you by Secretary. We have successfully completed our annual conference, which I have told you earlier. It was attended by more than 550 delegates on the screen, and thousands of people watched this live on YouTube also. I thank my very dynamic and strong-willed Secretary, Dr. Smita Mishra, for deep devotion and hard work towards IAP. Even from hospital bed, she continued working even for last 4 days also. I am thankful to all the office bearers and especially our President-elect, Dr. Lalit Mehndiratta, Secretary-elect, Dr. Manish Gupta, and Vice President, Dr. K. Kejani, my all esteemed EB members. They were always with me whenever I needed their help. And CIAP members, especially President Bakul Jayant Parekh ji and Dr. G.V. Baswaraj, Dr. Piyush Gupta ji, who is President-elect 2020, Dr. Vasudev, National Vice President, and Dr. Sangeeta Yadav. They were always very helpful whenever we needed any help. And they were there immediately with us, and they helped us. We pulled through in this difficult time also. I salute my fellow pediatricians and health workers who are fighting like soldiers against this invisible enemy. They are the true warriors. I salute them. Please take utmost care. I pray to God Almighty for your safety and good health. Jai Hind, Jai IAP. Now I'll request Dr. Smita Mishra to go ahead with the proceedings. Unmute yourself, madam.
Thank you very much, sir. This is very kind words, and I'm really thankful whatever you said. But I can say that it was always pleasure to work with you and the team which we have. So coming to next session of today's program, that is award paper presentation. So first of all, we are going for Dr. Satya Gupta award papers, and I invite our judges, Dr. Ellen Taneja, Dr. K.C. Tamaria, and Dr. Deepak Singla. And I also request Dr. Varsha Sawant to start the presentation. The presentation is total minutes allotted for the presentation are 10 minutes. One bell you get at 6 minutes, another in 8, and you should stop your presentation so that in rest of 2 minutes the judges can keep the question for you. So welcome, best of luck, Varsha. Please, Rohit, share the screen. Rohit?
Yes, ma'am.
Share the screen of Dr. Varsha. Dr. Varsha, Can you hear me? Dr. Vers,
रोहित, क्या आवाज नहीं आ रही है? क्या प्रॉब्लम है? या शेयर नहीं हो रहा है? रोहित,
यस सर।
ये स्टार्ट कर दो, डॉक्टर वर्षा का स्क्रीन शेयर है।
सर स्क्रीन, सर स्लाइड है आई नहीं होंगी ना मेरे पास इनकी,
तो खुद शेयर करेंगी।
डॉक्टर वर्षा को मैं आई एम जस्ट रिंगिंग हर अप।
Amongst the participants, panelists, they have to come as panelists only, no? Initially, they will, all the presenters will be panelists.
Yeah, hello.
Varsha's name is not there.
Ji?
That is,
She's not in the screen actually.
9765087502.
let us ensure that all the
Actually, Sushil has rang up. Only one person said she will not appear.
Till that
मेरी
time,
बात
can
कराओ।
we take the next person if she is available? He
Yes,
or she?
Yeah.
Dr. Saurdeep Banik, if
He
you
is
are
there.
there,
Dr.
please.
Saurdeep is there.
Saradeep is there.
So, Dr. Saurdeep, please share your screen.
Yes, ma'am. Is it visible, ma'am?
Open the presentation.
Is it visible, sir?
Yes,
Yes.
yes.
Presentation, yeah, presentation.
click on your presentation, it will open.
It is not visible yet.
Yes, your screen is visible, click on the presentation, it will open.
Yeah. No, your face is visible, but your presentation is not visible. Yeah, right.
Yes,
Now
it is there.
Now it is visible.
Then go to the screen. Good.
I will request except judges and all others should go mute and they should put video off. Only judges will be allowed to speak.
Okay, please start.
Okay, sir.
Please start.
Good afternoon to all. I am
Good
presenting my paper titled Prevalence of Primary Headache and Anxiety Among School Children aged 12 to 18 years in Urban Setting. Introduction. Headache and anxiety are common problems in children and adolescents. The estimated overall mean prevalence of headache in children is around 54.4% and migraine is 9.1%. In India, it varies from 19.5 to 66% and migraine 11 to 27%. India prevalence of anxiety varies from 8.5 to 16.7%. Headache and anxiety both causes few morbidities like school absenteeism, impaired social relationship, and poor quality of life. Rationale of the study. Prevalence of headache and anxiety is understudied in children in urban setting. Anxiety and headache has not been studied alongside in India, and their relationship also needs to be elucidated. Paucity of data on various triggers, risk factors for headache is understudied in children. What is the research question is? Research question is the prevalence of headache and anxiety in school children. Aim is to study the prevalence of headache and anxiety. Primary objective to determine the prevalence of primary headache and anxiety among school children aged 12 to 18 years. Now, primary headache disorder, it is criteria for primary headache fulfilled by ICHD 3 edition beta version criteria. And for anxiety, it is Spiegelberg state trait anxiety inventory criteria for state and trait. Secondary objectives, study the association between headache and anxiety, and association of various risk factors for primary headache disorder and anxiety like age, sex, family history, excessive media time, sleep deprivation, and obesity. Methods, it is a cross-sectional school-based study done in a public school in Delhi between August 2018 to June 2020. Inclusion criteria is school students aged 12 to 18 years, and exclusion is students who had chronic systemic disease, cases of mentally or physically disabled children as per record, and children who had known case of primary headache disorder and neurobehavioral disorder. Study tool for headache, it was a two set of questionnaire. One is screening questionnaire and one is confirmatory questionnaire, which is done by a face-to-face interview. So screening questionnaire is a 5-item questionnaire which is self-prepared, and confirmatory questionnaire which is done by a face-to-face interview to all the skin positive headaches is taken from the ICSD 3 edition criteria, which is a 20-item questionnaire. And for anxiety, it is from Spielberg state trait anxiety inventory, where state is an acute anxiety state and trait is an anxious personality disorder. For screening, it is 6-item questionnaire, and for final questionnaire is a 40-item questionnaire, 24 state and 24 trait. So methodology, we have selected 12 to 18 years of children. So after applying the inclusion and exclusion criteria, after taking consent, we have screening questionnaires given to the children, and then who were positive for either headache or anxiety, they were done a second questionnaire through a face-to-face interview in the school, and then statistical analysis was done. Sample size calculation. Sample size we have calculated according to a 3.8 into pico by d square, where prevalence we have taken from various studies. For headache between 19 to 66% and anxiety is 8.5 to 16%. So by calculating, so we have targeted a minimum of 400 screen positive cases. So results, total students between class 7 to 11 is 1600. So after applying the exclusion criteria, 50 were excluded. So total questionnaire were given for screening is 1550. Number of students who did not return the screening questionnaire is 401. So total screening done was 1149. Total screen positive was 520. Out of this, only headache screen positive was 231. Only anxiety screen positive was 83. And combined headache and anxiety positive was 206. So face-to-face was interview was done. Total 477 interview was done. So 43 was dropout. And for those only headache, 229 interview was done out of 231. For those who were screen positive for only anxiety, 75 interview was done. And both for headache and anxiety, 173 interview was done out of 206. So total migraine came out as 4%, TTH is 8.9%, total state positive anxiety is 6.2%, and trait positive anxiety was 4.2%. So total screen is 1149. Out of this, male is 53%. So maximum age group is between 12 to 13 years, which is around 43%, and maximum students from class 7, around 25%. So total screen is 1149. Final questionnaire applied to 477. So total primary headache positive was 12.9%, migraine 4%, and TTH was 8.9%, and total anxiety was 7%. So statistical analysis was done with various parameters with both the primary headache positive and anxiety positive group, and we have found that with primary headache positive, night sleep duration, family history of primary headache, excessive media time, and those with anxiety are statistically significant. Rest parameters are statistically insignificant. And with anxiety, age, night sleep duration, academic performance, low attendance, and those with primary headache was statistically significant. So in summary, primary headache was 12.9%, migraine 4%, and TTH was 8.9%. And those parameters are statistically significant with primary headache. So those students who were positive for primary headache, they have increased, they have less duration of sleep, they have family history of positive, they use excessive screen time, and they are also associated with coexisting with anxiety. And those with anxiety, increased age increases the anxiety. They have less duration of sleep, poor academic performance, poor attendance, and they are also coexisting with primary headache. So in our we have varies with different studies. In our study, primary headache came as 12.9. In different studies done in India and abroad, mean prevalence of primary headache was 19.5 to 66%. The variability is due to a lot of factors like different age group in different studies, school type, urban or rural, and the methodology like self-reported or interview. For anxiety, in our study, it was came as 7%. Different studies ranges from 8.5 to 16.7%. In our study, there is little less prevalence because of maximum age group was between 12 to 13 years of age. So in strength of the study, this kind of study has not been done
Please
in
conclude.
where alongside anxiety and headache, so many parameters have been compared with each other. We had applied 2 questionnaires, among which one questionnaire had been interviewed face-to-face by the primary investigator, which strengthened the study result. A limitation sample was selected from a single public school. Maximum representation of children between 12 to 14 years has the total adolescent prevalence might be understudied. Anxiety questionnaire was administered by the student, so might have led to bias to actual prevalence. So in conclusion, we found prevalence of primary headache and anxiety was 12.9 and 7% respectively in urban setting. TTH was more prevalent than migraine. State positive anxiety was more common than trait positive anxiety. That means the acute stress related anxiety was more prevalent than anxious personality in children. Headache is more frequently seen in children with decreased sleep duration, family history, or excessive screen time. Anxiety is more frequently seen with children with increasing age, decreased sleep duration. They have poor academic performance and poor attendance. Headache and anxiety are associated with each other. Those who have headache has higher incidence of anxiety and vice versa. So school children should be screened for headache and anxiety for providing early intervention to reduce school absenteeism and improve school performance. Thank you.
Thank you, Dr. Sirabdeep. Thank you very much. Can you tell me what chronic diseases you excluded in this?
Sir, bronchial asthma, tuberculosis, any neurological issues, any seizure disorder.
Okay, tuberculosis diagnosed or?
Yes, sir. But in school record, if there is any diagnosis of tuberculosis.
Them?
Yes, sir.
Past history or the children who are suffering?
So who are suffering, who are taking on medication, who are on medication.
Okay. In your study, it is a 7% less than other studies.
Yes, sir.
And it was you said that age range was different. So what was the age range in other studies?
So other studies between the maximum 12 to 18 years, but maximum anxiety came out after 15 years, the prevalence increases in the study.
Okay. Okay. Thank you.
One question. Your heading says, yeah, Dr. Deepak, your title of the study is urban setting.
Yes, sir.
But urban setting will include low middle group also, and you have chosen a public school,
yes,
where
sir.
the bias is automatically towards the higher income group. So the title should be something different to truly reflect, because tomorrow if I am studying the headlines of this paper, I will feel this applies to all the urban children, which is not true. Like if you go to a government school,
yes,
suddenly the data will be totally different. Either you should have taken 50-50 sample. The stratification of data could have been better if you are labeling it as urban setting, because Delhi urban means we have all kind of populations here.
Yes.
So that is something which I feel the heading could have been chosen with more due diligence.
Okay.
Dr. Tamria, do you agree with me?
Yeah, yeah.
Dr. Sardeep.
Yes, sir.
This is Dr. Taneja.
Yes, sir.
Good presentation. I must say you followed all the requirements of the presentation. My simple question was, you made such a beautiful attempt to visit the school and find out the cause of anxiety, stress, find out the relationship of anxiety, stresses, and detect the prevalence of headache. Hypertension is one of the important tools or important, underlying conditions in both of these situations. In this age group also, 11 to 18 years of age also, and as well as it can be a determinant for stress, anxiety, and headache,
Yes.
vice versa also. So did you examine these children also? Did you attempt to find out whether they have any underlying hypertension, and could that be addressed too? Because many of times there are only non-medical conditions which need to be addressed in these things. But hypertension is one medical condition, because you have made such an attempt. You visited the school, you interviewed the children, and did you take blood pressure also of these children?
Sir, actually I could not take the blood pressure because the time allotted towards me is very less in school. But they have not provided me too many time.
but having a face-to-face questionnaire of 40 questions, BP just takes less than a minute or so,
Yes.
maybe maximum 1.5 minutes.
Yes, sir.
It was quite feasible. I believe this is an opportunity which was missed. Should
Yes.
have added over there. I don't know what was the limitation, and this was a DNB thing, and there might be some limitations, but this was a wonderful opportunity. Otherwise, this kind of a data is available. We did our one of a thesis in our hospital was also on headache, and this kind of a similar data is quite available, reasonably available from India also. So the prevalence of TTH and migraine and non-TTH headaches, they are there. But
Yes.
this kind of an assessment and evaluation and maybe helping further would have been much more, informative and better. Anyways, you have a wonderful presentation. Thank you.
Thank you, sir.
Good presentation. Thank you.
I have one thing to say, Dr. Saurabh.
Yes, sir.
Basically, how do you relate ki this headache and anxiety, how they are correlated? You are saying the anxiety was common with headache was common. How do you relate these co-factors, and what more you could have done? Because as Dr. Taneja said, hypertension, and how in the questionnaire, how will you take the history of headache? It's a very subjective symptom. The child will say, I have, I don't have, and
Sir, we have.
what will be the importance of this for the community? You want to do something more, or do you think it's okay? You could have done more for this thing. And headache, how do you define the headache? Basically, headache is not easy to define the kind of headache you're saying.
Yes, sir.
Can we move
How they are
on?
related?
Sir, for a screening questionnaire, headache, we have the question framed like that how many headaches do you have in the last 6 months? So it doesn't any headache they can say a number. So how many headaches they have in the last 6 months? So if it is more than 5, we have taken as a positive for headache. And when we did the second questionnaire, so we have various criteria like how many headache, then is it headache more than 30 minutes at a time, or more than 2 hours, or less than 30 minutes, so like that we have.
And the correlation between headache and anxiety?
Sir,
you were saying that headache was common in anxiety also, anxiety was common in headache. How was the correlation found?
Sir, those who are screened
or you are
positive,
just saying?
No, sir, those who are screened positive for both headache and anxiety, and those who are screened negative for both. So when we have done statistical comparison with this, then it came that both the headache and anxiety have a correlation with each other.
Okay.
Okay, thank you very much.
Ah.
I think we should move to next.
Move to next this thing. So, sir, the second candidate didn't turn up because she has some theory exam. So this was the only paper in this group, Dr. Satya Gupta Award. Now we move to another group, Dr. P.N. Taneja Award, and I request Dr. Tamaria to stay in the for this also, because Dr. Pemde, who was judge in this session, cannot come because of some personal issues. So I request Dr. Sangeeta Yadav, Dr. K.C. Tamaria, and Dr. Dinesh Kaul to conduct the Dr. P.N. Taneja Awards paper session. Is it fine, Dr. Tamaria?
Okay, fine.
Okay.
No issue.
Then Dr. Puneet Kumar Chaudhary, are you there?
Thank you. Thank you,
Yes,
ma'am.
ma'am.
Thank you.
I'm there, ma'am.
Okay, so please share your screen. 6 minutes, then 8 minutes we will give a buzzer, and 2 minutes for the judges' question and answer. And I will request all the esteemed faculty to mute themselves, and only judges and the person who is presenting, they will interact.
Good afternoon, everyone. Ma'am, is my screen visible?
Yeah.
Go ahead.
Good afternoon, everyone. Respected teachers and my dear colleagues, I will be presenting my thesis paper. The title of my thesis paper is Inter-Observer Agreement between the primary care physicians and pediatric neurologists in classifying epilepsy among children aged 1 month to 18 years using modified Inkland diagnostic tool according to IAP 2017 classification scheme. This modified tool is based on the name of my institute. So for the sake of anonymity, I have removed the name. Briefly about the ILE classification scheme of 2017. According to this scheme, seizures at the level 1 have been broadly classified as focal onset, generalized onset, unknown onset, and a new classification that is unclassified. And at the level 2, these have been classified as focal onset, aware with motor, focal onset, aware, non-motor, and subsequently. And the most important thing is this classification scheme is entirely based on clinical judgment, and there is no role of neuroimaging or EEG. Coming to the importance of correct classification of epilepsy, this is very important because establishing seizure semiology in children is sometimes difficult because of the common mimickers, and the differentiating between the different semiologies at the times may be difficult. Also, misdiagnosis in rate of epilepsy is very high as 30 to 40%, even when the trained pediatricians are involved. So when there is a wrong diagnosis, it leads to the wrong management, and this in turn leads to significant burden for the health system of any nation. So primary care physicians play a crucial role in identification, treatment, and prompt referral of childhood epilepsy cases. Hence, empowering the primary care physicians to identify seizures type is very important. Briefly about the Inkland diagnostic tool for epilepsy. This was developed. It has 13 questions to diagnose epilepsy, covers 2 to 9 years aged groups, and sensitivity and specificity is 85 and 95%. A modification to the Inkland diagnostic tool for epilepsy was developed at our institute, and it covers a wider range of age, that is 1 month to 18 years, and it has a sensitivity and specificity of 92% and 88%. And the first 2 questions of this tool deal with semiology. So this Inkland tool and this modification, they both tell us whether the child has epilepsy or not, but they don't tell us what kind of seizure semiology the child has. So also, we don't know, there is no study comparing inter-observer agreement between pediatric neurologists and primary care physicians according to the ILA classification scheme. So our study hypothesis was that the inter-observer agreement between a primary care physician and pediatric neurologist in classifying epilepsy among children aged 1 month to 18 years according to ILA scheme will be 0.8 of kappa value. So the first objective of my study was that we will develop a questionnaire as an addendum to the existing institute Inkland diagnostic tool of epilepsy, so that along with class saying that the child has epilepsy, we will also be able to tell what seizure semiology the child has according to the ILA 2017 classification scheme. Our second objective was to estimate the inter-observer agreement between the MD residents and the pediatric neurologist. And the third primary objective was to estimate the inter-observer agreement between the MBBS interns and the pediatric neurologist. Outcome parameter was inter-observer agreement kappa value. This was a cross-sectional study. Study population was children aged 1 month to 18 years. Ethical approval from the Institute Ethics Committee was obtained. Written informed consent was taken and duration of the study was October 2017 to January 2019. Children with confirmed epilepsy aged 1 month to 18 years were included in the study, and children not accompanied by primary caregiver and poor general condition were excluded. Sample size came out to be 130. Initially, we decided to enroll 60 patients in each part of the study. So this is the flow of the study. First, we added 6 questions to the existing modified tool so that we can also classify the semiologies. So a questionnaire based on this was developed. 2 MD residents and 4 undergraduate interns were trained for tool application. Children aged 1 month to 18 years with confirmed epilepsy were enrolled in this study. Construct validity was done in 20 children, 10 under supervision and 10 without supervision. So any child was evaluated in the first part of this study by an MD and a pediatric neurologist. So MD resident used this addendum tool developed to classify the epilepsy, and the sequence in which an MD or the pediatric neurologist would classify the seizures was randomized, and also which MD resident and which pediatric neurologist will first do the evaluation, that was also randomized. In the second part, similarly, independent evaluation was done by undergraduate interns and the pediatric neurologist, and later we calculated the inter-observer agreement with kappa values. So this is my baseline characteristics. Total 144 children were there. Mean age was 5.5 years. At the first level of classification, the most common seizure was generalized seizure, which constituted 43%. 15% of the children out of 144 had multiple semiology seizures. Rest 122 had single semiology seizures. At the level 2, the most common seizure semiology identified was general motor. Few of the seizure semiologies like unknown non-motor and focal aware motor. There were no children which presented with these semiologies. So the results at the first level of classification between the MD residents and the pediatric neurologists, the agreement was 68%, kappa value was 0.52, which was below the hypothesized value of 0.8, suggestive of moderate agreement. At the second level, the kappa value was 0.28, suggestive of fair agreement. At the part 2 of the study, where the evaluation was done by MBBS interns and the pediatric neurologists, the agreement at first level of classification scheme was 0.45, suggestive of moderate agreement, and at the second level, it was 0.3, suggestive of fair agreement. So coming to the discussion and conclusion, this existing institute inclined diagnostic tool for epilepsy as seen in previous study has good sensitivity and specificity for establishing the presence or absence of seizure. So its modification, which is addendum 2000 sensitivity 2017, which was developed as a part of this study, has shown moderate agreement for categorizing broad seizure categories at first level, but not for detailed semiology at the second level and the subsequent level. However, this is the first tool to help primary care physicians help classify epilepsy, and it is a promising tool which can be bettered with modification. We felt that a more comprehensive training to the primary care physicians, which in this study were represented by the MD residents and MBBS interns, if we train them more comprehensively, their inter-observer agreement will be improved. The strength of this study is that this is the first study which estimated the agreement between the primary care physicians and pediatric neurologists in classifying seizure among children. Randomization of the sequence in which each child underwent evaluation by MBBS interns and MD students and the pediatric neurologist was done properly. Also, the sequence in which 3 pediatric neurologists, 2 MD residents, and 4 interns evaluated the children was also randomized. Evaluators were blinded to the finding of each other. When the pediatric neurologist was evaluating the child, the primary care physicians were not present in the room, and vice versa. Limitation of this study we feel is that MD and MBBS students at the place of their study in our institute may not truly represent the primary healthcare physicians. There is no disclosure, none conflict of interest, and no source of funding. I'm completed my presentation.
Thank you, Dr. Chaudhary.
Yes.
Very good presentation. With the permission of the other judges, can I
Sure, ma'am.
set the
Sure,
ball
sure.
rolling?
Yeah,
Okay.
bilkul, sure, ma'am.
Okay, thank you. You are Puneet, no?
Yes, ma'am.
Puneet, what do you mean by construct validity and its implication?
Ma'am, initially before starting the study, this tool was used by the MBBS interns and the MD residents, and as a gold standard in the classification is the pediatric neurologist. We cross-checked that whether the evaluation done by the MBBS interns and the pediatric MD resident using this tool was correct or not.
Is it applicable in what other conditions or situations this is applicable? See, if you are using some tool, what are its practical implications and utility in other situations?
Ma'am, in this situation, it was that to empower the primary care physicians, whether we can develop a tool which can help them classify the epilepsy correctly according to the 2017 scheme, because correct classification is important for the treatment, whether
Okay.
it is.
Now tell me what change was done in this tool which you wanted to study, the addendum which you have made in this existing inclined tool, what changes were done, incorporated, and why?
Yes, ma'am. So this tool which was existing, ma'am, it tells us whether the child has epilepsy or not. So first 2 questions of this tool, they also include questions related to the semiology. So we added questions as to include all the semiologies as per the 2017 classification scheme, so that all the semiologies are there, so that we can also.
Do you have it as a part of your annexure for presentation?
Ma'am, I have not included as the annexure, ma'am.
Okay. With your tool, which does not have much agreement, what change you would like to have in this tool, in this addendum, so as to improve the inter-observer value between these two, primary health physician? Like you said, limitation is that the cohort of the observers or the study subjects is different and not very much like primary health physician.
Yes,
what the points which you would like to incorporate and suggest the changes so that it is more useful for the primary care physician?
Ma'am, we would like to make the questions in our questionnaire more elaborate and better, which can be understood by the primary care physician, so that he can ask the questions and he can understand what the patient's attenders are saying. Also, we can include a video-based training module in which who are assessing the children, they can actually see the seizure semiology. So this could have been included as a part of the training of the MD residents and the interns, ma'am.
So that before applying the questionnaire, one shows them the video and that should be part of it. Then one should proceed with it.
Yes,
Am I
ma'am.
right?
Yes, ma'am.
So that is one suggestion you would like to give along with this?
Yes.
Good.
Thank you.
Okay, I'm done.
Puneet, it was a single blinded or double blinded study?
Sir, the pediatric neurologists, they were the gold standard. They were evaluating the children, and when they were evaluating the other assessors, that is the primary care physicians, they were not present in the same room. And the forms were after they have evaluated the pro forma was kept in a sealed envelope. So the other assessor was not knowing what kind of seizure semiology the child has. So both the assessors were blinded to each other.
So two blinded, double
Yes.
blind.
Yes.
Okay.
Well, I'm not a pediatric neurologist. Could you kindly tell what were the components of this tool, some of the components which you structured them for the questionnaire?
Yes, sir. So for focal seizure, the question was like, does your child have stiffening of the one side of the limb associated with uprolling of the eyes, drooling, frothing from the mouth, bluish discoloration around the mouth? And for the focal chronic seizure, the question was whether your child has jerky movements of the limb of the one side. For the focal to secondary generalization, the question was whether the abnormal movements start from the one side and proceed to the other side. And for the generalized, suppose for a myoclonic seizure, the question was like, does your child have sudden lightning like violent movement followed by fall to the ground?
But these questions would be, say, irrespective asked by the neurologist as well as the primary care physician to the parents. Is that so? Because the questionnaires were similar, which were asked by the pediatric neurologist and the primary care physicians.
Yes, sir. But the questions were more elaborate so that it was easier for the assessor to understand and subsequently ask them to the parents.
Okay.
I think done.
Yeah.
Well,
Thank you,
we call
Dr.
it?
Puneet.
Thank you, ma'am. Thank you.
Thank you.
So now I call Dr. Alpana Meena. Dr. Alpana Meena, are you there?
Yes, ma'am.
Please share your screen. And you know the total time is 10 minutes. 6 minutes will give buzzer, 8 minutes will give buzzer, and then after 8 minutes, the questioning will start. Okay.
Okay, ma'am.
I'm really full of admiration because all the presenters are very much on time.
Good afternoon, everyone. I am presenting my paper on urinary abscindin levels in children with iron deficiency anemia. Introduction: the iron deficiency anemia is a common nutritional deficiency worldwide.
Alpana, please share
You
your
need to share the screen.
Alpana,
slide.
Share the
slide
screen.
is not running.
Please open your presentation, Alpana.
And
make
share
it-
the screen.
Yeah.
You double click on your presentation and then on the bottom is the share screen green icon.
तुम्हारा उससे नहीं खुलेगा वो जो टिक मार्क लगा है ना you have to open on your presentation itself.
Yeah,
Yes.
that's good.
Perfect. Now I am starting and you can start. Okay.
Okay. Alpana बोलो. think.
I'm having this problem actually.
Alpana, एक काम
Is it
करते
visible?
हैं. Yeah, Alpana, just listen first. Smita, let us. Can we Can the host do the presentation for her from their screen, and she just speaks, because she might have a little problem with the bandwidth. That's why her voice is not very clear. Then she only has to speak.
Ma'am, we are sharing from the back end. Dr. Alpana, you can speak.
Yeah, Alpana, do that. Then you don't share from your computer device. Then we will not have problem with your hearing part, because sometimes when we have video, we have problem with the audio. We switch off your video, we only have your audio. That's clear? Go ahead.
Okay, ma'am.
Yeah.
Okay, ma'am.
Yeah.
Is it visible, ma'am?
Yes.
Hello.
Yes,
my slides are
visible.
Alpana, please proceed with your presentation.
Okay, I'm presenting my paper on urinary hepcidin levels in children with iron deficiency anemia. Introduction: iron deficiency anemia is a common nutritional deficiency worldwide. In Indian scenario, age 6 to 59 months contains of 69.5%, in 5 to 11 years 41.8%, and in 12 to 15 years 68.6%, and 15 to 19 years is 55.8%. Hepcidin is a 25 amino acid peptide hormone, and that synthesized in hepatocytes. It helps in iron regulation by facilitating control of iron uptake and movement in form of ferritin, and by inhibition of absorption, and by blocking the release of iron from macrophage. My objectives were, my primary objective was to estimate urinary hepcidin levels in children with iron deficiency anemia, and secondary objective was to determine cutoff levels of urinary hepcidin, and to estimate, to study the correlation between urinary hepcidin and serum ferritin levels and other iron parameters. Methodology: my study design was case control study, and place of study is pediatric OPD at tertiary care hospital, and sample size was 100, and written informed consent was obtained and pro forma filled. In my study, children were classified as follows. In iron deficiency stage 1, that 25 children were taken with normal iron parameters except low serum ferritin, that was less than 20 nanogram per milliliter. In stage 2, children were taken with low serum ferritin less than 12 nanogram per ml, and low serum saturation, transferrin saturation less than 16%. In stage 3, the 25 children were included that have clinical picture of microcytic anemia and low transferrin saturation and serum ferritin levels. Data collection, normality of data were tested by of SIMO test. Quality variables were compared using ANOVA and Kruskal Wallis test. Quality variables were compared using square test, and a P of 0.05 was considered statistically significant. My 6 months to 12 years, and in exclusion criteria, this was anemia due to other causes like chronic disorders, anemia, and megaloblastic anemia, and infections and issue of iron. My results were control group was 114.28 plus 94 nanogram per ml, and stage 1 99.86 plus 47, stage 2 18.31 plus minus 27.66, and stage plus minus 40. In my levels was significantly low
There seem to be some audio issues. Can we hear it?
No, I don't think we can hear her. Her voice is also cracking intermittently.
Dr.
not audible
Alpana,
actually, ma'am.
Dr. Alpana, listen to me. Dr. Alpana, Dr. Alpana, listen to me. Can you hear me?
I think we lost her.
So,
I think we have lost her.
Rohit, Rohit,
Rohit is also not
Yes,
there,
ma'am.
I think.
Rohit, I am sending you the number of Alpana and we'll start again for her. And I am calling another person. Huh?
Yeah, we can move to next
Okay,
presentation.
ma'am.
Yeah. So you have slides for everyone or you don't?
No, ma'am. We don't have slides for everyone.
But
Dr.
for Alpana, you have.
Yes, ma'am.
So I
Good.
think still this slide was run by you or Alpana.
We are, ma'am, playing the slides.
Okay, so
But,
despite of that, the sound is breaking, right?
Yes,
So
ma'am.
just
Her
let her say
connectivity
ki
issues
she
there.
should move place and then she should actually restart. So I called Dr. Juhi. Dr. Juhi, are you there? Dr. Juhi Gupta.
Yes, good morning, ma'am.
Good morning. So Dr. Juhi, you start share your screen. The time for you is total 8 minutes of presentation and 2 minutes for the judges to ask question. So kindly start sharing. After you start sharing and speaking, then I will start timer.
Yes, ma'am. Is my screen visible, ma'am?
yeah, visible.
Okay, thank you.
Go ahead, please.
Okay, okay, ma'am. A very warm good afternoon to all my teachers and respected colleagues. And I thank Delhi IAP for giving me this opportunity. The title of my study is Evaluation of Repetitive Transcranial Magnetic Stimulation as an Adjunct to Modified Constraint Induced Movement Therapy, which is CIMT, in improving upper limb function in children with hemiparetic cerebral palsy, age 5 to 18 years, a randomized controlled trial. I don't have any disclosures. Cerebral palsy is leading cause of lifelong physical disability, and hemiplegic cerebral palsy is the most common subtype amongst term infants and second most common amongst the preterms. Transcranial magnetic stimulation is an upcoming non-invasive rehabilitative modality, and there is a paucity of studies on combined use of repetitive TMS and modified CIMT. In a child with hemiparetic cerebral palsy, either we can excite the lesioned hemisphere or we can inhibit the non-lesioned hemisphere so that it does not inhibit the lesioned hemisphere with interhemispheric inhibition. In my study, contralesional inhibitory repetitive RTMS was used. My research hypothesis was in children with age 5 to 18 years with hemiparetic cerebral palsy, RTMS as an adjunct to modified CIMT for 4 weeks is superior in improving upper limb function as per increase in total QUEST score by 5 in comparison with modified CIMT alone. QUEST is quality of upper extremity skills test. On similar lines, we formulated our primary objective and the primary outcome measure as well, which was difference in mean change in total QUEST score within 1 week of completing 4 weeks of intervention. There were several secondary objectives like subdomain scores of the QUEST score, assessing the speed and strength of upper limb using a 9-hole pegboard and a handheld dynamometer. Assessing the sustenance of improvement at 12 weeks, quality of life, compliance to therapy, adverse events, and cortical excitability. It was a randomized controlled trial with patient recruitment from OPDs, clinics, and Department of PMR, with the enrollment period from February 2019 to March 2020. The inclusion criteria were, apart from age and diagnosis of CP, were IQ more than 70, preserved vision and hearing, and children with uncontrolled epilepsy, severe concurrent illness were excluded. The sample size calculation brought us to 35 children in each group, but we committed at least 20 patients in each group as per feasibility. This was done based on prior studies. The flow of my study was in the 7 days prior to In the 7 days optimization, all children underwent a functional assessment and a TMS neurophysiology assessment. In the 0 to 4 weeks intervention period, all children received 10 sessions of RTMS, which were real for the intervention arm and sham for the control arm. The sham TMS was given using a sham coil, which replicated the real coil and produced the same click sound. And the supervised CIMT was common to both the groups. The children were assessed once at 4 weeks for primary outcome and the again at 12 weeks. And in between 4 and 12 weeks, all children received structured home-based CIMT sessions. We used block randomization with variable block size prepared by Department of Biostatistics, and the allocation concealment was done using sealed envelopes, which were also prepared by them. All children underwent a baseline TMS assessment using a EMG data and a hotspot identification, that is location of the hand area of the motor cortex for each child. Thereafter, children were seated on the TMS chair, and this is the TMS machine by which they were given the TMS. These are some of the CIMT activities in which child is wearing a restraint on the unaffected arm and is doing activities from the affected arm. These are some of the home-based CIMT activities done by the study population. In the end of the visit, functional assessment was done by a physical therapist who was masked to the group assignment. We monitored the children using a TMS and daily activity monitoring log, and the data measurement and the statistical analysis was done using Stata 14.0. This was a 9-hole pegboard, and this was a handheld dynamometer used in the study. The ethical clearance was taken, and the trial was prospectively registered at clinicaltrials.gov. In the consort flowchart of my trial, 168 children were assessed for eligibility, and 46 children were randomized with allocation concealment, 23 to each arm. All the children completed the trial except one, and all 46 children were included in intention to treat analysis. A secondary per protocol analysis was also done, which did not change any of the conclusions. All children were comparable with respect to demographic baseline parameters as well as the functional parameters. The primary outcome revealed the change in the mean quest score of 11.7 as compared to 6.6 in the control arm, with a effect size of 5.1 and a significant p-value. And the proportion of children with increase in quest score by 5 was also 82.6% in the treatment arm as compared to 52.2% in the control arm, with the effect size of 30.4 and a significant p-value. This was a quest score used in the study. In the secondary outcome measures, we found improvement in the domains of weight bearing and protective extension. These are the subdomains of the quest score. This was the dynamometer used in the study. In the secondary objectives, at 12 weeks also, these changes were sustained in the total score as well as in the domain scores. And if we compare both the groups at 3 time points using repeated measures ANOVA with Bonferroni correction at baseline, 4 weeks, and 12 weeks, there was a significant improvement for the total score as well as the domain score for both the groups, as well as the speed and the strength parameters for both the groups. We did not find any serious adverse event. In the cortical excitability parameters, resting motor threshold and the cortical silent period, which was calculated from the end of the MEP to the resumption of the EMG activity, decreased after therapy. And for the quality of life measures, there was improvement in feelings about functioning and participation in physical health. We also did a post-hoc neuroradiology classification of the MRIs of the study subjects, wherein we classified the stroke patterns into posterior trunk of middle cerebral artery, that is PT pattern, the distal M1 pattern, the proximal M1 pattern, wherein the basal ganglia is also involved, the periventricular venous infarction pattern, and the lateral lenticular striate pattern, where we see a gliotic focus in the basal ganglia area. The maximum children had a pattern 84.8%, and the commonest pattern was periventricular venous infarction in the 41% children. Ours is the first study from a low to middle income country which has explored the effects of combining RTMS with CIMT for improving upper limb function in children with hemiparetic cerebral palsy. Children in both arms could participate in a structured rehabilitation program encompassing peer-supported supervised CIMT sessions. Patient population was homogeneous and minimal attrition rates. though a longer follow-up could have been more indicative of the long-term outcomes. And the conclusion was that combining the two therapies is superior and the effects are sustained at 12 weeks. Thank you. These are some of the drawings made by children in the study.
Thank you, Dr. Chui. Dr.
you.
Chui, how you randomized the your control and cases?
Sir, we used a variable block randomization with a variable block size. So we used sealed envelopes. So whenever a study child was fulfilling the exclusion and the inclusion criteria, we would open those opaque sealed envelopes, which were prepared by the Department of Biostatistics. And that is how we randomized. And the type of randomization was block randomization in 1:1 ratio, sir.
Okay. So you control, you taken from the all patients who attending OPD, control also selected from there?
Yes, sir. Both the groups were selected from the same population.
What was the dropout rate in your study?
Sir, only one child did not complete the sessions. He had a family emergency, so could not travel to the hospital for the sessions.
Okay. Okay, thank you.
Thank you,
Ma'am,
sir.
Dr. Sangeeta. Dr. Sangeeta. Dr.
Yeah.
Paul.
Yeah, Dr. Sangeeta, go ahead first.
Okay. Pooja, what is the advantage of this transcranial magnetic stimulation? You had very elaborate charts, but as far as the conclusion is concerned, I have just wanted you to, what key message and recommendation you would like to make out of this study of yours?
Yes, ma'am. Ma'am, currently the standard of care in children with hemiparetic cerebral palsy is CIMT, that is constraint-induced movement therapy.
Yes.
But still the results are suboptimal. And these machines of TMS are very widely used in psychiatry side and they are already FDA approved. So if we can start combining these two therapies and devise the optimal rehabilitation programs, that will add to the benefits of CIMT and that will help in improving the quality of.
Now I would like to know what is the cost of this machine and what will be its utility if we want to extend this program under, you have heard of the Rashtriya Swasthya Karyakram? Supposing if we want to extend it to various disability centers across which we are trying to, so that is why I asked you the cost and its utility. Like we are doing it for CBNAT, no, for NTB game. That is why I'm asking you this question.
Okay, thank you for your question, ma'am. Ma'am, this machine is a costly machine. The cost varies from brand to brand and our machine was 90 lakhs. But this TMS has been increasingly being used in autism, ADHD, epilepsy, migraine, and increasingly studies are coming up. So it can be used for a variety of modalities, variety of diseases as well. And these machines are already available at many centers. It is just that they are not being used for child neurology and pediatrics.
So that is your conclusion and that is your recommendation that it should be. So that's what I asked. What is the key message? In fact, what is your recommendation?
Since, ma'am, it is a non-invasive modality and the equipments are completely reusable all the time. And not only for cerebral palsy, this can be used apart from this study. There was a parallel study going on for epilepsy and now there is a study going on for autism. So for a variety of neurodevelopmental disorders, this machine can be really helpful for children.
Okay. Thank you. Thank you, Juhi.
Thank you.
I think this is a nice study. It's a very nicely designed study. You have even taken for a trial. It has been registered with the clinical trial registry. But with this info, I gather to understand that possibly this is not an FDA approved technique at this point of time. Is that so?
Yes, sir.
Okay, but your study design and the results show that this seems to be quite effective. So I think this should be definitely an asset for such children with cerebral palsy. So I think maybe we need to have more conclusive studies, so that, but the cost should not be as a deterrent if this is the modality of treatment combined with other things. But you are telling that the psychiatry people are using in which other conditions?
Sir, the machine is FDA approved. Was approved in 2000.
For what? Which condition?
Yes, sir. For major depression in adults in 2008 and for migraine in 2013. So this is FDA approved for these two conditions in adults. So that is why it is mainly being used in psychiatry side. For child neurology, it is yet not FDA approved. The trials are ongoing, sir.
But this is nothing like to do like an electroconvulsive therapy. This is nothing to do with the conventional, what the old time psychiatrists used to do in ECTs, electroconvulsive therapy. Is it something akin to that? Is the modality of, I mean, the way it works, how it sensitizes the neurons and how it affects at the cellular level, is the mechanism same as ECT?
Sir, so the basic difference is there is nothing electrical in this machine. It is magnetic. It is magnetic fields.
It's a magnetic. It's like in magnetic fields. Or you are generating primarily magnetic fields, and they cause certain neuronal changes.
Yes, sir. Yes, sir. They cause long-term potentiation and long-term depression changes in the neurons.
Okay. For how long do you give them this magnetic stimulation? For about, say, 10 minutes at a time, or and how frequently?
Sir, we can give the various regimens of 5 minutes, 10 minutes, 20 minutes, 30 minutes. In my study, it was given for 20 minutes. Usually across the world, it is being given for 10 minutes, 20 minutes, or maximum 30 minutes.
And how frequently? And how frequently it's done?
Sir, either it can be given daily for 7 to 10 days, or like in my study, I gave alternate day over a period of 4 weeks.
Thank you.
Thank you, Dr. Choi. Nice presentation. Thank you.
Thank you. Over to Smita.
Dr. Smita.
Rohit?
Ma'am, Dr. Alpana is here. Yes, ma'am.
Okay. So continue with Dr. Alpana Meena.
Yes, ma'am.
Please share Rohit, please share her slide.
Ma'am, we are sharing.
Okay, so continue with that.
Okay. Good afternoon, everyone. My title was Urinary hepcidin levels in children with iron deficiency anemia. Second slide, please. Introduction. Iron deficiency anemia is a common nutritional deficiency worldwide. In Indian scenario, age 6 to 59 months contain of 69.5%. In 5 to 11 years, incidence is 41.8%. In 12 to 15 years, 68.6%. And in 15 to 19 years is 55.8%. Next slide. Now, hepcidin introduction. Hepcidin is a 25 amino acid peptide hormone synthesized in hepatocytes. It acts by it helps in iron regulation and acts by facilitating iron uptake and movement in form of fat, and by inhibition of absorption of dietary iron in duodenum, and by blocking the release of iron from macrophages. Next. My objectives were, the primary objective was to estimate urinary hepcidin levels in children with iron deficiency anemia, and secondary objective was hepcidin, and to study the correlation between urinary hepcidin, serum ferritin levels, and iron parameters. Methodology used was, the study design was case control study and place of study in pediatric orthopedic tertiary care hospital. Sample size was 100 and the written informed consent was obtained and performer were filled. Children were, in my study, children were classified as follows. In iron deficiency stage 1, the children, 25 children were taken with normal iron parameters except low serum ferritin level, that was less than 20 nanogram per milliliter. In stage 2, that 25 children were taken with the low serum ferritin, that was 12 nanogram, less than 12 nanogram per ml, and low serum transferrin saturation, less than 16%. Data collected was entered, and analysis was done using SPSS version 21. Normality of data were tested by Kolmogorov-Smirnov test, and quantitative variables compared using ANOVA and Kruskal Wallis test. Qualitative variables compared using chi-square test, and p-value of less than 0.05 was considered statistically significant. Next. My selection criteria was in inclusion criteria, all patients of anemia from age 6 months to 12 years, and exclusion criteria, anemia due to other causes like hemolytic anemia, megaloblastic anemia, chronic disorders, and infections, and previous 3 months. The results were urinary hepcidin level in normal healthy control group was 114.28 plus minus 88.94. In stage 1, 99.86 plus minus 145.47. Stage 2, 18.31 plus minus 27.66. And in stage 3, 16.03 plus minus 48.78 nanogram per milliliter. Urinary hepcidin levels were significantly low in all stages of iron deficiency as compared to control group. And reduced hepcidin levels were significantly correlated with serum ferritin, iron parameters, and other hematological parameters. This slide shows correlation between urinary hepcidin and clinical laboratory parameters, and that it includes that hepcidin levels are significantly low with increasing severity of iron deficiency anemia and less than 0.05. Next slide. Comparison with other studies. At a study conducted by Sonia Ji et al., the values were in control groups were 439.92 plus minus 91.84, and stage 1 362.6 plus minus 31.36. In stage 2 273.16 plus minus 30, and in stage 3 189.12 plus minus 21.14. And in my study, the control groups having hepcidin levels of 114.28. In stage 1, 99.86 plus minus 145, and stage 2, 18.31, and stage 3, 16.03. Next slide. The conclusion of the study was that with the increasing severity of iron deficiency anemia, along with hematological parameters, that is hemoglobin, mean corpuscular volume, MCH, MCSA, and transferrin saturation, total iron, and urinary hepcidin levels also decreased. The levels of hepcidin can detect iron deficiency anemia even before it is clinically manifested. As being a non-invasive sample urinary test, it may be recommended as a simple mass screening tool in large population in a resource-constrained nations like India. For further recommendation, it opens opportunity as a simple toolkit which can be used by peripheral health workers to detect IDA even in adult patients and especially women of childbearing age. And for this, for determine hepcidin levels, further studies are recommended on a bigger sample size to define cutoff levels for a logical conclusion. Thank you.
Okay, good. Alpana, I will start with the questions with the permission of the other judges.
Yeah, ma'am. Please go ahead.
Yeah. Alpana, if you had to put your hypothesis, what would have been your hypothesis in this study of yours?
Ma'am, my hypothesis was that in iron deficiency anemia, as hepcidin is a iron regulator, so it also decreases.
So what will be your statement for hypothesis?
That hepcidin levels might decrease in children with iron deficiency anemia.
And what will be the research question?
That ma'am, can it decrease in children with iron deficiency?
What statement you have used related to research question?
Ma'am, I use that hepcidin levels. Can hepcidin levels decrease in children with iron deficiency anemia?
Okay. Now, since you have recommended that your study can be used in the periphery as a, so what kind of tool it becomes then, this study of yours, urinary hepcidin?
Actually, ma'am, I determine the levels by using ELISA test, but
Okay. No. You recommend that it can be used as a screening tool?
Yes, ma'am.
That is the word you would use?
Yes, ma'am.
Okay. If you use the screening tool, you will you have one objective was to establish cutoffs, isn't it?
Ma'am, sorry, ma'am.
Your one of the objective was to determine the cutoffs. So have you determined the cutoffs in your study?
Ma'am, according to my study, that cutoff levels was included. I told in my presentation that in control group that was
to just listen, Alpana. To make the cutoffs, you use some other statistical method to arrive at the cutoffs?
No, ma'am. I use only chi-square test and.
कोई होता है मेथड जो यूज कर सकते हैं to establish the cutoffs?
No, ma'am.
Okay, thank you. I'm done.
Alpana.
I hand over.
Alpana.
Okay.
Have you calculated
Yes,
sample size? Have you calculated sample size?
Sir, that was the formula. According to that, there's a total 100 patients were taken actually.
How you taken? How you decided 100 patients?
He wants to know the statistical calculation. How did you arrive at the number 100?
That is, sir, n equals to 1 minus AD under curve minus alpha, and that was the actually, sir, that was the formula that was used.
You including all the anemia cases and excluding some hemolytic anemia or other anemias. So all anemias, what do you mean by all anemias?
Megaloblastic.
Sir, I took the anemia cases that come in OPD. But after some investigations like CBC and iron profile, I did that. And after that, excluding the cases which conclude like if there is vitamin B12 deficiency, so I excluded that type of cases.
Okay.
And in iron profile, if there is iron low, that I included also that. And low ferritin levels also.
Okay. Dr. Cole?
No, I think her design is quite good. I don't think see any problem with the study design. She is primarily looking at the iron deficiency anemia, and she has taken ferritin, storage iron, as a marker, given it different grades, say 20, less than 20, less than 12. And but the thing is that what will it cost? Is it more cost effective than doing an ferritin level? Well, if it is it is cheaper than doing a ferritin, then and it can be done at a peripheral level. As you said, it is done by an ELISA. We need a lab, a biochemistry, or any other lab which has the ELISA reader, which has a, so it can't be done on a bedside or something like that. So it won't be that easy. N would be the cost. So if it is there are a lot of hematological parameters which are being generated by the labs. But I think it is a worthwhile to look at this. I was looking before you were at an Egyptian study where in 211 where they had looked at the urinary hepcidin levels. And so if it is going to be a cheaper alternative and a more better alternative, then possibly yes, we can use it.
So therefore, from this current study and all, one cannot conclude and recommend it for the as a peripheral screening.
Mass level.
Yeah, it doesn't look like a screening tool.
Exactly.
Yeah, screening tool.
Fine.
I think, thank you, Alpana.
Thank you, Alpana.
Okay.
Over to Smita.
Okay. Thank
Dr.
you.
Smita,
Yes.
so we have done.
So,
Next,
sir, thank you very much.
only 3
Dr.
cases.
Only 3 cases.
Okay. Fine.
Now we move forward to another award, that is Dr. Sarla Vaishnaw Award. The judges for the session are Dr. Sisir Paul, Dr. T.P. Yadav, Dr. Anurag Agrawal. Judges, please take your seat. Dr. Sisir Paul, Dr. T.P. Yadav, and Dr. Anurag Agrawal. And the first presenter would be Dr. Asma Tak. Dr. Asma, are you there?
Yes, ma'am. Am I audible and visible?
Yes,
You
Asma,
are
you are
audible and visible,
Yeah.
and share your slides.
Please share your slides and start.
Our judges, Dr. Yadav, if he is there. Dr. Sisir Paul is there. Dr. Yadav is there? Okay.
Ma'am, is my screen visible?
Ah, yeah, this is visible very clearly. So kindly
Start, Asma, start.
Okay, thank you. So good afternoon, respected seniors and dear colleagues. I thank the distinguished chairpersons of IAP Delhi for providing this opportunity. The title of my study is Body Composition of Healthy Term Indian Newborns by Air Displacement Plethysmography. South Asian adults have similar body fat despite a lower BMI compared to Caucasians, and this leads to a greater risk of metabolic and cardiovascular diseases in them. Early studies on newborn body composition using skin fold thickness suggested that Indian babies, though smaller and lighter, have similar skin fold thickness, and this led to labeling them with a thin fat phenotype. This was supported by hypothesis of the thrifty genes, wherein it was stated that Indian babies may have a set of thrifty genes that conserve more body fat. But the Indian data on newborn body composition using reference methods like air displacement plethysmography is still scarce, and we need more such data to draw effective comparisons with the Caucasian population so as to understand whether the differences in body composition of newborns do actually exist, and if so, whether these differences are due to genetic and non-modifiable factors or physiological ones. So the first study which established the thin fat phenotype in the Indian baby was by Yashnik et al., who suggested that Indian babies in their study, though smaller and lighter, had similar subscapular skin fold thickness and thus compared to Caucasians, and thus had a thin fat phenotype. This was followed by MRI done by Neena Modi et al., who saw that the Indian babies in her study had similar total adipose content compared to Caucasian babies. Later, deuterium dilution technique was used by Jain et al. To study the fat mass percentage of Indian babies, and they found that it was comparable to Caucasian babies, although it did not show any correlation with birth weight. And lately, a study done by air displacement plethysmography in South Indian babies by Kurian et al. Shown that birth weight and fat mass percentage actually was having positive correlation, which meant that as birth weight decreased, fat mass percentage decreased. So this was against the thin fat phenotype theory. So my research question was, what is the body composition of healthy, term, appropriate for gestational age Indian babies as measured by air displacement plethysmography in the first 48 hours of life? And what was the effect of various fetal and maternal factors on the newborn body composition? The primary outcomes I studied were fat and fat-free mass of the newborns, which were studied both in absolute values as grams, as percentage of the body weight, and as indices adjusted for length. Secondary outcomes studied were factors that influence these, like duration of gestation, the newborn weight and length, parental weight and BMI, and maternal diet and socioeconomic factors. We included term babies who were appropriate for gestation and born single to healthy mothers, as described as having no chronic illness or pregnancy-related complications. We excluded any sick newborns or those born with gross congenital defects or undergoing phototherapy in order to ensure a healthy cohort. The body composition of the infants was measured by air displacement plethysmograph, known as PPOD, developed by the COSMED. So this is the PPOD machine, and it has a mass scale on which you measure the mass, and then there is an enclosed chamber which measures the volume. Then mass by volume is used to calculate density. Then the machine uses an equation to determine the fat mass percentage, in which density of the body is the independent variable. Anthropometry of the newborns as well as the parents was performed by following the SOPs followed at the hospital, and antenatal data was collected retrospectively. The results. So we had equal proportion of male and female babies in our study. The mean postnatal age was 36 hours of the babies, and the mean gestational age was 38 weeks. The mean birth weight was 2,882 grams for the babies in our study. Coming to the family characteristics, maternal preconceptional BMI was 21.4, and at the time of delivery was 25.6. Gestational weight gain, as calculated by subtracting the maternal preconceptional weight from the weight at the time of delivery, was 11.8 kgs. We further characterize this weight gain on the basis of categories as given by the Institute of Medicine for pregnancy weight gain into inadequate gestational weight gain, adequate, and excessive. 44% had inadequate weight gain, 39% had adequate, and 17% had excessive weight gain. So we see that the babies in our study, 8%, they had a fat mass percentage of 8% of their body weight. And coming to the factors that influenced this, we saw that birth weight had positive correlation with the body fat percentage, meaning that with increasing birth weight, body fat actually increased, and with decreasing birth weight, we did not see any conservation of body fat, contrary to the popular opinion of the thin fat phenotype. Instead, we saw that body fat also decreased at lower birth weights. This is more clear in this graph, in which we have divided birth weight into categories, and we see that in the category of birth weight that is comparable to the Caucasian population of 3,300 grams, the mean fat percentage also increases from the value of 8 to 10%. And in the group which has birth weight of less than 2,700 grams, we do not see any fat conservation. Instead, the body fat drops from 8 to 7%. Other factors like gestational age. With increase in gestational age, birth weight also increased, and so did its components fat and fat-free mass, but it did not have any significant effect on the body fat percentage. Coming to gender, females in our study were comparatively lighter and smaller compared to the males. They had higher values of fat mass and lower values of fat-free mass, such that the overall fat mass percentage was lower in males compared to females. Coming to maternal factors, the maternal BMI in the at the time of delivery had positive correlation with the body fat percentage. So we see that mothers who had a lower BMI gave birth to babies that had a lower body fat percentage, and those that had a higher BMI gave birth to babies with higher body fat percentage. In terms of gestational weight gain categories, those mothers that had inadequate weight gain during pregnancy gave birth to babies that had lower birth weight and body fat percentage compared to those that had adequate weight gain, and those that had excessive weight gain gave birth to babies with higher birth weight and body fat. We did not find any significant relationship with any of the other secondary factors like maternal age, maternal education, maternal occupation, family income and socioeconomic status, maternal preconceptional weight and BMI, and paternal weight and BMI. So this is a table which shows us a comparison between the Caucasian data and the Indian data, and this is the current study which I'm talking about. So you can see that in all these factors that are influencing the body composition of the newborns in the study, Indian babies fare less compared to the Caucasian babies. The gestation age, which influences birth weight, is lower in our study compared to the Caucasians. Similarly, the birth weight in our study was 2.8 kgs compared to the Caucasian range of 3.3 to 3.5. The babies were also smaller with a length of 48.5 centimeters compared to Caucasian range of 49 to 50. And despite being smaller and lighter, these babies were not showing fat conservation. They had a lower body fat percentage of 8%, while as the range for the Caucasian population is between 9.3 to 10.8%. Mothers also had a lower BMI and a lower gestational weight gain compared to the Caucasian mothers. So, to conclude, the Indian newborns do not have a thin fat phenotype. Rather, the fat mass percentage drops with decreasing birth weight and is hence lower compared to Caucasian newborns. But important is that this low fat mass percentage of Indian babies can be attributed to physiological factors, including lower birth weight and lower maternal BMI at the time of delivery, rather than ethnic influences exerted via genes. Summarizing, the neonatal adiposity or the body fat proportion in our study was influenced by the birth weight of the babies, and this in turn was influenced by physiological factors like duration of gestation, maternal BMI, and gestational weight gain. So the strength of the study was that this is the first study that reported the body composition of newborns from North India using a reference method like air displacement plethysmography. We compared the body composition. This data can be used for comparison of body composition data of preterms, SGA or large for gestational age babies, sick babies or formula fed newborns in an Indian setting, so that it can have a we can take a step towards indigenous references of body composition rather than using Western data. And the study approached the body composition of newborns in a holistic manner. However, most babies were a selective cohort, and these belong to mothers who required tertiary center care, so it could have led to selection bias. The correlation with the maternal body composition or
Please conclude.
Okay. The correlation with maternal body composition or intrauterine growth parameters was also desirable, and follow-up measurement of the babies is needed to observe the trend in the fat mass percentage of the newborns. So this study helped dispel this study challenges the previous theory of the thin fat phenotype of Indian babies, and it shows us that Indian babies do not have a greater fat at birth. So it will be interesting to study the body composition of such cohorts into adolescence and adulthood to see what are the environmental and physiological factors that lead to greater fat gain in adult life and hence greater risk of metabolic and cardiovascular diseases. Thank you. Any questions?
Okay. Sir is there, Dr. Yadav sir. Sir can start the discussion maybe. Hello.
Sir, please.
Yes, sir.
Unmute yourself.
Dr. Yadav sir.
Am I audible?
Yes, sir.
Yes, sir.
Yes, sir.
Okay, I just wanted to ask, what is the relevance of your study?
Yeah, same question I had in my mind. Exactly. I noted. What is the relevance of the study?
Nothing extra did you tell us. So what is the relevance?
That is the first question I too noted.
The relevance of the study lies in the fact that the earlier opinion was that the differences between the Indian and the Caucasian body composition is of the newborns is because of the genetic reasons. However, in this study, we see that at birth weights approaching that of the Caucasian babies, we are actually having a similar body fat percentage. So if we control some of the physiological factors that determine the body, that determine the birth weight of the babies, it will help, it may change the body composition of the Indian newborns as well. So it kind of negates the effect of genes that are leading to ethnic differences between the body composition of Indians and Caucasians.
But that was not the hypothesis you put forward to dispel, and nor was the study designed for that purpose.
Sir, it was designed to determine the body composition of the Indian babies using a reference method, and we use that data to compare it with the Caucasian population.
No, that is true. That is why I'm saying relevance is still not answered.
Sir, because earlier studies had showed that Indian babies were actually born with a greater percentage of fat. But in our study using a reference method, we
I'm
have
again saying, interrupting you, the thin fat theory. The study was not designed to refute that.
Sir, but in our study, we can see that our babies, despite having a thinner physique, despite having a lower BMI and a lower birth weight, the body fat of our babies
You are
is
just
not
repeating
high.
your findings. You're
Yes.
repeating your findings. See, your study was not designed to refute that hypothesis or theory. Okay. So you cannot justify that you refuted that theory. Dr. Paul, please.
I just wanted to know, I mean, do you want any future studies on this? I mean, what is the way ahead? I mean, what do you achieve by doing this and the follow-up of these babies, whether you feel this fat was normal or lower at birth, and in the future I mean, what is the aim to do this thing?
So the aim here is that in adults, we see that South Asian adults have greater body fat percentage. But when we see that the Indian South Asian babies, in this study, as we can see that they don't have a greater fat percentage at birth. So we are saying that genetic factors may not be at play for this difference in body composition. If we now follow these babies into adulthood, then we may be able to see what is the postnatal trajectory of fat gain, and that may in turn help us to understand the factors that affect that postnatal trajectory of fat gain, and hence modify the risk of metabolic and cardiovascular diseases that is associated with that fat gain. So
to see whether it is genetic or acquired type of a thing.
Yeah, because if we say it is genetic, then it becomes non-modifiable. But if we say that the role of physiology is also important, role of maternal nutrition is also important, then there is a scope for modification of those factors, and there is a scope for lifestyle interventions in later on life, so as to not have that adverse body composition wherein we are having greater body fat as adults compared to Caucasians, despite having a leaner physique or a lower BMI.
Thank you. Dr. Anurag.
So how did you calculate your sample size?
Sir, the sample size was calculated using the study by Jain et al. That was previously done on body composition of Indian newborns only. And in that sample size, we took a relative precision of 12%, and we took the fat percentage as the independent variable, because that was the variable which was having the highest standard deviation. And using that reference study, we were able to calculate our sample size of 130 newborns. But considering some babies might drop out due to logistical issues, we went on to enroll 145 newborns.
So you were just doing a single estimation. So how would your baby drop out? Either the baby is in the study for that day or is not there on that.
Yes, sir, but the issue was that these babies were healthy babies, and most of them would be discharged by day 2 of life. So sometimes it was not, even if you go a day ahead and enroll these babies in the study based on your criteria, the next day they might be getting discharged, and because the lab timings had to be matched with that, so we estimated that there could be a possible dropout. We may not be able to perform measurement of all the babies that we enrolled.
And what was the research question as such?
So research question was that what is the body composition of the healthy, term, and appropriate for gestation Indian babies as measured by air displacement plethysmography in the first 48 hours of life.
So you were seeing only fat. So why do you want to use the term body composition? Why not body fat, whatever, mass or whatever you wanted to say? Why see body composition of healthy terms? So it gives a very broad meaning. It could be protein, it could be carbohydrate, it could be anything else. So it should have been body fat composition of healthy term Indian newborns. Why composition? Why do you want to make it such
I thought you were going to give all the figures.
Yes, I also thought, I was in fact thinking, how will you do it? You are only using some kind of a formula which is provided with the machine. And what is the validation of the formula?
Sir, this formula has been previously validated by using the this is body composition measurement using air displacement plethysmography, uses a 2-component model in which it distinguishes body mass into fat and fat-free mass. This has been validated with the gold standard, which is the 4-component model. That is measurement of all the 4 components, as you said, protein,
If this is
mineral
not the
content.
gold, so Dr. Saab, if this is not the gold standard, then you have done an agreement study. You have not even done a, so you were comparing with, okay. So,
Sir, but the studies on agreement have already been published on this in a newborn setting only. Prior to this,
what was the level of agreement?
sir, while the body fat percentage in the study performed by the 4-component model, that is the gold standard, was 7.5%. The body composition in that study measured by the air displacement plethysmograph was 6.5%.
6.5 versus 7.5, so around near, what was the kappa cohorts? You will not remember it because it was another study. Okay. The slides which you were presenting were slightly out of the standard presentation mode. I do not know that's acceptable or not. Normally, were you given a pattern in which the slides have to be presented?
No,
Title,
sir.
Introduction, research question, then your null hypothesis or whatever, then your sample size calculation, methodology.
Sir, actually I had placed those slides, but because of time constraints, I decided to omit 1 or 2 slides so that I could buy the time given to me.
I think we have taken a lot of time. We will move to the next presentation. Okay, thank you.
Thank you, sir.
Sir, I think we can move Dr. Yadav sir and Dr. Sizerpal sir.
Yeah, sure.
Next candidate.
And any other question?
No, please, next
To the next
Okay,
because
okay.
we have a lot of time.
Okay. So now I call, and this second presenter is not there, Dr. Chintana. So Dr. Sujoya Datta, please come and share your screen. The time allotted to you is 10 minutes and 8 minutes for the presentation and the rest of time for the questions. So kindly continue.
Am I audible and my screen visible?
Yes.
Please go on to slide mode.
Okay.
Yeah, okay.
Good afternoon, respected judges, respected seniors, and my dear colleagues. I'm Dr. Sujoya Datta. I'm here to present my paper on poor vitamin D status in children and adolescents with type 1 diabetes mellitus. Shall we worry? Diabetes is an emerging global pandemic, and according to a study by International Diabetes Federation, in 2017, India was ranked second in having children and adolescent patients with type 1 diabetes mellitus. Also, India has a high prevalence of vitamin D deficiency across all the age groups. A meta-analysis of observational study found that serum 25-hydroxy vitamin D levels were significantly lower in patients with type 1 diabetes mellitus than in healthy controls. So why we conducted this study was that India is a country with high incidence and prevalence of both vitamin D deficiency as well as type 1 diabetes mellitus. And there are very limited studies available on vitamin D level in Indian children and adolescents with type 1 diabetes mellitus. Also, the effects of vitamin D levels on various factors like glycemic control, hospitalization due to infections or decay episodes, these have not been very well studied. So we had the research question that what happens to the serum vitamin D level in children and adolescents with type 1 diabetes mellitus, and we conducted this study with the aim to assess vitamin D status in children and adolescents with type 1 diabetes mellitus. Our primary objective was to assess 25-hydroxy vitamin D levels in children and adolescents with type 1 diabetes mellitus and compare it with controls. And we had secondary objectives to determine association between duration of type 1 diabetes mellitus and 25-hydroxy vitamin D levels, glycemic control and vitamin D levels, frequency of infection episodes, hospitalizations with vitamin D levels. We conducted a cross-sectional study spanning across 18 months after obtaining approval from our institutional ethical committee. Based on a study by Bay et al. In 2018, taking alpha 5% and power 80%, we arrived at a sample size of 42 cases and 42 controls. We included cases as patients with type 1 diabetes mellitus of the age group 2 to 18 years for treatment for more than 3 months, and age and gender matched unrelated non-diabetic controls were recruited. We excluded patients with type 1 diabetes mellitus who have poor compliance to treatment, patients who presented in DKA or had history of DKA within 2 weeks preceding the enrollment, patients on any vitamin D supplements or drugs like anti-epileptics, glucocorticoids, thyroxine, antitubercular drugs, antihypertensive drugs, history of chronic disease or any parathyroid abnormalities or coexisting malabsorptive disorders. We took history of frequent infections like skin boils, fungal skin infections, gastroenteritis, upper respiratory tract infections, sinusitis, urinary tract infections, eye infections, frequency of hospitalizations due to infection or DKA in past 1 year, daily insulin requirement over the last 3 months. We recorded vital parameters, anthropometry, any clinical signs of vitamin D deficiency. We analyzed HB1 glycosylated hemoglobin by HPLC and serum 25-hydroxyvitamin D levels by radioimmunoassay. We did comprehensive diabetes management according to standard guidelines for our patients, and they were provided with diet and exercise counseling and reinforcement. We took vitamin D cutoffs according to global consensus recommendations on prevention and management of nutritional rickets, as 20 nanogram per ml or more as sufficient, 12 to 20 nanogram per ml as insufficient, and less than 12 nanogram per ml as deficient. And we took glycosylated hemoglobin levels less than 7.5% as good control, 7.9% as fair control, and more than 10% as poor control. Primary outcome measure of this study was serum 25-hydroxyvitamin D levels, and the secondary outcome measures were correlations between vitamin D levels and duration of diabetes mellitus, correlation between vitamin D deficiency, insufficiency, and sufficiency, and their glycemic controls, and frequency of infection episodes and hospitalizations, and vitamin D levels. We did the statistical analysis using SPSS software version 26, and we calculated this, frequencies using descriptive statistics. We used students t-test to compare group characteristics like vitamin D levels, glycemic control, hemogram, liver and renal function test, infection episodes, chi-square test to compare categorical variables like vitamin D status, Pearson correlation coefficients to find the correlations as mentioned in the outcome measures like glycemic control, infection episodes, hospitalizations, and took p-value of less than 0.05% as significant. What we found was that our baseline characteristics of our cases and controls were comparable. We had 43% of males and 57% of females in both our control and cases, and the age, height, weight, and BMI were comparable in both the cases and control groups. In cases, our mean age at diagnosis was 7.1 years, duration was 3.29 years, and average daily dose of insulin was 23.98 units. Coming to a primary outcome measure, this HbA1c and vitamin D levels, we see that as expected in cases, the glycosylated hemoglobin levels are much significantly more than the control group, with cases having 11% and control having 5.1%. In vitamin D levels, we find that the cases had 19.8 as the average serum level, and controls had 21.7 nanogram per ml as the serum vitamin D level. When we come to the status, we see that the controls were in the sufficient group in considering the average vitamin D level, and the cases were in the insufficient group. However, our p-value was did not come to be significant, so we did not consider this as statistically significant. When we compared the vitamin D status in cases and controls, the interesting result was that in cases, the percentage of vitamin D deficient and insufficient patients of diabetes in our cases group was significantly higher than the percentages of vitamin D deficient and insufficient children in our control group. So that came out to be statistically significant. We found no correlation between the vitamin D status and the glycemic control in our cases, and the p-value was not significant, and only one patient in our cases had a good glycemic control. Even in duration of the disease, there was no significant correlation between the duration of disease and vitamin D status of our cases, and all the three categories had only marginal differences in the mean duration of the type 1 diabetes mellitus. And even when we looked at their average serum levels, there was no significant difference. In frequency of infection episodes not requiring hospitalization, we saw that there was no significant correlation between the frequency of infection episodes and the vitamin D status of our cases. There was no significant correlation between the infection episodes requiring hospitalization in relation to the vitamin D status in our cases. And also there was no significant correlation in the frequency of DKA episodes in our cases with relation to the vitamin D status in our cases. So we came to the conclusion that even though the mean serum vitamin D levels were comparable in both cases and controls, however, the vitamin D status in our cases was significantly poorer when compared with our healthy controls, which implied that we would need further large population-based interventional studies to determine if this low vitamin D status really affects the health and disease of these groups. Thank you.
Dr. Sujoy.
Yes, sir.
What is the correlation of vitamin D, or what is the action of vitamin D in production of insulin? Is there any action of vitamin D plays any production of insulin or action of insulin?
Sir, in various studies at molecular and genetic level, it has been found that vitamin D has actions at the beta pancreatic cells in the potassium channel receptors. There has been, at molecular level, it has been found that there was a significant interrelation between the vitamin D and the insulin secretion from the pancreas. So studies were done whether this has been, whether there were any significant correlation. However, very few studies have been done regarding this, whether the vitamin D status really affects the insulin requirement of these patients or not.
No, my question is, by giving vitamin D, does insulin secretion increase?
So to determine if it really increases or not, we would need interventional studies to determine whether we...
No. Has any study been done to show that? What does the literature say?
Sir, the literature study showed that it could be beneficial in the sense that if the vitamin D levels are good, then the insulin requirement from outside of the children would be less, as in the pancreas would be able to secrete more insulin.
And do you think by supplementing vitamin D in patients of diabetes with vitamin D deficiency would improve the glycemic control?
So for that, we would need interventional studies to see whether it really happens. That has not been proved in our observational study.
What does the literature say on that?
Sorry, sir?
If it does not affect the secretion of insulin or action of insulin, then what is the relevance of this study?
So the relevance of this study was that we found that in our diabetic children and adolescents group, the proportion of the vitamin D deficient were more than in our healthy control group. So it is possible that the vitamin D status does affect the is low in our diabetic group as compared to the healthy group. So we should conduct further study to see whether this the vitamin D status also affects the course of disease in our type 1 diabetes mellitus or not.
Few years back, a study was published in Indian Pediatrics done by Lady Harding Group, They showed that in community, 80% of Indian children are vitamin D deficient.
Yeah.
Yes, sir.
See,
I think it would have been better if you study in poorly controlled, the vitamin D is less and compared to the well controlled or something. Giving a general statement like this, I don't know how far, because vitamin D deficiency is rampant, and I think all endocrinologists are supplementing vitamin D to all their diabetics. That is what I know in my patients on the follow-up with endocrinologists. They generally supplement with vitamin D to all. So if there's any difference between the poorly controlled and well controlled, and the level of vitamin D would have probably more relevance.
She did not find any correlation with glycemic control, although the HbA1c was 11 point something, which shows poor control in all
Poor
our
control,
patients.
yeah. Poor control. The average H1C is very high for a controlled diabetic.
Sir, most of our patients had HbA1c in the category of poor control, but we did not find any significant correlation with the vitamin D status in our study.
So that's what I'm saying. Your conclusion does not match your tables. What did you conclude? What is your conclusion?
Sir, I concluded that even though the vitamin D status is significantly poor in our diabetic group than our non-diabetic group, but whether this vitamin D status really affects the course of disease in diabetes or not, that could not be found out in our observational study. We would need interventional studies for that.
So that is not your aim of study. You can leave that second part out. But in your tables, only one table was showing some significance. You were so fast that I could not read that table.
Sir, I can show the slide again.
That table which was showing significance. So from that table, you have inferred that vitamin D is deficient in diabetics more than in non-diabetics. That's
Yes,
what you
sir.
want to say. That was
Sir,
only.
I'm repeating the slides.
There was just one table which had a
Yes, sir.
significant
I'm
level.
coming to
Other
this
than
slide.
that, all slides were showing there is the p-value was not significant at all anywhere.
Sir, this is the slide that showed that there was a significant p-value.
Of what? What is this? Vitamin D deficient? Number
Sir,
of
this is
16
the
controls.
this is the vitamin D status in our case group and our control group. In our case group, we had 38% who were deficient, 21% who were insufficient, and 41% who were sufficient.
Is this p-value for one group of observation or all three group of observation?
Yes.
All three.
So this is a combined p-value. So
yes, sir.
Deficient and insufficient are how much different? This borderline difference is there between them. So if you just look at the table as such, the vitamin D sufficient are 17 and 20. That is nearly similar. So if the lower column is the lower row is similar, the top two, if you add up, they also come somewhere near itself.
Yes, sir. That is why it averaged out, and we did not get any significant difference when we see the serum vitamin D levels in cases and controls.
Yeah, so that's what I'm saying. Vitamin D and insulin or diabetes have no correlation anywhere, as per your study.
Sir, as per my study, I found that the serum levels don't have a much difference, but the number of vitamin D deficient patients in the cases are more than the number of vitamin D deficient patients in control. But these patients do not have much difference in their vitamin D levels among them.
So if you come to next, insufficient, the insufficient level is more in controls and less in vitamin D. So what does that mean? Why don't you take that interpretation that vitamin D is better in diabetics and not better in normal population? So basically, this does not have much of a relevance. We can simply say that okay, we did not get much of significance.
Yes, sir, we did not get much of significance.
So it's all right. Your study does not have to always prove your research question or your hypothesis, disprove your hypothesis.
Yes, sir.
You always say that there is no correlation, and we are happy with that also.
Yes.
So I think.
Yeah.
Sir, any other question?
No.
No, I think that's all right.
Thank you.
So, thank you so much. Thank you.
Thank you, sir.
Can we close this session?
Yeah, definitely. The third presenter is not there, I think, no?
No, he is not there. So thank you very much, Sujoya. Good presentation, and we'll look for the result. So Rohit, I request you to share the CV slide. Now this is the time when we are going for the oration. So this is first oration is Dr. P.N. Taneja oration. In Delhi, when I came, first I worked with him and I had a lot of respect for him, lot of things I learned about the Delhi and as well as pediatrics. So this is my proud privilege to introduce this oration today in this annual day. I invite Chairperson Dr. A.K. Datta, Senior Pediatrician, to please come and take the seat. And
Smita, I am already there.
Okay, so I'm so sorry, there was a phone. And just show me the slide, CV slide. Dr. Datta is very well known, but I have an opportunity to read his accomplishment, please. So he is Emeritus Consultant in the Indraprastha Apollo Hospital, New Delhi. Former Director, Professor, Head of the Department of Pediatrics at Lady Hardinge Medical College, New Delhi. Fellow of Indian Academy of Pediatrics. Fellow of National Neonatology Forum of India. Past President of NNF India. Past President Delhi Branch of IAP. Indian Expert Group Member of Polio Eradication. Recipient of Outstanding Asian Pediatrician Award in 2012 by Asian Academy of Pediatrics, Lifetime Achievement Award from National Neonatology Forum of India in 2018, published over 175 papers in national and international journals and edited books of immunization. So, sir, I'm co-chairperson with you for this oration, and this is my really proud moment because we grew with your books, your teaching, though I was not directly your student, but definitely through the books, I was always there. So please introduce the, give introduction of Dr. P.N. Taneja. And I welcome Dr. Arvind Taneja if he is there. Dr. Arvind Taneja, if he is there, or he didn't join. So we welcome Dr. Arvind Taneja if he is there. I cannot see him. Dr. Datta, please go ahead.
मेरा slide निकाल दो पहले. Okay. It's really a privilege and pleasure for me to chair this particular important session. Regarding Dr. P.N. Taneja, you can say that he is godfather of pediatrics so far as the North India is concerned. He has been a teacher of teachers, researcher of researchers, and whatever he used to say, he was like, if Dr. P.N. Taneja stands, then वो जहाँ पे खड़े होते हैं उधर से लाइन शुरू होता था. It is something like that. जैसे अमिताभ बच्चन का स्टेचर है, डॉक्टर P.N. Taneja was like that. वो जहाँ खड़े होते थे, लाइन उधर से शुरू होता था. He was initially in Delhi. He joined in Maulana Azad Medical College as professor and head of the department. And then he shifted to All India Institute of Medical College. But prior to that, even he has worked as head of the Department of Pediatrics, professor and head of the Department of Pediatrics, and established the Department of Pediatrics at Assam Medical College, Dibrugarh. And during that time, Arvind Taneja was a child. He was studying at St. Edmund's School in Shillong. I have known Dr. Arvind Taneja because he was senior to me at Maulana Azad Medical College, and we used to regularly every Thursday, if nobody comes, every month Thursday meeting, Professor P.N. Taneja will be the first one to come and attend our IAP annual monthly meeting. And always he would give his expert opinion on each and every issues. He was the first person in Delhi who started private practice and showed that you can do a private practice as well as teaching together while he was teaching in Maulana Azad Medical College. And we know Arvind Taneja, very illustrious son of Dr. Dr. P.N. Taneja. Dr. P.N. Taneja has been really an iconic figure so far as the pediatrics is concerned in India. And we are very lucky that we had a person of that particular stature to guide us, to many of us, and he has many students who are doing exceedingly well in various parts of the world. I'll now hand over the mic to again Smita for continuation. And today we are having सिद्धार्थ राम जी को इंट्रोड्यूस तुम करोगे या मैं करना है?
सर आप कर दो, आप कर दीजिए सर.
So P.N. Taneja's, nobody else can be befitting to give this oration today as Siddharth Ramji. I have known Siddharth Ramji many, I think when he was a student. He has passed his MBBS as well as MBBS from Maulana Azad Medical College. Then he joined Safdarjung Hospital and did his MD in pediatrics. And then he has, after passing his MD in pediatrics, he has devoted himself for newborn care in the country. And his contribution in the care of the newborn in the country, I think very few people in India will have the experience as well as the contribution which he has given to the newborn for this particular country. The pioneer work of room air in resuscitation, he is the pioneer in this along with Dr. Sockstead. And they have really contributed and shown to the world that oxygen is injurious for resuscitation, only room air is good enough. He is not only an outstanding neonatologist, outstanding researcher, he is an extremely good human being and is very simple, very humble, very approachable. Anybody, any student or anybody can directly reach him. But on the contrary, I can tell you that he is a very strict disciplinarian, and for the sake of the newborn care, especially in his unit, everybody used to really get scared of him because he would come much earlier than any student. I have seen him and observed him that even when he was working in MCI, he used to come and take care of his patients and then he would go. When he was working as a medical superintendent, dean of Maulana Azad Medical College, he never, even for a single day, he always cared his newborn patients. He used to come much earlier, go and take rounds, and then he would do his administrative work. So such kind of dedication is very rare so far as the present day scenario is concerned. And he is one of the best person to be emulated. I'll request all the junior people, all neonatologists, that please emulate Professor Ramji. Even if you can emulate 10% of whatever virtues he has, whatever he has, you will greatly benefit from Siddharth. And I'm very happy to introduce Siddharth, and I will now hand over the mic to Siddharth Ramji for his oration, Dr. P.N. Taneja oration. Over to Siddharth.
Thank you, Professor Datta. Can I share my screen at this moment? So thank you, Professor Datta. At the outset, I was when I saw that slide of my presentation, I must state that I was quite embarrassed. That was not, I don't think it should have been there, because my contesting for the presidency of NNF and PM Taneja oration have nothing to do with each other. I should have been happier if that was not there. All the same, I must thank IAP Delhi for giving me this honor of being able to deliver the PM Taneja oration this afternoon. And thanks, Dr. Datta, for all these kind words. We have been looking at child health through the eyes of the way as pediatricians have looked at, in the hope to answer numerous questions that parents would ask us. But I thought I should take you through this journey of how the newborn would actually have viewed this, his life till he was born, and the life that is in front of them till adulthood. So what would have been the kind of questions a baby might have asked? I think every baby would have asked, am I normal? Nobody knows. Even though I look well, a good birth weight, physically normal, I may still have a lot of anomalies, and I don't know what is going to happen to me in the next 4 weeks. They're not sure whether they're going to survive the next 2 weeks, given the fact that neonatal mortality in this country is so enormously high. They're also unsure of what's going to be the childhood like. I mean, they have to traverse this first 4 weeks of newborn, then infancy. Environments in which they live are not appropriate. So I think the baby has a lot of concerns about whether they would ever be able to become like other kids. And of course, most important, end of the day, what kind of adult am I going to be? Many years, in my 20, 30, 40 years of my life, what kind of things are going to happen? And in order to be able to view this whole paradigm of our life through the lens of a newborn, I think it's very important for us to understand one very simple thing. And that simple thing is that the newborn here is only an intermediate station in the continuum of life. I think it's important for us to understand much has happened to the pregnant mother before even she became pregnant. There's a whole environment during pregnancy which the baby has seen and lands up somewhere here. But there is a huge amount of life through infancy, childhood, adulthood, all of which is actually a continuum. And therefore, the newborn can look back from this station and see what has happened to all the stations that have gone by. Not that you can do much about it now, because it's all over. But are there lessons for us to take? And for the newborn, when the newborn looks at the next several decades of their life and put them together, because that's important, I think, for us as pediatricians to understand if we have to actually change the quality of life for adults through our childhood. So what I propose to do during this presentation is to take you through two scenarios, two major phases. One is what has happened to the newborn before it came into existence, which means we look at the prenatal effects. I shall primarily concentrate on the pre-pregnancy status and fetal outcomes, which are essentially looking at intergenerational and transgenerational effects. And I think this is something very, very important for us to understand. And I shall concentrate on some new interesting insights into environment and fetal outcomes. I shall not be dwelling on pregnancy and fetal outcomes, social demographic factors. I think these are all things that we all know. I shall leave it aside because these are all known facts. And then in order for the newborn to look at what's going to happen to them in the years to come, I think birth weight and gestation are the best proxies we have, which kind of sums up all that has happened to them through the 9 months of pregnancy or lesser if it's a preterm, and what are the effects the mother's health had before she became pregnant on its outcome. And if you look at birth weight and gestation and look at things like nutrition, growth, and most important, adult health, I think these are what I would like to share with you. And at the end of the presentation, give us an insight of what we ought to be if we have to successfully handle our kids. So let me first come to this whole story of transgenerational or intergenerational effect. There's a lot of data on how intergenerational effects impact birth weight. This first study was actually from North Arcot district of Vellore, which looked at a parental cohort of about 470 fathers and about 420 mothers, and looked at about 1,500 offspring of these parents. And what they observed from this cohort was that if the mother herself was a low birth weight, she had a 2.8 times higher risk of having a low birth weight baby. And if the father was about low birth weight, then he had a 2 times higher risk that his kid would be born low birth weight. But what was gratifying was the fact that across generations, in spite of this increased risk of low birth weight, giving birth to low birth weight, in fact, incidence of low birth weight decreased across gestations. So there's still some hope for us that any interventions that we would do to minimize or mitigate the burden of low birth weight would actually improve with generations to come. But this was a small sample. We have now a much larger data set from the entire Taiwanese population. What they did was they looked at the third generation offspring. These were generation babies born between 1999 and sometime in 2006. And what they noticed was that the effect of the mother's low birth weightness on the baby's low birth weight is very similar to what they found at in Vellore, about 2.3 times risk. But they were not able to demonstrate the paternal effect that had been noted in the Indian Vellore study. So clearly, I think the issue of what the difference lies in the fact that this was a huge sample of entire population, and small samples often give erroneous results. But I think we have now even more compelling data. Not only is it the birth weight of the parents that is important, but probably what is also important is their own growth during their childhood seems to have an equally important effect on birth weight. And a consortium was constituted of 5 cohorts that were across the globe. There was the Brazilian cohort from Pelotas, from Guatemala, the Philippines, South Africa, and of course we had the most eminent New Delhi birth cohort, which was started in Delhi by Professor Shanti Ghosh, and Professor Bhargav took it further. And we, of course, you all know that it has now so much of data sets. But these cohorts were brought together, and what they did was they did an analysis of all the data together. And here is data for this effect. They looked at about 3,400 adults and about 5,500 of their offspring. And what they showed was that if the mother was stunted at the age of 2 years, then the likelihood was that you would get about 100 grams lower in birth weight. But more importantly, there was a 1.6 times higher risk that her baby would be a low birth weight. But the same in terms of paternal stunting was not documented. So clearly it seems that the mother's weight, the mother's own growth during her early childhood seem to have long-lasting effects which probably don't get undone even if we improve the nutrition later. And so this, and remember, these are all independent effects, all controlled. You can see it controlled for several factors. So these are independent factors, very strong epidemiological data to suggest that intergenerational effects are very long and persisting. And so we have to really think deep when we talk about prevention of low birth weight and doing something for these babies after they're born. Just as birth weight is important, of course, maternal height is also very important. There is in the same now data from 5 cohorts. We have data to show that the mother is short, less than 150 centimeters. The likelihood of her child being stunted at adulthood is very high. And if you pool all the models together, it still remains around 4 times. And of course, you can detect this pretty early. So if offspring of this mother remains stunted at 2 years, there is a pretty good chance that this child, even if he grows an adult, will remain shorter than his other peers. So that's where these effects lie. So it doesn't stop at 1 generation, it goes through 2. And the Taiwanese, as you realized, is a 3-generation effect. So the effect doesn't stop even at 1 generation. It seems to be manifest even into another subsequent generation. I want to talk briefly about the environmental effect. We are very familiar with air pollution. We talk about so abundantly. There's also a lot of effect on noise pollution, its effects on fetal growth. But there's one interesting thing that I came up for, which doesn't come around in medical literature. And that is the greenery around the residential areas where pregnant women stay. How many of us have actually thought that the wonderful gardens and green areas around us can actually have an impact on birth weights? So this was a very interesting, and I was preparing for this talk and I came across this. I was amazed at the enormous amount of literature in non-medical journals on the greenness, the blueness, which relates to the water bodies around where we live. And so this systematic review, which compiled 36 studies and over 12 million participant data, was to look at the estimated association and dose-response relationship between residential greenness and pregnancy outcomes. And they used a vegetation index, which I will not talk about, but those of you who are interested can see them in these 2 wonderful recent publications that came out earlier this year. But what they did show was that as the greenness increased from the lowest to the highest vegetation index, that means more greenery was around, the incidence of low birth weight decreased by about 14%. And there was also a decrease in intrauterine growth restricted babies by about 7%. And they found that this was, for birth weight, this actually was a dose-response relationship. And it also had the same effect on head circumference. The reason why I look at head circumference as an important factor is that there's so much of data to show that the size of the head, or the head circumference, is a very strong proxy to the contribution individuals should make to society at large when measured in economic terms. The human capital value of head circumference is immense, and I think there is now tons and tons of data which have shown that effect. And so it was impressive to see that something which we just take for granted, or maybe not even take for granted, has such an impact independently. And these are all, mind you, this data is controlled for all the other medical, socioeconomic, demographic, parity, and so on and so forth. And impressive to see the reduction that you would see by this. But what is more important is not just the quantum of greenness, They also had a scale for the quality of greenness to show that just having trees are not enough, but if you must have sufficient green areas where mothers could spend time, walk around, be alone, and imbibe the environment, which could have a positive effect on all her endorphins and so on. And so I think the fact is that when we talk about reductions of low birth weight, I think these are important effects that we need to consider, something that we as medical people and public health specialists have paid scant attention to in the last so many years. Let me move on now to say that what happens to the newborn later. The baby is born and he has a life ahead. And we need to look at what happens for his nutrition. So this is NFHS4 data, which I think most of you will be very familiar with, clearly shows that, remember, these are all mothers' perceptions of the size of the baby they've not really measured, but they are consistent to a reasonable extent. So obviously, clearly, when mothers said the babies are very small or they were more than average, you can see a clear gradient that the extent of or burden of stunting decreased as they moved from very small to more than average size at birth. And the same was true for wasting. So clearly, if the baby is small at birth, and it's the gradation, you also tend to see it reflecting itself in terms of stunting and wasting when the child goes through his early years. That is India, but there is very extensive data which has been compiled from 66 developing countries, a huge amount of data, which has also looked at how to identify individuals, including the siblings, twins, to account for the environment, the genetic factors they may be, and so on. And when controlled for all this very complex mathematical matrix that they evolved, what they also found was birth weight had a consistent effect on stunting and wasting. And this is consistent across. So therefore, it's a fact we need to remember that this gradient of small babies at birth have impacts on their stunting and wasting during childhood. And similar data has also been seen from other countries. This is from Indonesia, which is a close neighbor. Things are not very different across. You're all familiar with the Pune low birth weight cohort, because it's now, this cohort has crossed into, I think, 30s. But the purpose of putting this slide is simple. We know that we can be a low birth weight, we can be a preterm and small, you could be a term and therefore growth restricted, and you could be preterm and growth restricted. And clearly what you see here, and this is the data for the first 18 years of this birth cohort, that when you look at their height and you look at their weight, you can clearly see that growth restricted babies still continue to lag behind. And if you're preterm and growth restricted, you're doubly jeopardized. And so this effect continues. And so it's the fact that you're born early, which is not entirely under your control. Some of it is under the control of the medical practitioner, but a lot of it we still don't know much about. And the fact that you're growth restricted and the factors operating in growth restriction are complex, it leaves its stamp, indelible stamp, through our lives. But undernutrition is not the only problem. We are now challenged with the double burden of, dual burden of overnutrition, obesity. And this data is from 12 countries, it's cross-sectional, looks at about 5,000 children aged between 9 and 11 years. And what they clearly show is that in higher birth weights, very high birth weights, not only being small is a problem, being too big, too heavy is also a problem. And clearly, you have 1.5 to 2 times adjusted odds ratio of becoming obese at 9 or 11 years in the event, and this is also controlled for several factors. But what is important to note is that in the case of boys, this seems to have some kind of a U-shaped relationship. That means this obesity problem, and I think that is something which is becoming very aware now with Professor Barker's hypothesis, now documented through several studies, and I'll share a bit of it toward the end of this presentation. That in the case of boys, this problem goes from being low birth weight to the high birth weight. In the case of girls, it seems to have a relatively more linear relationship. And so gender certainly is a factor we have to keep in mind when we are looking at lifestyles, counseling, what we need to do, and outcomes. So we have a big challenge. It is not simply looking at a child, but we need to look at the child with a different lens. I would say different lenses of different powers to understand the very many facets that exist or have existed before this baby came into this world, and which is going to impact the way this child is going to grow during childhood and into adulthood. Just to say, there has been a great deal of data we already know about on neurodevelopment and cognition. I'll just run quickly to say that if you're a term small for date, it leaves long-term outcomes too. This data from a Japanese birth cohort of 46,000 plus babies showed that there was delayed development as early as 2.5 years. Behavioral problems were seen more often and quite easily by 5 years. And it also showed that by 8 years, there's a higher risk of attention deficit disorder and aggressive behavior in these children. And similar findings were also seen published earlier in the Dutch cohort. This is not curious to one part of the world, but this is true, seems to be true across. And there is some data from Indian cohorts too to suggest that similar patterns probably are being seen. And preterm SGAs, on the other hand, seem to do better. They don't seem to have too many problems. Of course, hyperactivity is something that they've noticed, but relatively their outcomes seem to do better as compared to term small for gestational age. I think these are factors that we need to keep across. When as a pediatrician, you come across a mother complaining that my child has, a behavior which is attention deficit, regressive, and so on, I think we need to go back and try to understand what's the legacy this baby has been carrying, the child has been carrying, and what we need to do about it. And let me finally move into this very important fact of what happens to adult health. As a newborn, we need to see, as pediatricians, I don't think we ever see very well as to what's going to happen to this child adult based on what I'm going to do or I'm not going to do with them. And I think this understanding is very critical for us. We now know that an ample data is available in adult metabolic syndrome, especially in low birth weight babies. And we know we have this information from the Pune low birth weight cohort, from Trivandrum, from CMC Vellore, all of which have shown that you can have altered glucose metabolism, higher blood pressure, high triglycerides, obesity. But of course, the most compelling evidence has come from these cohorts. We first published this from the New Delhi birth cohort, which clearly showed what all this can do. So the size at birth and weight in childhood and the risk of adult diabetes. This is from the same 5 cohorts which were brought together. This is data from about 6,500 adults. I don't want you to look into this complex table. I think what you need to look at is here. Lower birth weights and accelerated weight gain after 48 months are the most obvious risk factors for adult glucose intolerance. So of course, it's a continuum. Those who are, as your birth weights keep going down, irrespective of what happens to you in terms of weight gain later, there is a risk. But of course, the accelerated weight gain after 48 months seems to be the critical factor. This is something that we had published in the new NEJM when we had shown this data from the New Delhi birth cohort. And clearly this is something we need to understand, because as pediatricians, we need to understand how feeding, lifestyle of the child, etc., operate, and what happens after 2 years could actually be disastrous. Mothers are concerned that my baby is not growing, and many of us are more than happy to tell mothers to feed the kids more often. How many of us actually tell mothers, don't feed him? It's okay. As long as he's maintaining his centiles, that's the way he's supposed to be. You don't need to chase a line to which he or she doesn't belong. And I think we must understand that doing so could actually undo a great deal and make life more miserable for this kid when he becomes an adult. It's also the linear growth children experience, which has impact on adult health and human capital. This data is from over 8,000 of the adults who participate in the same combined 5 prospective birth cohorts I alluded to earlier. The higher birth weight was associated with, of course, adult body mass index greater than 25 grams per meter. We'd like to be better. So if you have higher birth weights, you're also less likelihood of being short-statured adults. And you also have reduced likelihood of not completing secondary school. That means as your weights went down, you're more likely not to be completing school, likely to be shorter, and of course your body mass index will decrease. And I think this is a good proxy of what's going to happen to their human capital in terms of production, in terms of economic contribution to society, which I alluded to earlier. And there's already a very large amount of data in a paper in which we had assisted using data from the New Delhi birth cohort to actually calculate what all this would mean in terms of the individual and the country. And of course, as I said earlier, the faster linear growth, which I alluded to for diabetes, had some benefits. So that means if you had linear growth, you had your shorter adult stature, right? Reduced risk. And of course, that means you grew better, it is fine. But then if your acceleration was beyond many centiles, that placed a risk for you for diabetes. So linear growth is fine up to a point, but beyond a point, it could have adverse effects. There's also some data to show that if your birth weight, this is from the Brazilian Pelotas cohort, we looked at these children who now, of course, adults of 30 years, and showed that as your birth weight decreased, or rather, let's say the birth weight increased, for every Z-score increase in birth weight, you came up with better grip strength. And these were possibly associated also with what happened to the weight and length for height scores at 2 and 4 years. That means it's a continuous trajectory. And of course, SGAs and low birth weights did worse. So it also had something to do with your muscle mass and strength that you had to do, which means if I was to translate in terms of productivity, it will come down. Because obviously, if you don't have enough strength, you're also going to end up with being less productive individuals, especially for those who are not in white-collar jobs. So let's look at this diagram. You know, we have talked about what happens is my genetic background, and you look at your development, postnatal growth, altered body composition. I had this very interesting, I heard that last presentation on which a lot of questions were being asked about body composition, so on, and adult obesity. But we must remember that there is the environmental effect which can create huge epigenetic effects on the germ cells. And so this becomes one vicious cycle from postnatal to prenatal. And it is this that we need to avoid. This is the area where we can intervene. We can't do much here. We can do something here, but eventually what translates into the next generation is this effect that will happen on the epigenetic effect. So there is, eventually we must remember that while there's a genetic background, there is great potential to do some modifications which can impact through epigenetics. And I think that's the area in which we are all now working, to understand that in spite of being born under adverse circumstances, in spite of transiting through relatively better circumstances from a poor environment to a relatively well-off environment which takes off in the wrong way, we have the potential to do some modification. Our understandings on this area have been very little. So I just wish to share that India has a huge cohort. This cohort is almost completed its enrollment at this moment. It's in fact completed, where it's looked at why preterms are born, especially for those who are idiopathic. And it's got huge amount of data on epidemiology, omics, genetics, microbiology, pathology, radiology, sequential samples. And we are hoping that this cohort, the data from this cohort, will be able to answer some of the questions that we have been looking for. And finally, the message that I wish to give all my friends, colleagues, pediatricians is that we need to look at child health with a larger panoramic lens. We just can't look at the child and look at only what happens after birth. We have to look at what happened before birth, and we have to look at what will happen to this child through his later years. We need to be aware of the birth weight and gestation too when you're assessing growth and nutrition during childhood and adolescence. And we must constantly be on the lookout. It's like issuing a search warrant. On the lookout for early onset cardiovascular and metabolic derangements. And of course, I think finally, we need to partner with several people, obstetricians, adult physicians, public health experts, environmental and educational organizations, civil society, economists, social scientists, name it all. You know, we have to become like an octopus. Many hands we need if we really want to improve child health and adulthood. And I must say this because it's only when I worked with the newborn over the years that I realized how important it is if, as a pediatrician, as a neonatologist, I wanted to see this child well. And I realized that we actually are ill-equipped because we don't understand the other elements. And this is what I've learned in my life journey as a neonatologist, that you need to be a public health specialist, you need to understand environment, you need to understand education and its impact, to understand biology, you need to understand social science, anthropology, and so on and so forth, if you really want to make that huge change for the children whom we treat. Thank you so much for giving me this opportunity and the patient listening, and it's been an honor once again for me to deliver this PN Taneja oration to a great pediatrician. Thank you, sir. Thank you.
Thank you very much, Siddharth, for your par excellent oration, especially highlighting what needs to be done so far as the newborns are concerned. Before I hand over the mic to the organizers, I would like to request Arvind Taneja to come over and say a few words. Arvind, are you here?
Yeah, I'm here.
Yes, Arvind.
Yeah, you said something?
No, please speak on.
Okay. Well, I am really happy with what Siddharth Premji has presented today. I think it's a very fitting tribute to my father, who tried to nurture pediatrics. He was one of the first few pediatricians in North India, and a lot of us, including myself, trained under him, both in his pediatric office practice and also in the hospital. I'm glad to see that the legacy is continuing and that there are many brilliant people who have taken up the field of pediatrics to further this science in India. The only caveat that I'm upset about is that pediatricians, even today, tend to be kind of sidelined in the scheme of medical practice. They do not get as much importance as what the other specialties or the surgical specialties get. So with these words, I would say thank you, Siddharth. Thank you, Ashok. Thank you, Smita, and thank you, the organizers of this conference, for giving me the opportunity to say a few words. Thank you.
Thank you very much, sir. It's always an honor to hear from you.
Thank
And
you.
hello, somebody else wants to say something?
Actually, I want Dr. R.N. Srivastav, who has Professor R.N. Srivastav to speak few words, because he has worked as a house surgeon physician of Dr. P.N. Taneja, Professor P.N. Taneja.
Yes, those were very early days, 1959, long time back. But I remember his rounds and his teaching very clearly, and his support to the staff here, very supportive all the time. And once he's around there, we felt confident ourselves actually. And I remember Arvind Taneja, he was only a child then. But the early days, but very pleasant days. And Urban Hospital, he and Dr. Shanti Ghosh created the best department of pediatrics, one of the whole, in the whole country actually, the very well known. So I really admired him like anything. And those were the foundations of pediatrics, as Arvind has mentioned. You also mentioned that. Thank you.
Thank you very much,
sir.
I think now I thank.
Sir, I want to make a comment just
Sure.
Because now we are going towards the pediatric and adolescent for the terminology for the pediatrics. So I would really like that it should be extended little towards the fetal life also, because obviously Dr. Ramji said it all, that now the diseases which we are looking at even in adolescent, somewhere they are having their roots in the fetal life. So some extension is needed before birth also. Besides that, we are going towards the adolescent and the higher age group like 23 years. So thank you very much, sir. This is what I wanted to say. And Dr. Ramji, it was excellent presentation, and really I loved it, because this is epigenetics is coming big way, and there are so many diseases are because of epigenetics, and that's example you have shown. Thank you very much, sir. And I would like to call now for
I'd
the
just
next.
like to make an announcement here, Dr. Smita. Dr. Srivastav reminded us of Dr. Shanti Ghosh along with Dr. P.N. Taneja, and I just want to apprise the IAP Delhi and with a good news that this year we have started oration with the name of Dr. Shanti Ghosh oration in the North Zone Pedicon for the first time, which I'm sure Dr. Sangeeta is going to take the baton next year. She probably would like to continue. And we continue to remember our stalwarts who have devoted their lifetime nurturing pediatrics and nurturing pediatricians. And along with Dr. Taneja, Dr. Shanti Ghosh also probably next year we'll have another oration by her name also. So that good news I wanted to bring. And Dr. Srivastav had been urging that we must try to remember all our senior stalwarts in some way or the other. And this was one way we could do it. Thank you very much.
Very well done. Very well done.
Very well done, sir. So I would go for the next oration now, because in the interest of time, this is a Dr. S.C. Khanpur oration. And I would like to invite Dr. S.K. Bhargava, senior pediatrician and teacher to so many of us, and to chair this session, and Dr. R.K. Nath, the president of IAP Delhi. Dr. R.K. Nath will introduce Dr. Bhargava. So kindly, Dr. Nath, take it over.
Okay, thank you so much, Dr. Smita. I'm really grateful to all the dignitaries who are present on Sunday here. And I welcome all the attendees for this oration. It's a prestigious SC Khanpur oration we are going in for. And SC Khanpur, I'm lucky that I'm student of Dr. SC Khanpur and Dr. Bhargava both. I had the chance to have the blessings of both of them. And to chair this session, I'm inviting Dr. S.K. Bhargava. He is a very senior pediatrician and a top neonatologist, and former HOD of Department of Pediatrics at Safdarjung Hospital and New Delhi, Editor-in-Chief of Indian Pediatrics. At present, he is affiliated to Sundarlal Jain Hospital, and he was IAP Delhi president in 1973. Now I'll request Dr. Bhargav sir to say a few words about his association with Dr. Khanpur, and I'll request him to say something. Dr. Bhargav, please.
Thank you, Dr. Nab. Greetings to everybody. It is a pleasure to be invited by Dr. Nab, the president of IAP, to this oration, and I accepted this for two reasons. The first and the foremost is that Subhash Khanpur was a very dear friend of mine. Not only that he was a close friend of mine, his whole family was my family friend. His wife worked with me at Safdarjung. His son was classmate of my daughter, and I was instrumental in asking him in one of those days when I was passing through the Lady Harding. I met Subhash and asked him, Subhash, why don't you come to Safdarjung? One of these days, I'll hand over the department to you. I don't intend to work my full period of the service at Safdarjung Hospital. He laughed and said, you joke with me. He came with me and both of us worked. It was a pleasure to have him in the department because it is very rare to find a colleague like him. Gentle, very humble, always supportive, always ready to do what you like. And ours was a very young department. I was a very young head in those days, and I needed all those support from my young faculty to go ahead in the country because I was trying to fill a very big shoe left by Dr. Shanti Ghosh. So it was in those difficult times and challenging time that Subhash came and worked with me. It was equally sad and shocking for me that he left so earlier, that he fulfilled not those dreams which both of us planned during our stay. So I miss him. I miss him many times because when I remember my days, it is always that Subhash is one of those who was so helpful to me in those my own days. Having said that, this is about the Dr. Subhash Khanpur, and I could talk many anecdotes where we organized a lot of things which were not happening in those times. But I would like the audience to perhaps share a more a lecture which comes from a more dynamic person. Perhaps I should like to introduce Dr. Piyush Gupta because as your contemporary, I belong to the next generation, not having known him as much perhaps as you know him. I know what you may call some of those things which, as a senior and an observer, you make observations and impressions about people, which perhaps I could say now or at the end of the what you thought if you wish to introduce. Piyush, Amesh, would you like to say?
Sir,
introduce?
I'll introduce. I'll introduce. Yeah. Now we are going in for Dr. Piyush, sir. Well, topic for this oration is my journey.
Let me say a few words. When,
Yes, I am yours. Okay.
Piyush, I got to know him really when he became the editor of.
सर आप बहुत ज्यादा तारीफ वो बोलना नहीं तो मैं बोल नहीं पाऊंगा उसके बाद. I get so emotional.
नहीं करने वाला
जी.
आपके बारे में वो कहूंगा जो लोग नहीं कहेंगे.
सर.
आपको याद है? कविता सुनाऊं कुछ आपके बारे में?
बिल्कुल सर. Please.
No, the less said the better. Santosh, Chief.
I only want to say a few words.
Chief, can you hear me?
I must admit, I had not known him earlier. I got to really know him when he became the editor of Indian Pediatrics. I have a special love for Indian Pediatrics because I was an editor of Indian Pediatrics, and he took over in a very challenging time and brought it up. And to all editors, I have followed very closely. So when Piyush took over, I followed his journey as editor very closely. And I was very impressed to the extent that one day I called him and invited him to have a lunch with me. And he very graciously accepted it. At that time, we exchanged a lot of what we talked about each other. And I got to know him a little. I got to know his other personality in these lockdown times. I come from Ujjain, the Nagari of Kalidas and Vikramaditya. So therefore, I'm very fond of kavitas and other things. So when Piyush started reciting his poems, I became a fan of him. Not of being an editor and a famous author of 30 books, 200 papers, and lots of awards and recognitions, but the way he recites the poem, the way he says it, so impressive, so touching. And that's how, Piyush, I would like to introduce you to the aspect that a lot of pediatricians should be. As I say, in my life, I did not see much beyond pediatrics. But today I teach there is a world beyond pediatrics. And Piyush, maybe you can communicate that message to people that all of us are pediatricians. But for us, there should be a world beyond pediatrics too. And for that, I am very impressed, delighted by your interest in the Indian Hindi poetry. Thank you and wish you the very best. I look forward to your oration.
Thank you, sir.
Thank you so much, sir. I'll introduce the topic. It is my journey in nutrition. It is delivered by my very dear friend, Dr. Piyush Gupta. He is Director, Professor and Head Department of Pediatrics in Charge, Medical Education Unit, University College of Medical Sciences, Delhi. He is President-elect CIAP 2020. He is going to be the President next year. Editor-in-Chief of Indian Pediatrics 2008 to 2013. And he has authored 200 papers and 30 books, as you have mentioned. International Editorial Board member, the Journal of Pediatrics USA 2016 to 2018. Is member of World Association of Medical Editors, awarded by Royal College of Pediatrics UK, awarded the National Teacher of Excellence Award in Medical Education by Vice President of India, technical expert advisor to Government of India, WHO, DBT, UNICEF, ICMR, MCI, INCLAN, and several universities in Southeast Asia and India, ex-Joint Secretary, South Asia Pediatric Association. And over to you, Dr. Piyush Gupta ji. Please carry on with your deliberations.
Thank you. Thank you, Dr. Naab and Dr. Smita. First of all, I am thankful to Delhi IAP for giving me this honor. I am really humbled, and that too with Professor Bhargav in chair. As I said before कि सर के सामने कुछ बोलना बड़ा मुश्किल होता है, तो I am afraid how am I going to speak for next 30-40 minutes. And such senior luminaries, I respect them a lot. All the past editors, especially for being in that league, Professor R.N. Srivastav, Dr. Siddharth Ramji, and Dr. Bhargav, and then Dr. Datta sir is also here. So, sir, I am really thankful for accepting to chair this session. And the journey started. I'll take you to my postgraduate days. So this was from Delhi. I went to Banaras. I belong to Delhi. 1978, I went to Kashi Hindu Vishwavidyalaya, and probably that was the time. And after that, I did my post graduation from there, and 9 years I stayed there. And probably I owe my interest in nutrition to this one man who everybody knows, who doesn't need any introduction. So I would like to firstly dedicate my journey and my all the achievements in nutrition to my teacher, my professor, Dr. K.N. Agarwal sir. He is not here in India, he is in US, but he has promised that somehow he will definitely see this oration whenever he gets time. So sir had there used to be a nutrition unit with more than 150 people who were working under Professor K.N. Agarwal, and we had approximately 30 villages around the Banaras Hindu University that was included in the Kashi Vidyapit block. And all his work, we all used to work as students, and we just watched how phenomenal he was. He could work from morning till night. And so that was the inspiration, sir. Thank you very much for leading the way and guiding me into this journey of nutrition. I joined University College of Medical Sciences 1987 in Delhi, and by that time, that was the first IAP meeting was held in UCMS GTB campus in 1988. And I was a senior resident at that time, and I presented this first paper on case report on scurvy, which was again a topic related to nutrition. And incidentally, this was also my first publication. And I still remember vividly that in that first, we didn't have a proper lecture theater at that time at GTB hospital. And Dr. Shanti Ghosh had come, and she really complimented me at that time. And she said, you will go a great way the way you have presented and discussed this particular case. So this is how the journey started, with Madam's blessing at University College of Medical Sciences. Subsequently, we worked with Professor K.N. Agarwal, also joined UCMS, and we were working in the field of iron and weekly iron folic acid supplementation, for which we started some project under UNICEF. But in between, I had to go to Dharan, had this opportunity where I shifted on deputation to Nepal, BP Koirala Institute of Medical Sciences. But I continued the light that he had shown, the same areas that we were working here in Nepal also. Again, we found that the prevalence of anemia appeared very high in Nepal, in that fertile area where majority of residents were non-vegetarian. Then they were consuming lot of iron-rich, so-called iron-rich food, and yet we conducted a study there, and we found that amongst the school girls, the prevalence of anemia, even in that setting, was to the tune of 70%. And then we tried to simulate the same study that we were doing in a UNICEF-supported trial in India, weekly versus daily supplementation for anemia. So this was a new concept in those days. And in this trial, we had 3 groups. The group A received iron and folic acid once a day. Group B received once a week, and group C did not receive any drugs. And we found that the prevalence of anemia declined from 70% in group A and B to 20% and 13% respectively. So a marked decline in both the groups. And it was a similar decline, while there was no change in the prevalence in the group C. So we concluded that the supervised iron and folic acid therapy once a week is an effective alternative to daily administration. So this was one of the first studies probably hinting in this part of the world on efficacy or of the weekly supplementation in treatment of anemia. When I came back to UCMS, and the focus shifted somehow to in utero malnutrition, because Dr. KN was also interested in that time in that. The folic acid was a new thing again in that day, and we just conducted this study published in NMGI to find out the knowledge and practices of folic supplementation. Now almost everybody knows about folic acid supplementation for prevention of neural tube defects. But we found that in those days, only 20% were aware of folic acid during pregnancy, but none was aware of its intake in the periconceptional period, which was very essential. Oxidative stress. The role of oxidative stress was being looked upon in intrauterine malnutrition. Though the oxidative stress was implicated in neonatal diseases and acquired malnutrition, but the role in intrauterine malnutrition was not clear. So we conducted this study to determine the status of oxidative stress in small for gestational age babies which were born to undernourished mothers, and subsequently got published in BMC Pediatrics. We had two groups. We compared term small for gestational age babies who were born to malnourished mother versus normal control. And as you can see, there was a marked difference between the study and control group, which signified that intrauterine malnutrition is associated with significant oxidative stress in SGN units born at term to malnourished mother. Now, till date, this remains my best cited papers with more than 200 citations, and because this was a basic research that was first conducted at that time. So after getting this conclusion that there is an association between oxidative stress and intrauterine malnutrition in small for gestational age babies, obviously, the next research question was that can we somehow dismiss this oxidative stress? We can minimize it and improve the birth size. And how? If we have to ameliorate this oxidative stress, maybe we need to give some antioxidants. And can this help? By that time, the Pune low birth weight study had come, and it was shown that the green vegetable supplementation and the fruit and vegetable supplementation were probably useful in increasing the birth size. So we tried this supplement, a multi-micronutrient supplement in addition to iron folic acid, that would serve as an antioxidant, and we wanted to see its effect on the birth weight. So this is the study, we randomized control trial again. We published in JAMA Pediatrics, those days known as Archives Pediatrics Adolescent Medicine, multi-micronutrient supplementation for undernourished pregnant women. The hypothesis was that it could increase the birth size if it could minimize the oxidative stress, and it would also reduce the incidence of low birth weight and maybe have some effect on the early neonatal morbidity. This was the constituent of the multi-micronutrient tablet that we were giving, of more than 15 micronutrients were there. We started off with almost 22,000 antenatal women, and out of that, finally, we enrolled 200, which were divided almost equally into the micronutrient and placebo group. And the results showed that there was a significant difference in the length, mid-arm circumference, in all the anthropometric parameter as in the micronutrient group as compared to the placebo group. Also, the incidence of low birth weight, incidence of small for gestational age also came down after giving micronutrient supplementation for intrauterine malnutrition, that is to the malnourished women. Now, this was the first of its study, again of its kind, which concluded that targeted multi-micronutrient supplementation during pregnancy increases the lean body size, and though the effect was small, but it was significantly decreasing the incidence of low birth weight babies. So this was a study which triggered off many such similar studies, and till date, many systematic reviews have also been done. And recently also we were instrumental in getting a systematic review on, and that included our study as the first of its kind in that particular topic. Coming to the postnatal malnutrition, we shifted to the postnatal malnutrition, and this was an acronym that we devised and which was published in the Lancet, and a very famous acronym it has become. It is just says the child has to be shielded. The child with severe malnutrition, at that time it was known as protein energy malnutrition when it was published. The child has to be shielded. That means from the sugar deficiency, hypoglycemia, all those, all the important parameters which need to be taken care of while managing a child with severe malnutrition. And the feeding, it has to be the best feeding, which is again acronymized, and this was a good teaching tool. In that particular era also, we worked on the first ever national workshop on development of guidelines for home-based care and treatment of children suffering from severe acute malnutrition. While doing these guidelines, so much emphasis was paid that these children could be managed at home. So again, we conducted this study on home-based rehabilitation of severely malnourished children in resource-poor setting. So the study had rehabilitation at home, that is 16 weeks following an initial assessment and stabilization at hospital. The sample size was 34, and we found that during home-based rehabilitation, very few children had weight gain, which was usually desired. And the recovery was also not complete. So what we concluded was that home-based management, simply using home-prepared food and hospital-based follow-up, is associated with suboptimal and slower recovery. So that means that stress the need for nutritional, either you manage at the hospital, that in a recovery center, such as which paved the way for the NRC, Nutritional Rehabilitation Centers, later in the program, government program, and or one needs to have support group in the community, which would be, or a supplement which would be taking care of the management of children at home. By the time severe acute malnutrition term was coined, and mid-upper arm circumference was coming into the vogue. And mid-arm circumference, being a simpler tool, was being recognized, and we compared that for finding its value in prediction of mortality in hospitalized children. So we studied more than 1,500 children, and they were consecutively recruited, and mid-upper arm circumference was compared with the traditional parameter, that is the weight for height z-score, for predicting the outcome. And we concluded that mid-upper arm circumference less than 11.5 centimeter, which is taken as a cutoff for defining severe acute malnutrition also, is a better predictor of mortality in hospitalized under 5 children, and it should be measured in all emergency settings to identify the children at higher risk of death. Another area where we worked and which was of concern was about diarrhea and the management of diarrhea in children with severe acute malnutrition. It was known that rotavirus is the most common cause of diarrhea in infancy and under 2 years of age, but the same yardstick was being applied to malnourished children. So when we did this study, we found that the rotavirus was less frequent and E. coli was more frequent in children with severe. In between, we had worked on several areas among vitamin D, which we will come to later. So after that, we found that there was no recommendation and there is no place for routine calcium supplementation or vitamin D supplementation in severe acute malnutrition. It was always thought that rickets is a disease of growing bone, and because in malnutrition, severe malnutrition, bone is not growing, so the rickets doesn't occur or the bony changes do not occur. So we conducted this study to see the prevalence of vitamin D deficiency and hypocalcemia in 150 children. And to our surprise, we noticed that hypocalcemia we noted in 26% children, and vitamin D deficiency was there in 65%, and 42% children had rickets. So we concluded that rickets and hypocalcemia are common in children with SAM, and routine supplementation of vitamin D may be considered for severely malnourished children. Also, the calcium may be empirically prescribed to severely malnourished children with clinical rickets. And this is being strongly considered when the new recommendations on severe acute malnutrition management are being framed. Coming to the story on vitamin D, why vitamin D is so important? We all know there was a lots of hue and cry about the role of vitamin D. We started off with the simple trying to lower the dose that was being used for treatment of nutritional rickets. So we conducted this study with 3 lakhs versus 6 lakhs of oral vitamin D3 for treatment of nutritional rickets. In those days, we remembered, if you remember, people of our era, that we used to have one preparation for one sachet used to contain 6 lakh units. And it was a standard that you take one sachet for treatment of rickets. And now one sachet contains 60,000 units. So you have to use 10 sachets. So this study concluded that 3 lakh unit was as good as giving 6 lakh unit. So we could treat nutritional rickets with the lower doses as well. And subsequently, the studies have also shown a 1.5 lakh unit treatment of vitamin D deficiency. The thing started, vitamin D spread beyond rickets. And the role of vitamin D was being seen everywhere, in influenza, in tuberculosis, in asthma, multiple sclerosis, chronic kidney disease, and whatnot. But as an antimicrobial, it was clearly shown that vitamin D acts upon the immune mechanism, and it can modulate the production of cytokines and antibodies. And this occurs through the enhanced expression of cathelicidin antimicrobial peptide, which is important in the host defenses. So special effect was seen on the respiratory tract, and there was a lot of, again, emphasis was being placed on routine supplementation of vitamin D in children with pneumonia. And so we wanted to study, because there was no studies in the Indian context, and even in the developing country context, they were not there. So we conducted this study first on vitamin D supplementation for severe pneumonia, again a randomized controlled trial. Now in this study, this was again a randomized controlled trial. So we supplemented vitamin D to children with pneumonia for 5 days. But it was a small dose, 1,000 to 2,000 international unit per day, and it was given for 5 days only. And the effect was seen. The effect was seen on the resolution of severe pneumonia. As you can see, the resolution of severe pneumonia and the duration of hospitalization was similar in both the groups, whether the children receive vitamin D or placebo. So we concluded that probably this short-term supplementation had no effect on resolution of pneumonia. It was when we published this study, so we had several queries came out, and those who were advocates of vitamin D supplementation in pneumonia, and they said, you have not measured vitamin D levels in your study, so you have recruited patients that may include both vitamin D deplete and vitamin D replete. Your duration of supplementation was too short, only 5 days, that too with minimal dose. The dose was inadequate, because the other study which showed some effect, they have used 1 lakh units, a bolus dose, to show some effect. And then they said that there is no impact has been seen on the long-term utility of this intervention, that is whether it is useful in decreasing the recurrence of pneumonia. Following that, we conducted a larger study, which was backed and funded by the Indian Council of Medical Research. And this study was conducted over 3 years period, and which overcame all the limitations that was there in the earlier study. And here we supplemented 1 lakh units for severe pneumonia, and we presumed, or we hypothesized, that it will lead to at least 1 day reduction in the time to resolution of severe pneumonia. And also we studied that the proportion of children suffering from a repeat episode in the next 6 months, that is the recurrence rate of pneumonia, would also go down with this supplementation. Ultimately, out of 55,000 approached, we enrolled 300 plus number of participants, children under 5 years of age with severe pneumonia. And you can see the result, the time of resolution of severe pneumonia, the two snakes here, duration of hospitalization. Again, the two snakes, that is the brown and the blue, are equal. Time to complete recovery, similar. Fever clearance time, similar. So there was, again, the recurrence of pneumonia also in the next 6 months was same in the two groups, around 25% versus 23% in the other group. So this was again proven that vitamin D supplementation to children with pneumonia is neither clinically significant nor consistent, and a routine supplementation which was so strongly being promoted by the vitamin D lobby, we were able to stop it from being implemented in this particular age group. By that time, in 2015, global consensus recommendation on prevention and management of nutritional rickets had come in, which advocated that 400 units of vitamin D should be given from birth to 12 months of age, independent of the mode of feeding. However, there was a growing advocacy for routine vitamin D supplementation. But still, there were no recommendation from Government of India, ICMR, or Indian Academy of Pediatrics. There was also lack of literature on sensible sunlight exposure for prevention of vitamin D deficiency. It was very obvious that in a country where sunlight was available in abundance, so why not a therapy of sunlight, or why should not sunlight exposure result in decrease or reduction in vitamin D deficiency prevalence? This was the only study we could find which was conducted in 1985, which showed the relation between sunshine exposure and vitamin D concentration in exclusively breastfed infants. And the study stated that if 30 minutes per week of sunshine, wearing only a diaper, can this is enough to maintain serum vitamin D concentration. So we had several research questions, because after 1985, this study, nothing was done, and especially in our context, no studies were available. So the research question was, does sunlight exposure actually predict serum vitamin D levels? If yes, how much sunlight exposure and duration is optimal for adequate serum vitamin D levels in infants in India? And number three, are the infants getting the desired exposure to sunlight? As the Specker study had said, that you need to have at least 30 minutes of sunlight per week in infants. But again, this study was conducted on Caucasian infants, and maybe because of our skin color and skin thickness, genetic changes, differences between the Indian and Caucasian population, we could not extrapolate the same results in our setting. So we conducted this study on sunlight exposure and vitamin D status in breastfed infants, and we followed up about 100 children from birth to 6 months of age, and we just noticed how much sunshine. This was the observational studies, and we followed up and we noted their exposure to sunlight, how much it is big they are exposing. This was not an interventional, so we found that in this population, in 66%, 70% vitamin D deficiency was noticed, and the median weekly sunlight exposure was hardly 5 minutes per week. Remember, this is the 10 a.m. to 3 p.m. when the UVB rays are maximum. So only children were being exposed for only 5 minutes in a country like India, where sunlight is in abundance, and that too on only 6.8% of body surface area. What was recommended was 30 minutes on 40% of body surface area. We did some mathematical calculation to arrive at our estimates, how much do our children need, and we found that afternoon sun exposure, again, the finding we found was exactly same as was there in the Specker study, that you require 30 minutes per week of sun exposure on 40% body area, and then the children are able to achieve sufficient vitamin D levels at 6 months of age. But this was just on mathematical calculation and estimates based. This was another study. Now there was the difference in summers and winters between the vitamin D levels. We found that there is hardly any difference whether you do a study in the winter or summer, because the level are almost similar in the winter and summer in this cohort we did in Delhi. The reason could be twofold. Number one, the summers are getting harsher, so children are staying more indoors, and the winters are getting less wintry. That means they're less cold, so children are staying more outdoors. So that has narrowed the gap. The seasonal difference is almost disappearing in our setting. So the studies could be calculated in every in all the whenever the study was conducted. So the results were relevant. By this time, the IAP also released its guideline. The IAP released its guideline and it advocated routine vitamin D supplementation to every child till 12 years of age, going even beyond 1 year of age. Our question was that there are so many guidelines were there. The international guideline was there, the IAP guideline was also there, though still by that time and even by this time, there are no guidelines from ICMR or government for routine supplementation of vitamin D. So we conducted this survey in pediatrician of Delhi to find out how many of pediatricians were actually prescribing vitamin D. This was done in all medical colleges, all government hospitals, private clinics, and the result was that 90% of the pediatricians whom we interviewed were prescribing vitamin D. So if 90% was prescribing, why the prevalence is still not decreasing? The obvious question is that yes, pediatricians are prescribing, 90% are prescribing, but is it translating into actual consumption? Are the parents giving it to their children? What is the compliance of this prescription? And we did this study and we found that compliance to prescription of routine vitamin D was very poor. Only less than 10% out of this 90% being prescribed, only less than 10% were receiving appropriate routine vitamin D supplementation in terms of dose, frequency, and duration. So hardly nobody, almost 10 out of 90 out of 100 children who are prescribed vitamin D at birth or at any time do not get it for complete 1 year of age. There are more unanswered questions in this journey of vitamin D which still remain, and we have to take care what level of vitamin D is adequate, sunshine, skin pigmentation, and what is the difference between what are the differences between the supplementation and sunlight exposure? Are they equal, or can we substitute the routine vitamin D supplementation by sunlight exposure during infancy? So this is a study we've just published. We're just going for publication. Again, a randomized control trial between the two groups. So this was a straight head-on comparison. In one group, we exposed the children to sunlight, and then the other group, we gave oral vitamin D supplementation for 6 months, up to 6 months of age. And to our surprise, the result was that oral vitamin D supplementation is more efficacious than daily sunlight exposure. This we did not expect. But when we went into the data, we found that this effect of oral vitamin D supplementation is occurring because of a higher compliance with the vitamin D supplementation, while the compliance with sunlight is poor. If the compliance to sunlight therapy is good, both are as equal, both are as efficacious as, so sunlight is equal to vitamin D, but in the routine setting where the compliance to sunlight is poor, vitamin D supplementation appears a better choice. By this time, now we have the comprehensive National Nutrition Survey, and it showed that the prevalence of vitamin D is decreasing. In 1 to 4 year, it was hardly 14%, and then 18% between 5 to 9 year. So there was a need to relook at the recommendation of IAP guidelines on prevention of rickets. So when I assumed chair of President-elect, we again started a task force, made a task force, and started this revision of the IAP guidelines on vitamin D supplementation, which will answer several questions. Is there a need for routine vitamin D supplementation in childhood? What should be the therapeutic doses? Do we need to supplement the breastfeed babies or lactating mothers, or both? Because now the data is coming on the antenatal supplementation of vitamin D as well, and role of vitamin D supplementation in the non-skeletal condition to also to be explored. Coming to the other facet of malnutrition, from undernutrition to overnutrition. This was another area of which interested us. So this study was done by one of the MBBS students, and he watched television channels which were being watched by children for 1 month, and he found that the more than 90% of advertisements which were related to food on children's channel were simply not related to healthy foods. The content was always to the unhealthy foods and beverages, those high in energy and low in micronutrient content. So this was the result. The second study that we did in this content was there were no recommendation or no data on caffeine intake among adolescents, among children. We know that caffeine is not a substance which is required by the body, but to our surprise, we found that the caffeine intake in Delhi schools in children was 120 milligram per day, which was more than the recommended of 80 to 100 milligram per day in adolescents. And this was much more as we compare to consumption in USA, Australia, or Canada. So obviously our children are consuming much more caffeine, and even the newspaper had the audacity to declare that Indian children are addicted to caffeine thanks to starting their day with tea and coffee. Subsequent to this, the nutrition chapter of Indian Academy of Pediatrics came out with these guidelines, which are now popularly known as the JUNKS guideline. The JUNKS guideline is all about the junk food. We coined a term. This acronym is now very well known and becoming very popular in the world of food. JUNK stands for junk, which is high in fat, salt, and sugar. U is for ultra processed. N is for nutritionally inappropriate. C stands for caffeinated, carbonated, and colored foods, and S for sugar sweetened beverages. So Indian Academy of Pediatrics has come out with these recommendations on the junk food, and we are in the next year, we are going to popularize this recommendation all across the country in a mission mode during a school-based program, which will be taken up under the IAP Action Plan 2021. The agenda ahead is that to bring the nutrition to forefront, both prenatal, postnatal nutrition equally important. The focus will remain on SAM, anemia, and obesity. We will be shortly releasing from the IAP side also parental guidelines on nutrition. There is a plan, and I am dreaming of that, to have an Indian journal to start on nutrition and adequate coverage or to be given in the UG/PG curriculum related to nutritional related subjects. IAP can play a major role. As I said, we are planning a major school-based initiatives next year, especially on junk foods and digital wellness, both of which are instrumental in increasing this epidemic of obesity. On the personal note, what now we are concentrating on is the ongoing research areas in both severe acute malnutrition and vitamin D deficiency. We are going to a molecular level where now we are studying the mitochondrial dysfunction and premature aging associated with SAM and vitamin D deficiency. So we have just designed, and some results are in, some results are yet to come. Thank you very much for this patient listening. I dedicate, again, the second dedication is to the entire team of postgraduates. My very dear friend, Dr. Dheeraj Shah, who has been constantly, we have worked as a team to almost all these papers, we had worked together for with help of all my dear students and friends who are shown here. Along with, we have our statistician, our endocrinologist, and dear friends. And finally, I will be failing in my duty if I don't uh, give my thanks and another dedication to this man, Professor H.P.S. Sachdev, who inducted me and who made my interest in nutrition double-folded and was always a guiding spirit at every nook and corner. Whenever I faced a problem, he was always there to help me. And I drew inspiration because he was the first editor-in-chief of Indian Pediatrics with whom I worked. And again, his style of working. So maybe I may have, I don't know whether I have imbibed something from him or not. And today, because Dr. Sachdev worked with Professor Bhargav, so directly I think there is a chain which I am linked to Professor Bhargav also. So I am fortunate to have that link through Professor Sachdev to Dr. Bhargav as well. Thank you, sir. Thank you, everybody, for giving me this opportunity to share a few of my research areas in this Kanpur oration. Thank you.
Thank you, Piyush. Has been a wonderful oration, especially for a person who has worked, talking for myself, not really been involved directly to nutrition, but having been worked from maternal nutrition to newborn to what Siddharth talked of the life course of a person from in utero to adult health, disease and human capital development. Your focus on acute malnutrition and focus on talking on, especially on taking on the advertised food, which I personally feel is where we should really go all out for. Having been crossed perhaps all the milestones that one perhaps would like to do as a pediatrician in life, one thing that I think you being the president-elect for IAP, and perhaps this is not the right forum for me to express, other than complimenting you for your excellent oration, is that I find that IAP is not so proactive in policy formulation as they should be. I feel we take if you'll forgive me, using the crumbs that are thrown to us, we accept them, follow them, and do that. I think Arden would remember the times then when we dictated the policy, we accepted the money, but the policies were determined by the pediatrician. I would especially like to remember my peers, Dr. Walia, so many of them, Dr. Desai, so many Bombay pediatricians who always got together to dictate as a pediatrician and not accepted what was given to us by national and international organizations, because now they come with tons of money. And in our times, the money was the last thing that was offered to us. We had to beg, borrow, and steal for every single paisa. For Indian pediatrics, you don't know. Arden is there, I can see him, what we had to go through. So please, when you take over as pediatrician, at the IAP, when you lead us, I would like you to play a very more proactive role. Now let me just put a question about the COVID. I have not seen any noise being made, a trial about COVID vaccine being made in children, whether the adult vaccine will be as good for us or as bad for us, or when we start inoculating us. Can we go ahead with children straight away? Do we need a trial or don't we need a trial? I have not seen IAP. I'm a member of the IAP, so-called alleged IAP President's Group, which is so active on WhatsApp. Not one comment. So please, when I'm taking this liberty addressing you because perhaps I'm advised not to move out of my house. So I'm taking this opportunity to request the President-elect to pay some attention to these things, which are really, as a IAP, we should be more of policy man than anything else. I would like to thank Ramesh and the entire team of Ramesh, Smita, and this particular team I would like to compliment. They have done such a good job in this difficult time. Every day there were some programs. So I would like to thank them for all that they have been doing for this year, especially in these difficult times, and to give me this honor to be chair at this conversation for a friend of mine whose family has been so dear to me. Thank you so much.
Thank you very much, sir. Thank you very much, sir.
Thank you, Sita. I have to especially mention you. I remember my you working with me, and I did not know you have been ill and unwell and working. And I'm sorry for my today's morning message. I did not get. I'm not so particularly fond of this instrument.
गुरु की डांट भी ब्लेसिंग है सर, गुरु की डांट भी ब्लेसिंग।
आपकी डांट हमेशा ब्लेसिंग है। आपके साथ मैंने पहला काम आप ही के साथ किया था। आफ्टर कमिंग टू दिल्ली आई वर्कड विथ यू एंड रिमेंबर माय इंटरव्यू विथ यू। Then I was not pediatric cardiologist, but you were talking about the echocardiography with me.
Can I have half a minute?
You've done very well.
Yeah.
Thank you.
Please.
Can I have half a minute?
Yes, Dr. Shrivastava sir, please.
There are two things, Dr. Piyush Gupta. Professor K.N. Agarwal, your mentor, was my class fellow. Right through the MBBS further on. And then I have two lines in his honor, Professor Piyush Gupta. Amartya Veer Putra ho, Drir Pratigya soch lo. Amartya Veer Putra ho, Drir Pratigya soch lo. Prashast Punya Panth hai, badhe chalo, badhe chalo. बढ़े चलो, बढ़े चलो. Thank you.
Excellent, sir. Thank you. Thank you. Thank you so much.
What a great advice.
लाने relevant नहीं है तो हमने कहीं नहीं, वो आपको मालूम होंगे. पीयूष गुप्ता साहब.
नहीं, relevant है सर पूरा.
Well, Piyush, just what about your mentor? I can't use the Hindi word for a brother-in-law. That's what he was to me. He calls my wife sister. And I always addressed him with that Indian name, brother-in-law.
Thank you, sir. Thank you, everybody. Thank you, Bhargav sir. Thank you, Srivastava sir, and Delhi IAP, all my friends, well-wishers. Datta sir is also here. Thank you, sir, for being here.
Well done, Piyush.
Thank you, sir. Thank you.
Thank you, Dr. Piyush Gupta ji. It was a wonderful talk we had. You took us in your journey, and we were taking a full ride with you in the journey, right from nutrients to junk food. The journey was fantastic. We enjoyed each and every word of you. Thank you. Thank you so much for
We are all proud of you. Piyush, we are all proud of you.
Thank you, sir. Thank you so much. I'm really humbled, and I'm really privileged to have you all here on this occasion to whatever I could speak. And it is all because of teachers, great teachers. Professor Datta was the first person under whom I worked at Kalavati when I joined in 1988 at Delhi. I still remember, sir. So you were my first employer there and the first teacher in Delhi. Thank you, sir.
Thank you so much, sir. Thank you.
Thank you very much, sir.
Thank you, sir. Thank you, Dr. Piyush. Thank you.
Thank you, Mr. Bhargav, sir, for good words, kind words, and of course, the guiding us. I thank you, everyone, and will move forward to another section. The Delhi IAP has extended its role in the society and the schools. We are working with various schools and we are promoting the child health literacy. It is very interesting that children who can play with the gadget at the age of 5 years, they don't know how to count pulse at the age of 14 years. So there has to be some knowledge transfer, and we are working on various part of health education. Our MEMS group, Medical Emergencies Management module in a school, is one of the wonderful initiative taken by the Central IAP, and the module was made here in our own Delhi. So this health education part, we really want that they should keep on imparting, and we can keep on making a platform from where they can impart this knowledge. So with keeping that in mind, we went for so many activities this year, and I really want to honor few of our associates who actually helped us in getting a good platform. So first of all, Rohit, can you share this slide I send you?
Yes, ma'am.
Please. You have my awards, wala, no? So these are the special awards we are declaring on behalf of IAP Delhi with the permission of Dr. R.K. Now, Honorable President of IAP Delhi and our EB member. So please move next slide, Rohit. So first of all, Ms. Anita Sharma, she is a mathematician, principal, educationist, and a dreamer. She is a member of General Council and the National Council of Educational Research and Training. She is a policy maker in nutshell. As a principal and as a founder president of ASGS Dream Big Society, it's a good name, Dream Big Society, where she thinks that every child has a right to be educated and should get education. She is not only a educationist and mathematician, she is also an entrepreneur and probably reformist. So she has a lot of interest, and she is working on certain disabilities also. And she wants to work with us for the MEMS program to take it forward. Next slide, please. So we want to felicitate Madam Anita as a Friends of IAP Delhi. So this is a felicitation award, Friends of IAP Delhi, in the school platform. Madam Anita, I would like to speak, you should speak something to us, and how you want to take forward our program of child health literacy. Madam Anita.
Thank you so much, Smita ji, and the whole team of IAP. I extend my heartfelt gratitude for giving this love and for this felicitation. As I was listening to Dr. Piyush Gupta, I had two things in my mind. Being a mathematician, being a mathematics educator, I was just thinking that if some of the things can be shared with us by the doctors, then we can convert them into the mathematics problems, which could be included in the mathematics textbooks, because nowadays even the CBSE has started giving the questions which are based on the case studies. So it is being felt that until the child has a practical knowledge and he is able to apply his knowledge in the real life context, the whole knowledge goes waste. And this is one problem due to which our children, they are not found very suitable by the employers in the industry or the corporate sector. So including this medical case studies in the mathematics textbook would be a very, very good idea. I did this experiment 2-3 years back. At that time, the CBSE started the open textbook examinations in the classroom. And I came across one book by one of my friends, Children Eat Everything. This is the name of the book, and it is by Dr. Nilanjana Singh. She's the president of the Indian Dietary Association. So I converted that book. It was talking about the child obesity and many related problems. And I converted that book into the mathematical case study. And it was appreciated by all teachers, and they feel that about number of things they were able to sensitize the children, how they should take care of their diet plans and how they shall take the good nutrition. So this is one thing which was coming to my mind. Second thing is that recently the ministry has declared, the government has declared the national education policy. And this, in this national education policy, for the first time, it has been said that that being the educators, we shall make parents as a very, very important stakeholder in the education, and the education shall start right from the age of 0 years. That means from the time of conception. And for that, a special curriculum shall be made for the parents, where they shall be given this important understanding that what kind of health and nutrition plan they should follow in order to have a healthy child, in order to have a child with a fully developed brain and all that. And in the morning today, we had a meeting on this new education policy, and at that time only this was decided that a parenting curriculum shall be framed. And I was just remembering you people at that time that only IAP can contribute in this matter, in a sense which can make very that you can develop a very, very significant program. And the kind of the studies which Dr. Piyush has shared, I was not able to attend the first presentation, but the second presentation I attended, and I really found this very interesting, and lots of things are there for everyone to understand as a parent. So I would like to have the contribution IAP in this direction. And the third thing is that when we conducted this child health literacy program, even at that time when education minister came here, and few days back also somebody from their office has inquired from me that how we are scaling that program. So as Dr. Smita, we had a conversation earlier that you have 35,000 members at the national level. If each doctor can start with one school, just educate one school completely in that child health literacy, and create every child a member of the child health brigade, then I think in this year itself, we are going to have millions of students who will be educated in this direction. And we can start thinking about this. I could give my services in connecting you people to the schools. So
Thank you very much.
whatever services is required from my side, I'm always there. Thank you so much.
Thank you very much, ma'am. And Dr. Piyush probably will talk it over later. So this is the felicitation award, sir. We are awarding Ma'am Anita, and you can understand how enthusiastic she has been. We have been performing some school education program over the 40-45 schools. So many principals participating, counselors participating, parents participating. So she has given a very great platform. She also is a founder president of ISGS society, which is working only for these things. So even association with that society, the lot of schools will come into fold. So thank you very much, madam. Rohit, next.
Thank you so much, madam.
Thank you. So next, we want to award this Friends of IAP Delhi felicitation. We want to give Miss Rashmi Joshi. Rashmi Joshi is president of Down Syndrome Parental Society. And along with them only, we recently, sir, you have actually, Dr. Piyush have attended that program. So this was a program about kids with the Down syndrome who are not, who don't have any disease, but a different arrangement of the chromosomes. So they need to be live up to the potential, and they need to be learned to make choices, and we need to learn to make, let them make choices. So these are the aim and objective of these kind of program, and they, I really request my next upcoming office bearers to be in association with our friends of Delhi, and carry forward this thing which we started in this year. Rashmi Joshi, are you there? Rashmi? Rashmi, somebody was
hello, ma'am.
Hi,
This is
Rashmi.
Deepti here, ma'am, from
Okay,
the
Deepti,
SPS.
thank you very much, Deepti.
Yes,
So
and
tell few
Anil
words.
Joshi,
Yeah, Anil Joshi,
Acha,
I
Anil
am
Joshi is
here.
there. Yeah.
Ji, thank you.
So Mr. Anil Joshi is very important person because he has been working day in day out. He is a IT person, but now he is interested in per se policies regarding the children. So I really welcome you, Anil ji.
No, thank you, ma'am. Thanks so much.
So and then you want to say something, Anil ji?
Yeah, thanks. I mean, as I said, I'm here on behalf of all the mothers of children with Down syndrome. And I'm very happy to be here to represent my wife, who is sort of one of the torch bearers of this movement. I have no words to thank Delhi IAP and Central IAP, especially Dr. Nab, Dr. Smita, Dr. Manish, Dr. Lalit Mendiratna, and Dr. Jani for having taken this lead. The reason why I'm saying this is because pediatricians are the people with whom the life starts. And every child is precious. So the way we welcome the child in this world, regardless of the condition he's born with, our total responsibility is to make the life meaningful and happy. And these are the basic thoughts with which we started our journey some 27 years ago. And the beautiful journey with pediatricians, actually, the foundation was paved way back in 1997 when we conducted the first national conference with IAP Central in Nagpur. And the journey started from there. Possibly the disabilities wing was founded at that time. And we are happy that this partnership has begun in Delhi, because from Nagpur we came to Delhi some 15 years ago. The reason why I'm thanking you guys is because it is that sort of a synergy which is going to make a difference. And with the support and guidance of Down Syndrome Federation of India, which is a national network of the parents with the aim of reaching out to every family who has been caring for the Down syndrome child. And we have any number of beautiful examples across the country to show and establish that, yes, every adult with Down syndrome can lead a meaningful life, provided we, as stakeholders in the ecosystem, provide him that sort of an opportunity and extend wholehearted support by accepting the way he or she is. I'll stop here by saying thanks, thanks, and thanks. The partnership has just begun, and we, with the help of Down Syndrome Federation of India, plan to take it to all the national network of pediatricians so that the society at large becomes aware and become supportive, welcoming, and are ever willing to provide every possible help that may be required in understanding the true potential and helping them attain them. Thank you so much.
Thank you, Mr. Anilji. Now, next, we also identified some student leaders who are working in the field of health. One of them was Parvita Mishra. She is my daughter, and she started a organ donation program amongst the children, school children. But it was in 2015, but subsequently this program became more structured, and Mr. Lakshya Agrawal took it over. Please show next next slide. I'm so sorry. Abhi Lakshya ka dikha dena, please. So Lakshya, are you there? Lakshya. So he is now in the University of Massachusetts, and Lakshya.
Hi.
Hi Lakshya. So you want to 2 minutes only, please.
So I'm first of all, I'm really grateful for this opportunity, and I'm thankful for Smita ma'am, Delhi IIP, and Payasani charitable trust for helping me out throughout this whole journey. I um, I started out this organ campaign to educate my fellow peers about the disease organ donation. People don't know about this and develop myths regarding this process. So I just wanted to educate my peers so that they could take better decisions when they had to choose for their family members and in near future. So it was just a little step so that they could be educated about this process.
Thank you very much, Laksh. You have done wonderful job. You given us first research, published research for the Delhi IAP. Thank you very much. So next, Seher Taneja. Seher Taneja. Seher Taneja, is she there? She is there? Seher?
Yes,
No.
ma'am, I'm here.
So please, 2 minutes, few words only. She is one of the most enterprising child I met, and she is doing so many things. But she is also she has participated in our programs also as a moderator and as a speaker and as a artist also. So please share few words.
Thank you so much, ma'am. And firstly, I would like to say I'm very grateful and honored to be getting this award by IAP Delhi. And I would like to thank Napsir and especially you, ma'am, for being a part of my journey throughout and helping me and guiding me. Also, if I talk about my journey with organ donation, I have my own initiative by the name of Abhigita, where what we do is, as Lakshay very correctly said, what we try is to raise awareness amongst youngsters about the importance of organ donation and the gift of life and how important it can play a role in so many lives and change the whole uh, way of saving lives. And we've successfully reached to almost 5,000 people in the country. And this post-COVID era where we're on online platforms through Zoom, it has been a very successful way of reaching out to more and more people and clearing the myths which are associated with organ donation. And Ma'am Smita Mishra, thank you so much for guiding me in this journey and telling us what is the correct way to go about it. And we would love if all of you, the COVID warriors, I'm really inspired by the work all of you doctors are doing, and my parents. I see them working hard. And that's why the whole motivation of us as students playing our little role by making people aware. And I hope we can further associate with this initiative, Abhigita, organ donation, and many more platforms.
So
Thank
the
you.
organ donation in high school, the idea only is that they should not going to fill a form or anything. They have to just talk that organ donation is not a taboo. Just do it. Just do it. It should be trendy that we are organ donor.
Exactly.
So this is what is the idea. Just to put a seed inside the brain because they are decision maker over the period of time. So next slide. Thank you very much, sir. You are really impressive. Thank you very much. Next.
Thank you, ma'am.
Rohit, Shibi is a MBBS student and daughter of Dr. Mandy Ratha. She actually co-authored the book Approaching Teens, and we are very proud of her because she made a very good book which we released on the Teenager Day. Next. Sharadi is also MBBS student and rather postgraduate student, and she co-authored a book on the deworming along with Dr. Anurag, and we have created a memento for her also. Thank you very much. Next. Now we our award session finishes over here, and now
congratulations, Smita. Can I just put congratulations and words of appreciation
not,
for this young brigade or breed which is coming out in such a good manner and contributing. And plus your innovative ideas. I'm so happy about it, Dr. Nab and Dr. Smita. how you have reached out to the community and involved all this young generation to take this all forward. Thank you. Thank you.
We
Ma'am,
had several school health programs.
so मैम यही है कि आज के दिन में ना बच्चे इतने enthusiastic हैं, teachers इतने enthusiastic हैं, they are just ready to actually grab if some knowledge has been offered. It's like that. Huh, ma'am? Am I right? So coming to next portion, because of lack of time, we are going for presentation of annual report 2020, and so just a minute. So I will start from calling everyone, respecting and welcoming everyone. Our conference has patrons Dr. Bakul Parikh, Piyush Gupta sir, Dr. Ramesh Kumar sir, Vasuraj sir, co-patron Dr. A.S. Vasudev, Dr. Sangeeta Yadav ma'am, Dr. Harish K. Pemde, Dr. Devin Mishra, Dr. K.C. Tamaria, Conference Chairperson Dr. Shyam Kukreja, our Chief Organizing Chairperson Dr. R.K. Naab, Chief Organizing Co-Chairperson Dr. Ellen Taneja, Dr. A.J. Chitkara, Dr. Lalit Mehendirata, Dr. K.K. Jani, Finance Secretary Dr. Manish Gupta, Co-Organizing Secretary Dr. Tapisha Kumar, Dr. Deepak Gautam, Dr. Pankaj Garg, Dr. Puneet Dhawan, Advisors, Dr. J.S. Bhasin, Dr. A. Ghai, Dr. Krishna Chuk, Dr. A.S. Vasudev, Dr. Anupam Sachdev, Dr. Ashok Devrari, Dr. A.K. Sharma, Dr. Varinder Singh, Dr. Y.K. Sareen, Dr. Harish Chelani, Dr. Dinesh Agrawal, Dr. Anupam Sibbal, Dr. Arun Wadhwa, Dr. Ashok Chakravarti, Dr. Arvind Garg, Dr. Harish K. Pemde, Dr. Praveen Khilnani, Dr. G.P. Kaushal, Dr. Alok Bhandari, Dr. Devin Gaba, Dr. V.K. Goyal, Dr. Piyush Jain, Dr. Ruchira Gupta, Dr. Sanjeev Mehta, Dr. Sushma Nagia, Dr. Raju Gupta, Dr. Vipul Jain, Dr. Vikas Taneja, Scientific Committee, Dr. Shyam Kukreja, Dr. J.S. Bhasin, Dr. Ellen Taneja, Dr. A.J. Chitkara, Dr. Suresh Gupta, Dr. Arun Wadhwa, Dr. Tapisha Kumar, Dr. Dheeraj Shah, Dr. Harish K. Pemde, Finance Secretary Dr. R.K. Naab, Dr. Arun Wadhwa, Dr. Ashok Chakravarti, Dr. Dinesh Sahai, Dr. Sanjeev Mehta, Dr. Deepak Gautam, Dr. Piyush Jain, Dr. Raju Gupta, Dr. Dinesh Mittal, Dr. M.S. Tomar, Dr. Piyush Khanna, Dr. Devin Gaba, Delhi State City Branches President Secretary Dr. R.G. Alwadi, Dr. Swati Bharadwaj, Dr. Piyush Jain, Dr. Dinesh Mittal, Dr. Shalini Goyal, Praveen Khilnani, Dr. Manu Agrawal, Dr. Dr. Manish Chopra, Dr. Prashant Seth, Communication Committee, Dr. Vipul Jain, Dr. Alok Bhandari, Dr. Devin Gawa, Dr. Piyush Khanna, Dr. Pankaj Garg, Entertainment Committee, Dr. Arun Wadhwa, Dr. Ashok Chakravarti, Dr. Manish Gupta, Dr. Prashant Seth, Dr. Puneet Dhawan, Dr. J.S. Batra. Reception Committee, Dr. Tapisha Gupta, Dr. Nirupma Tyagi, Dr. Neelam Mohan, Dr. Shalini Goyal, Dr. Swati Bharadwaj, Dr. Hema Mittal. Poster presentation, Chairperson Dr. Harish Premde, Co-Chairperson Dr. Anju Agrawal, Dr. Hema Mittal, Dr. Ajay Kumar Gupta, Dr. Ravi Sachin, Dr. Kumar Ankur, Dr. Pankaj Garg, Dr. Deepak Gupta. E-Souvenir Committee, which will come up after this program. Chairperson Dr. Manish Gupta, Co-Chairperson Dr. Manas Kalra, Dr. K. Sharda, Dr. Shalini Goyal, Dr. Nirupma Tyagi, Dr. Prashant Seth, Dr. Piyush Khanna, Dr. Deepak Gautam, Dr. Dhiren Gupta, Dr. Lalan Bharti, Dr. Vandana Singh. So respected, I welcome everyone. I really want, this is heartfelt. This is time to express my gratitude to all of you. There were so many people because it was a big conference and everybody really worked from core of the heart. So I really wanted to say thank you. Many names we didn't take before. So this is why I took every single name and I'm really thankful to every single person. So respected seniors and dear colleague and the friends, good afternoon. At the outset, I want to express my gratitude to Dr. R.K. Naab, Honorable President and IAP Delhi member, for giving me opportunity to work as the Honorary Secretary of IAP Delhi. I have been associated with IAP Delhi since 2014 when I applied for Executive Board member on behest of then President-elect Dr. Kiran Agrawal. In the meantime, I remained associated with the IAP Delhi as I loved working creative and the social aspect. Dr. Naab had extraordinary energy strategy to envisage planning and programming for 2020 for much before he took over, but IAP Delhi kept swinging from one compelling issue to other once we took over the office. Biggest setback was COVID pandemic 2019. For the first time in life, we, like many other, literally counted patients from WHO India press release. We were refrained from any physical gatherings, so we had to cancel our most important monthly meetings. Till then, we conducted 2 meetings. We were lucky to have eminent speaker for the guest lectures. Our dear and respected Dr. Piyush Gupta was our first speaker for first ever meeting of our tenure. We keep on sending advisories for our esteemed members contributed by IAP Delhi EB members. We and our EB colleague actively participated in COVID-19 awareness program, and as the first warrior for the COVID, we participated in government DM meetings, school program, TV program, news release, WHO, UNICEF, whatever, whoever called us, we definitely responded. So friends, Maxwell said, circumstances do not make you what you are, they reveal what you are. IAP Delhi region up to the occasions, and our members have been part of big pandemic fight between the virus and man. There was fear all across the world, and doctors were detracting from facilitating services. But with the rising days of lockdown, calculating the risk of retracting from the timely immunization, WHOC, Central IAP, Delhi IAP came out with the advisories to continue essential immunization to avoid parallel epidemic. This was the region that many of our pediatrician list starts from Dr. Naab, Dr. Mendiratha himself fell sick and needed hospital and ICU care. Friends, this was a time of depression, financial losses, and never-ending gloom. IAP Delhi tried to engage with you in the form of greetings, posters, emailing, and the scientific material to apprise you with the recent knowledge. Thank you to IT who brought us various virtual platforms. DIAP actually led from the front, and the IAP Delhi went meticulously hand in hand with its city branches, giving them space and asking for itself. We avoided superimposing program. We did catch up monthly meetings so that we can keep the schedule. Once it happened, we again went on monthly Thursday schedule. At this point, I want to acknowledge all medical colleges, hospitals, head of the departments, and other esteemed colleagues, registrars who contributed to these meetings. Friends, it was not the usual time. And all these contributors were those who were packed in substandard PPE, 6 to 7 masks per month, lacking ventilation, staying away from home, listening bickering of administration, wrath of public, and yet not getting salary for the month. So, friends, hats off to all of them who really worked like a warrior. What we thought of Kargil warriors, military, army, the same was true here in the hospitals. So these monthly meetings are a matter of our pride for the members who had no less commitment for the academics as they have for the country. We are grateful to our city branches. We took initiative in creating a COVID action force under the leadership of Dr. R.K. Naab, Delhi IAP president. And I would like to admire him at this particular point. Like an elder brother, he was always there for everyone. He had always positive attitude and always had a positive belief on each and every person who was working with us in Delhi IAP. We have admiration for the North Delhi, Dr. Dinesh Mittal, Dr. Shalini Goyal, East Delhi, Dr. Piyush Jain, Dr. Nirupma Tyagi, West Delhi, Dr. Manish Chopra, Dr. Prashant Seth, and also South and Central Delhi IAP leadership, and AHA Delhi for joining hand with the IAP Delhi and making the academics more interesting and less crowded. People will definitely remember ImageCon, PulmoCon, EndoCon, AdolescentCon, ECOP, and many more. IAP Delhi did many webinars and special day celebration. I'm not going to count them, like Thalassemia Day with the Thalassemia Society, Breastfeeding Week, and Newborn Care Week with the NNF Delhi. We did a special session on rabies with the help of Dr. Anurag, Dr. GP Kaushal, eminent national faculties. A very admired program just before the World Rabies Day and World Heart Day. We celebrated World Heart Day also with the CIAP and the Adolescent Child Healthcare Week. Dr. Nav will acknowledge that this year of despair and dissociation was also can be calibrated as a year of harmony and brotherhood for the our sisterhood for the IAP Delhi city branches due to this togetherness amongst the various stakeholders. Friends, when we started, we had great plan to support Government of India program like National Tuberculosis Control, which was delegated to CIAP, rabies control, and intend to participate in all CIAP welfare program like charity Rath. We also had in our agenda to create a website where all IAP members, if they want to, can leave their information, and we mailed you asking for the same. We didn't get reply, but really still you can do that. Website would have ambulance number, emergency hospital number, and that is there. You can see that. You all can put information about your nursing home, ambulance facility. We have now a biodata bank of esteemed faculty on our website. We have a YouTube link. All our program and monthly meetings are available on Facebook. If you want to watch Daughters Day program, which we did with the Padma Shri Miss Hema Malini, and was a very famous program. She is a famous actress, MP. You can visit our Facebook page and you can look into that program. We are active on Twitter. I request all of you to follow Delhi IAP Twitter so that we can make a noise together whenever need arises. Social media is very important, friends. Last year, we published quarterly e-bulletin to convey our activities of particular month. However, this year it was insufficient. Due to the e-platform, this activity got heightened to the extent that every week we had webinars activity equal to 2 months activity. That's why our EB had accepted proposal to publish weekly Monday Pet News for this year so that we can provide a proper information about the upcoming and last week activities to you. These small news bulletin also provided crisp and concise research news courtesy to Dr. K.K. Jani and Dr. Manish Gupta, Editor-in-Chief of the Bulletin. I am thankful to Secretaries Dr. Shalini Goyal, North Delhi, Dr. Nirupama Tyagi, East Delhi, and Dr. Prashant Seth, West Delhi, who regularly given us timely input so that we can publish these inputs in the Monday news. It was really difficult because on Sunday mostly program were happening. Coming to bonhomie and interest of cohesive working. We celebrated successfully Teenager Day due to Dr. Deepak Gautam, who himself taken the responsibility, made alliance with the AHA Delhi, Dr. GP Kaushal, Dr. Latika Bhalla, and schools, school children, and leaders like Sehat Taneja, winning of our who is winner of our Student Leadership Award 2020, and Dr. Prashant Seth, cultural program, who made a wonderful cultural program for this day. And IAP Delhi was fully supported by CIAP in all its programs. We did totally dedicated point of care ultrasound 3 days virtual workshop on eco-imaging, neuro-lung imaging, and vascular imaging. Needless to say, they were out and out success. We took many programs which cannot be calibrated on the scale of academics. These programs were a result of long discussion with President Dr. Nab and few of our EB members. 1st October, Daughters Day program. 4th Saturday of every September is celebrated as the International Daughters Day program. We joined hand with the SDP School Pitampura and ASGS Dream Big Welfare Society. We had eminent guest of honor, Ms. Sumedha Satyarthi, co-founder of Bachpan Bachao Andolan and founder of Balashram. Distinguished guest, Ms. Surabhi Tiwari, Mrs. India International Culture and Elegance and Tourism. Ms. Lalita, a brave warrior from Bachpan Bachao Andolan, recipient of so many national and international awards. Ms. Avni Tiwari, first woman fighter pilot who she participated through a special message for the girls. Padma Shri Hema Malini ji was our chief guest, and she actually stayed there for hours together. We were thinking that she will stay only for the 15 minutes. We also had an eminent panel to discuss the issues associated with girls. We had school children to show their talent, and we had so many counselors and the teachers to talk to parents and our all IAP doctors to listen our program. More than 47 schools across the India participated the program. We are especially thankful to Ms. Anita Sharma, Principal SDPS and the founder president of ASGS. She is being felicitated as friend of IAP Delhi Award. 3rd November, we celebrated Children's Day and released a book on the child health literacy with the tag of Let's Every Child Be Part of Child Health Brigade. The book was written by Dr. Mendi Ratha and was based on CIAP ambitious project, medical emergencies management module for the school, and was thoroughly, we borrowed material from there, and we actually credited also. So MEMS group under the leadership of Dr. Alan Taneja conducted the workshop. Chief guest, Mr. Ramesh Pokhriyal, who is our Honorable Education Minister, expressed his keenness to follow child literacy in curriculum. As Madam Anita Sharma said just now, 24th November, friends, why adolescent suicide, depression, psychotropic drugs, and addictive drugs abuse is on the rise? Is it because of getting less or wanting more? Do you really think an adolescent facing undue competition and not yielding result can be subjected to psychotropic drug directly? Isn't this effort to feel good may take away the motivation of a child? To understand these arguments and counter arguments, we managed to do a program on important and unique subject of challenges of youth, career aspirations, success and failure. Dr. Prashant Seth came forward and conducted the workshop. Chief guest of the program was none other than Dr. S.K. Bhattacharya, founder president of Bal Bharati Group of School, an eminent educationist, a policy maker. Kids and Down syndrome are frequently seen as they have a longevity. They are usually beautiful, laid back, ready to take their own way of growth. They are teacher for their parents and teachers. They have no diseases but different arrangement of genetic material. The program Down syndrome, making choices and living up to potential was planned for the 21st March 2020, but could be being convened on 21st November in association with DSPS Delhi under the leadership of Ms. Rashmi Joshi and Anil Joshi and Deepti Mathur, and Ms. Dr. Manish Gupta, Secretary-elect, was the convener. It was our privilege and honor to invite the Dr. Rekha Ramchandran, co-founder and president of DSFI, Down Syndrome Federation of India, and Mr. T.D. Dharyal, Chief Commissioner for the Persons and Disabilities, to inaugurate the program. Both have helped in revolutionize the social standing of children with special need. We created few recognition awards, which you witnessed just now. We also recognized and we recognized the students also. We also released a small booklet in this tenure, School Etiquette on the COVID management of the helminth infestation in the children, with Dr. Anurag and Dr. Sharadi, and girl-specific adolescent issues, a book by Dr. Nirupma Tyagi, Approaching Teens, Dr. Lalit Mendi Ratha, Shivi Mendi Ratha, and Child Health Brigade, what I talked about few minutes before. And many of them are still on pipeline. So election, if they happen through the votes, may be called as vibrant process of democracy. If they happen through a consensus, this is called amicability. So this year we are looking at vibrant democracy. Therefore, we are in process of developing a software. Once the software is in place, with the checks and balances, we will have a process of election probably 3rd week of December, and we will inform you accordingly. I am really thankful to Dr. A.P. Dubey. It's not easy to conduct an election and in this era of conflict and taking all the pains. So thank you very much, Dr. Dubey. We really welcome you and we admire you for your patient dealing with all of us. Regarding the amended constitution, which we will not be able to put this time because we need a physical meeting, SGM, as per the registrar office requirement. And that will happen once the COVID is over. Then PCNI or NIPID, Dr. Nav has actually spoke about eloquently. We are really thankful for our scientific society and every scientific committee and every person who actually worked for it. And we are thankful to our morning guest, Ishwar Chandji Giri, Kailash Satyarthi ji, the Joginder Singh Tuteja, Madam Sangeeta, Madam and Pemde sir, Latika Bhalla, and also we are thankful to Dr. Sunita Maheshwari, Dr. Ashok Devrari, and Dr. Devendra Mishra. We are thankful to Dr. Ravi Malik, who taken everybody heart and brain at the same time, and Dr. Ajay Gupta, Dr. Vipul, and Dr. Mukesh. And I think our office staff was working. This was a time of depression. COVID was there. They were traveling every day from home to office. So Sushil, Anil, you have done wonderful job. You supported us. We are thankful to you. Swapnil, your team, Rohit, I think they have been wonderful worker. Nikita, they are always available. Whatever mistake will happen, but obviously they are always there to listen to us and to correct it. Uday, our person who is taking our looking after our website and all social media thing. So he has been a very cooperative all the time. Mr. Chaudhary has took over as our CA last year in 2019, and he is working hard because we had many issues and he is trying to sort it out. Ms. Neetu would be here to answer your audit query regarding the audit. So thank you very much. And thank you, Dr. Nab. At the end of this secretary's note, Dr. Nab, the president of IAP Delhi, I am really thankful that you have given me liberty and support to work to my best of potential. Thank you very much, sir.
Thank you.
Thank you, Delhi
Dr.
IAP.
Smita, just one point.
Wonderful time we had together, working together.
Yeah, Dr. Nab, just a comment on Dr. Smita's speech. Very nice, very excellent work you have showcased in the year of this difficult times. I think we all should appreciate and put it on the record, the hard work and the efforts done by the whole team and the amount of programs done. I think this should be recorded. In the agenda, you had mentioned that we would have the SGM and the changes to be made in the constitution. I think you should have erased that because see, I've been reading the constitution since morning and I've made notes which need so many changes in the constitution now. So I think if you had given me some time, I would have been more involved in the activities throughout the day rather than reading this about 50-page
I can
constitution.
take it back and we'll meet you later and we'll talk to you later.
Because see,
So, sir, I'm so sorry, and I take
no
it
issues,
back.
no issues. See, I'm also revising the constitution of Central IAP also. So we have been doing part by part for last almost 2 weeks, and I was totally involved. So I could see a lot of discrepancies which need to be corrected in our constitution also. And maybe whom should we talk to? I think Dr. Dubey is in charge.
Sir, we have a constitution committee.
Yeah.
Yes, Dr.
We have
Vasudev.
committee
I
and
think
we will recheck with them. Nobody has
Dr.
signed
Dubey
it.
is, I think Dr. Dubey is on the platform.
yeah, I think
We'll
Dr.
call a
Vasudev,
meeting.
I think now since we have time, actually in fact in the past also we have sent to everybody, but we did not see much of the response. But since we have now time, Dr. Smita has said that it has to go to the registrar office. So we can certainly take everybody's input, have a meeting later, and then put everything, whatever is required, and then give a final shape. So that is possible still.
Thank you.
I think what we can do is like we are having Zoom meetings almost every day for the Constitutional Review Committee of the Central IAP. And in the same way, we can have a Zoom meeting and we can formulate at least some changes can be made on the digital platform itself before meeting physically. I don't know when we would be able to meet physically. It may not be 6 months, 9 months. So at least on the digital platform, a lot of things can be sorted out very comfortably. There's no problem.
Certainly you can note down the changes you want to do, send it to me or to others. You can send it to me, and then we will see, and then the committee which is already there, all the members, we can have a Zoom meeting and certainly decide about these things. No problem.
ठीक है sir. हाँ, that is
I
wonderful
think-
idea.
I think
I would like
We
to
can invite
participate.
suggestions from members
I
also.
would like to
We can invite
participate
suggestions
in
from
the
members
Zoom
also.
meeting whenever
Absolutely.
you have.
Yeah, that is
The
still
last
possible.
formal meeting can be held for physical meeting when everything is finalized on Zoom meeting. That
Yeah,
will not be a
at
big
the
issue.
end.
At the
In
end,
the end.
because 5 or 6 members are there in the committee, so those 5 members can meet in the IAP Delhi office. We don't need
Yeah,
200.
that is at the end, but before
The
that,
SGPM has to be
let us give
physical.
input. Let us take
Special
input
GPM
from
has
other
to be
people as well.
physical.
Best is give your inputs. Even the members can give their inputs by mail.
Sure,
Yeah,
sure.
but have you
Everybody.
asked? Have you asked the
Input from
input from the
everybody is
members?
welcome.
Yes, sir. Yes, sir.
No, members have not been
No,
asked.
when it is when the
Just
mail
a
has gone to
Pankaj,
members.
Pankaj, we were planning to put in GBM.
Yeah,
first.
Pankaj, 2 years back, the committee is working. You are the member.
No. I'm saying to general
Pankaj,
members. You are saying
you
general
are
members.
member.
सर
The
इसके बारे में
committee
पंकज
is
पिछले बार
working
2019 में बात हुई
last
थी
2
GBM
years,
में.
and initially, general members.
What I
First mail,
suggest is now,
everybody
since we
knows.
have time, we
Dr.
can
Dubey
put
sir
forward
बड़ा
and asking suggestions from the members, and
ठीक
the
से
amendment
करते
committee can look into
हैं.
those suggestions.
And give a
Can
timetable,
I
give a
come in?
timeline so that they can
Dr.
send
Smita,
it
can I
within
come?
next 2 weeks or
Right,
so,
yes, sir.
whatever time.
Right.
Give a
Dr. Tamaria
timeline.
wants to say something. Dr. Tamaria wants to say something.
Dr. Tamaria, please go ahead.
Good evening. Good evening
Good
to
evening,
everyone. Actually, what we supposed to consider today, it was already passed by the GPM last
Yes,
year.
sir. वही तो मैं कह रही हूँ कि वो हो गया था.
And it was circulated to every member, but there was no suggestion on this. But now at last minute, suggestions are coming up. So
Yes, sir.
there should be some, how long we carry it on? Because this is after establishment of the Delhi IAP, constitution was not amended. We initiated this and we took pain, and Dr. Dubey we grateful to Dr. Dubey. He worked hard. He presented the constitution before the GBM, and it was passed word by
GBM में
word,
हुई थी बात. Yes, sir.
read on that day, and it was corrected and finalized that day. Now, if it is a postponed,
See,
the
These need to be
SGM
just
is
ratified by the
finally
SGPM.
SGM is basically
and-
meant to ratify and make
Sir,
any
this
Just need to be
changes.
ratified.
If there are any
these
Sir,
two,
then
Dr.
SGM,
Tamaria,
as
sir,
per-
what was
SGM was never
ratified
held,
and
sir.
what is there in amendment,
Sir,
there is a major
as
few
per Delhi
differences.
IAP constitution, sir, special GBM is not required.
It is
It
required,
was
sir.
included in this.
Sir, according to registrar office, they say कि it is required.
SGM,
So
it is required,
75%,
sir. It is always required.
75%
Following
majority.
the central IAP guidelines, and central IAP also requires SGM, and so does the Delhi
The
IAP.
constitution
75%
amendment has to
majority,
be
sir.
passed this
No,
year.
but this actually, this is not in our constitution.
It is
or
there, sir.
in,
It is there,
and
sir.
society. No, it is in new constitution, not in our original constitution.
So
Number
we
one,
hire our
number
constitution from
two,
CIAP.
Registrar,
Sir,
society,
when you are
Sir, number two,
SGM
as
needs
per
to be
Society Act, as per Society Act 1862, there is no provision that if there is any change in the constitution, that to be considered in the special GBM. For constitution, this is not required, but in a CIAP constitution, it is there. And we have taken this time. In original constitution, it is not there.
It should be
So
there,
that
sir.
whatever the pass in the GBM, it should be final and to be sent to the registrar of societies.
So we
That's
can
my
make a representation to the registrar again.
Sir, it is a
And
part
as-
of the registrar of societies. It's a part of it that after the general body, the special general body has to ratify all the changes.
Sir, that is
and
not
then
a
it becomes
provision in our
constitution.
constitution and not in a society act. And as far as
Dr.
a
Tamaria,
physical,
Dr. Tamaria,
as far as a
since
physical
Dr.
meeting is
Tamaria,
concerned, yes, sir. Yes, sir.
can I intervene just as we are seeing
Yeah.
that many people have now giving suggestions, which they have not done in the past. We can have a relook. There is no problem as far as the relook is concerned. We can have a relook, give some timeline, and then we should finalize. And if it is necessary, we can do that as well. There is no question that we cannot do. But let us find out. Let them find out. And in the meantime, give some time, maybe timeline. Dr. Smita, you can just suggest some timeline. After that,
1 month.
we
Okay,
can
sir.
have a
There
Zoom
should be
meeting
some
and then finish
timeline.
it.
It should not be lingered
No,
on
no,
like
ma'am,
15
no,
days
no,
कर देते
no,
हैं
no,
सर,
no, no,
15 days.
no, no,
15
Dr.
days is
Tamaria,
enough.
not 7 days. No, at
15
least,
days.
no,
No, no,
just
give
7
at
days,
least.
ma'am. It took 1 day to
7
read.
days, okay. 7
It
days.
took
7
1
days is
day. It
enough.
just
1
took
week is
1 day
enough.
to read the.
1 week is fine.
Ah,
Yes.
1 week is enough.
Yeah,
1 week
give
is
1
enough.
week's time so that people can give their inputs, and then we can have
Sushil,
Zoom meeting later
if
on
you
if
are there,
necessary.
we'll make a notice tomorrow morning.
And then
Sushil,
we'll have a meeting of
Please do.
Constitutional Committee, and then we'll have SGM.
Please
Yes.
do it.
That is
Yeah,
final.
no problem. Thank
And
you.
and
Within 1
and
week.
registrar of society to be requested for the virtual
Meeting.
platform.
Yeah, sure, we can
Virtual.
do that.
Because we
Yeah, you
cannot,
can do
we
that as
cannot meet in physically.
Not
at
necessarily
this
physical
moment.
harm.
Yes.
Right,
So
that is
a
also.
request to be sent to the registrar societies that we are calling special GBM on virtual platform.
बिल्कुल correct. बिल्कुल
Sir, maybe we
perfect,
can
sir.
have
Dr. Tamaria,
a
perfect.
hybrid kind of
And
thing. Ki 8 to
then
10
we
people
go
are
for
there in the office
agenda.
as
and
the
rest are on the Zoom.
as the opinion of all the members of the GBM seems here, and that and with the Dr. Dubey's permission, so we should include this special GBM for any future amendments also in the constitution, because as Dr. Tamaria was saying, it is not there in the original constitution. We should include this
Sure,
point.
sure. Sure, please suggest all
That is
what is
already
required.
included.
Please suggest all those things what is
That
required.
is included.
We will do that. There
Suggestions
is no.
should be given प्रशांत एक हफ्ते में हम लोग सब उस पे देख लेंगे कि क्या क्या मानना है.
Please, हाँ, जो
Dr.
है जरूर दे दो आप.
Dr. Smita,
हाँ जी.
सारे members को email करा दो copy of
मैं
constitution,
कल सुबह भेज दूंगी सर.
and then हाँ, and then deadline for 7 days, and all the suggestions will forward to the Constitutional Committee. Constitutional Committee will read for 7 days, and then the meeting of the Constitutional Committee will have SGM, and then we'll finalize everything. And
Yeah, good
I
time
think
table.
that is fine,
Resolution.
Dr. Dubey.
जो न्यू रेजोल्यूशंस हैं वो भी मेल करा दीजिएगा.
ठीक है लिख लिया मैंने.
Yes,
And copy which Dr. Smita sent copy that was passed in the GBM last year.
बोला.
ठीक है सर मैं कर दूंगी. अब नेक्स्ट एजेंडा में जाएं सर.
Yes, ma'am. Yes.
हाँ, ये now this is GBM for today. So welcome address, confirmation of. Now we have to go for confirmation of minute of last annual general body meeting. Just a minute. So then agenda 2 was minute of AGBM held on 16/12/2018 in Ashoka Hall. वो तो खैर हो गया. Agenda 3 after deliberation was presented to secretary adopted. Agenda 3 is after deliberation the annual report presented by secretary adopted. तो मान लो adopted.
Adopted.
लास्ट ईयर की मिनट्स ऑफ द मीटिंग रेटिफाई करनी है. लास्ट ईयर की मिनट्स एक बार प्रेजेंट कर दीजिए.
हाँ वही है.
इन्होंने ये बोल दिया था, इन्होंने मेंबरशिप के बारे में पास तो नहीं किया. ये अनस्टैंड कर रहे हैं हम लोग.
Agenda 4 is adoption of audit statement of account for the year 2018.
बोल देता हूँ ना.
नीता can I say something? सारे जो एजेंडास हैं उसमें प्रपोजल सेकेंडर भी तो नोट कर
बना सकते हैं. मेंबर दिल्ली आईएपी का सेंट्रल आईएपी का मेंबर रहेगा वही.
सेकेंडर विद ईच एजेंडा भी तो जीबीएम में होता है.
अच्छा तो
I propose, ma'am. I propose.
हाँ, somebody has to propose.
Dr. Gaba.
That is the way we run the GBM.
क्या करने हैं मैम?
Approve हो गया है ना? Last minutes जो approve हो गए, who is the proposer and the seconder? हर उसमें as a proposer and as a seconder.
Sir, President, sir, may I bring?
लास्ट ईयर की मिनट्स
हमेशा होते हैं और बिल्कुल होते हैं. You have to say जो भी last time meeting हुई है इस बारी वो जो करंट वाले अप्रूव कर रहे हैं उसका प्रपोजर और सेकेंडर होता है. हर उसका होता है हर एजेंडा का.
तो सर वो ईबी वाले लोग हो सकते हैं. ईबी के लोग जैसे डॉक्टर नाम इसको सेकंड करें ऐसा हो सकता है.
हाँ सब मैम कोई भी हो सकता है. कोई
to avoid the OB नहीं आएगा ना.
भी नहीं आएगा.
तो प्रपोजर मैं हूँ ना.
I propose Dr. Sangeeta will second.
अच्छा.
सर
किसके लिए जो सेक्रेटरी ने बोला उसके लिए?
Because I was nothing in
उसमें
2020 ना,
नहीं, हाँ
तो
जी,
I
सेक्रेटरी रिपोर्ट या
ठीक है।
क्या मैम कुछ बोल रही हैं क्या?
सर
हाँ,
मैं दो पॉइंट्स कहना चाहता
मैं
हूँ।
एक बात Alok wants to say something.
सर एक जो पॉइंट्स है, डॉक्टर पीयूष गुप्ता सर भी हैं और मैडम हमारे वाइस प्रेसिडेंट भी हैं जोन की। सर सेंट्रल आईएपी के कॉन्स्टिट्यूशन में इट इज वेरी क्लियरली रिटन एंड स्पेसिफाइड रिगार्डिंग सेंटर एंड स्टेट रिलेशंस. So there cannot be a member of a branch, state branch, who is not a member of the central branch. All
Yes.
other category of membership is associate members. We cannot have any voting member or contesting member in our branch who is not a central IAP member.
Okay, fine.
Agreed.
Every हमारा जो roles है, they should match with central IAP. जो central IAP के रिकॉर्ड में हमारे members हैं, हमारे ऑफिशियल नहीं रहेंगे. बाकी हमारे जो लोकल मेंबर्स हैं, हम जो क्लेम करते हैं, या तो हम उनसे पैसे लेके बैलेंस उनको सेंट्रल आईएपी का मेंबर बनाएं, या हम अपने पास से दिल्ली आईएपी पैसे डाल के उनका सब्सक्रिप्शन बेच के उनको सेंट्रल आईएपी का मेंबर बनाएं, या उनको एसोसिएट
सिटी स्टेट एंड सेंटर सब एक.
मेरा मतलब है जो सेंट्रल आईएपी फंडेड प्रोग्राम
Please
है,
go one by one. We can hear only one person.
सर आई कंप्लीट इन 10 सेकंड्स. जहां सेंट्रल आईएपी का प्रोग्राम है, सेंट्रल आईएपी का नाम और लोगो यूज हो रहा है, इट इज ओनली फॉर सेंट्रल आईएपी मेंबर्स. अगर हम कोई प्रोग्राम कर रहे हैं तो सेंट्रल आईएपी स्पॉन्सर्ड है, तो नॉन मेंबर्स से आपको चार्जेस लेने पड़ेंगे या दिल्ली आईएपी बियर करेगी. बट जो सेंट्रल आईएपी
That's done, sir, done.
वो ऐसा है.
सेंट्रल आईएपी मेंबर्स.
I request, I think.
अपना लिए सोच रहे हैं. थर्ड ऑप्शन इज आप उन्हें एसोसिएट मेंबर दे दीजिए, बना दीजिए.
नहीं, आपको फिर अपना कॉन्स्टिट्यूशन रिवाइज करना पड़ेगा डॉक्टर भंडारी.
सर कॉन्स्टिट्यूशन कैन नॉट बी कॉन्ट्राडिक्टरी टू द सेंट्रल आईएपी कॉन्स्टिट्यूशन ना.
नहीं, बट अभी तक जो कॉन्स्टिट्यूशन है उसमें ऐसा कुछ नहीं लिखा हुआ कि सीआईपी
क्लॉजेस मॉडिफाई कर लीजिए.
उसको मॉडिफाई कर दो.
Very important part of constitutional amendment will have to add into.
Alok, can I request and can I say something with the permission of the chair?
Definitely.
Number one is, since we are under the umbrella of central IAP, so we are bound by the constitution of central IAP. That is one. Number two is, since we are registered as a society, separately as a Delhi wala society, so जो हमारा constitution है, हम उसके हिसाब से भी चल रहे हैं, because sometimes the constitution of the registered society is little different for the working reasons from the central IAP, though by and large it is the same. See, I have been office bearer not only of Delhi IAP, but I have also been office bearer of different chapters which are now registered as society. So therefore, that is why I am clarifying that one thing is correct, that Alok said that they have to be member of central IAP and they have to be member of Delhi IAP. That is true. But we are not going to pay for anybody. The ones who have to become members have to be asked to become members of central IAP, and they will go ahead and become members. It is not our owners to pay for them and make them become members of central IAP. That should be very clear. Why should we be the financial supporter or the sponsors for encouraging this? That is very true. We are not going to do it. So that is one thing. The only this thing there, but as and when I will I'll take your permission to give suggestion as and when if it is required. Thank you.
President sir,
Dr. Sangeeta,
President sir, I would go a step further. As Dr. Sangeeta said, I think let us encourage that anybody who wants to become the member of IAP Delhi should also simultaneously become member of central IAP. Now in Delhi IAP, we have got 1500 some members, of which only about 1200 something are members of the central IAP. So we are losing the membership of almost 300 votes who could be central IAP members along with Delhi IAP members, and they can be a strong force for us also.
So, sir, we have done.
Agreed.
We have actually sent the mails
नहीं
every.
सर एक बात बताएं कि जो अब मेंबर ऑलरेडी हैं दिल्ली आईपी के, उनको अब क्या करोगे? जो नया रूल तो कॉन्स्टिट्यूशनल अमेंडमेंट आप कर सकते
जो
हो,
अब नए बनेंगे एटलीस्ट
उनका तो कर सकते हो आप, उनका
जो
तो कर
नए
सकते हो।
बनेंगे उनको हम कर सकते हैं सर।
पुराने
पुरानों
वालों
का
को
क्या
एसोसिएट
करेंगे?
पुरानों को भी कर
मेंबर
सकते हैं।
करो सर, पुराने वालों को एनकरेज करना होगा।
नहीं एनकरेज ही करना ना उनको, आप डिबार तो नहीं कर सकते।
बात है सर।
बाहर तो नहीं कर, लेकिन जो नए बनेंगे हम नए नहीं बनाए,
उनको तो ठीक है सर, नए को तो कॉन्स्टिट्यूशनल अमेंडमेंट कर
बनाए, दे शुड बी इन कॉम्बिनेशन विद सेंट्रल आईपी एंड दिल्ली आईपी बोथ।
सर कॉन्स्टिट्यूशनल अमेंडमेंट तो आपसे होगा ना, वो
office
सबसे
bearers
लागू
of
होगा।
Delhi IP have to be necessarily central IP members, so they cannot contest also.
Can
They
I say
cannot
one more thing?
contest.
Can I
Can
add
they vote?
something?
Because
Can they
all the
vote?
office bearers have to be central IP members.
वो तो है यार, that
For
is already
election you
there.
have to be.
That is already
जो
there.
भी नए सर सेंट्रल आईपी मेंबर्स बनते हैं उनका कंट्रीब्यूशन क्योंकि दिल्ली आईपी को
Ajay-
आता है, do they become automatically members of
Ajay-
Delhi IP?
No, no.
No,
there no central fund.
Can I say something, please?
Yeah, there is a central fund coming for all the
Please,
memberships.
can I say something? I have been
Yes.
in the institution for many years and as well as in the organization. There are many postgraduates who 50% of the postgraduate seats of Delhi are all India. So these residents are made to become members of IAP Delhi because they have to participate in the annual function for the award function. But after they are done, this many or most of them go back to their state, and from their state, then they will be counted. Whenever they become members, they will be part of that. So we have extra 300, 400 people on our rolls who had become IAP Delhi member, but now they some of them have actually, the ones who belong to Delhi have not become central IAP. So we cannot take responsibility of all the 300 because some of them go back to the state. But the ones who are staying back and are continuing, like it's very clear. See, once upon a time, I'm just giving a little example that Dr. Piyush who belongs to Delhi, but he was in UP and he's come back. So there are sometimes there are people who come back to the state, parent state, or go back to the parent state.
मैम आईपी
We
दिल्ली
have
के
to keep
इलेक्शन
it.
में voting
That's
right
why
का
it is important, ma'am.
That is
voting
right.
right का इशू है आईपी दिल्ली के इलेक्शन में, नथिंग एल्स। किसी का मेंबर बनो मत बनो डजंट मेक अ डिफरेंस। Do they have voting right? Members who are members of IAP Delhi but not of CIAP, do they have a voting right? That is the question we need to answer today.
See, now what
Madam,
does
student.
you have to see what you are.
Ma'am, the students which you are saying become members, they should be made associate members rather than full members unless they complete.
ज्यादा लोगों को बुला नहीं सकते थे, एक्चुअली तो हमें बुला लेना चाहिए था क्योंकि जो इतना अरेंजमेंट कराया
म्यूट करो संदीप, म्यूट करो संदीप, म्यूट योरसेल्फ।
Sandeep,
mute yourself.
Yeah, ma'am.
संदीप म्यूट करो।
Vipul, can you call Sandeep?
Sandeep, yeah.
Rohit, please mute.
तुमने संदीप को सेक्रेटरी नहीं बनने दिया ना, इसलिए उसने अपना ऑन करा हुआ, तंग कर रहा है।
I have a request to make. I think one person can speak at a time. Otherwise, so it is all in a. Who was proceeding? Actually, Dr. Smita, you took up the issue and then it is left. Otherwise, we won't be able to complete. There's so many other.
So, chairperson,
Please, I think let one
I want
person
to
speak.
invite Dr. Ramesh Nath, Dr. Dubey, Dr. Tamaria to chair this session. Or I should ask somebody else also. Please please guide me.
The president,
Hello.
Past
Can I
president
speak for
Dr.
2 minutes?
Tamaria, Dr. Dubey, and
May I
Dr.
speak for 2
Mehndi
minutes?
Ratha.
Dr. Gaba,
May I speak for 2 minutes just?
Dr. Mehndi Ratha is coming.
Or Dr. Gaba.
Can I speak for 2 minutes?
Yes, sir.
Yes, sir.
Like, okay, I think it is very nice suggestion. It is desirable that all our state members should be central IAP members. However, any person can become a central IAP member directly. There is nothing that the state has to send the membership to the central IAP. So anybody can become central IAP member directly, not necessarily a state member. And the same thing is true for the state membership also. Anybody can become a state member without becoming a central IAP member. This is how it has been happening. So it is not possible that all the people who are already state IAP member but they are not central IAP member, you can request them certainly, but if they do not become, you cannot force them. That is not possible. That is one thing. In future, if you want, you can do that, but please try to find out from other states also. All other states are doing the same thing. All other chapters are doing the same thing. If not, then only why Delhi? If everybody say in many chapters, there are people who are not central IAP member, but they are still member of that particular IAP chapter. So things should be uniform. So if it is so, then I think central IAP should amend like this, that every application from the state will come through the state branch. And once that is so, then automatically the person will become a state branch IAP member, central IAP member, and the money will also come back from central IAP to the state IAP. But that is not happening basically.
It should
The
be like
central IAP is making members directly, state branches are making members directly, and even city branches are making members directly. So this is what is the present situation. So I think
this
things
can
from
be
that
given by
context.
CIAP members to CIAP main office.
Hello? Hello?
CIAP members can give this information in CIAP meeting and tell
Yeah,
them.
already given, sir. Already we have raised this issue, and it will be done, I think.
But is
So if that is so,
it
Dr.
has
Rabha, if
already
that
been
is so,
raised
then
this time.
then I think all the problems will be sorted out. That is so.
Yeah,
That
yeah,
all
yeah.
members who are coming from state, they should get their application.
It will be
forwarded to the state.
three-tier system, city, state, and center.
Correct. If that is so, then it will be smooth.
Yeah, you can enter through any channel. You can enter, and you will be automatically member of CIAP.
Sir, till
Yes,
that time,
so that will be smooth then.
non-central IAP pediatrician should only be associate members of Delhi IAP.
I agree with that. I agree with Dr. Ajay is saying, what Dr. Ajay is saying. They should not have voting right.
They should not.
Those
मैं ये कह रही हूँ सर, मेरा एक छोटा सा सजेशन है, बिकॉज ये थोड़ा कॉन्स्टिट्यूशन की भी बात आ जाती है इस तरह का कोई भी रूलिंग लाने में, तो जो हमारे पास अभी कॉन्स्टिट्यूशन कमेटी है, दे कुन जब अभी 7 दिन का टाइम है, तो दे कैन गेदर information from Rajasthan, from other wherever their friends are, how they are doing. If they are
how other states are doing, that is what I'm saying. What is the status of the other states?
Committee sir, आप ही तो head है ना?
No, Dr. Vasudev is heading the committee, reforms committee, and I think he will take up.
Sir,
Dr. Vasudev.
Lead and become the first state to do this. I follow others.
Yeah.
Delhi is the leader always.
No, not. Say it is not a question, Dr. Agarwal. It is not a question of leader, not leader. What I am saying is that it should be uniform. See, it is not that tomorrow you are the only one who are stuck up, and then everybody is trying to say, but then central IP may say that we are accepting directly as well. It is not necessary. Your state might have made this rule, but the central IP does not have that rule. So they will accept directly as well. Somebody will send directly and they will not say no. So that should not happen. It should be that from the central IAP.
Should come from the center only.
The forms will be accepted only through state IAP. Then only it will be possible.
Sir, that I
नहीं तो अगर इतना कंपलसरी है ना सर, तो फिर ये हो कि सेंट्रल आईएपी का अगर 10,000 का वो है, मतलब फी है, तो 20% should go to state and then automatically you are member of.
वो है लेकिन
पैसा नहीं आ रहा है.
आया है पैसा. Yes,
सर नहीं आ रहा भाई.
वो इसलिए नहीं आया सर, हमने उनको.
Dr. Gaba is also.
डॉक्टर लास्ट मीटिंग में हमने जब मेंबर बनाए थे तो हमने दिल्ली स्टेट फ्री ऑफर की थी उसको.
Central IAP is not giving any money to
Delhi.
Delhi.
आता है
पैसा आता है, पहले आता था, अब नहीं आ रहा है.
बात तो
है पेंडिंग विद द सेंट्रल आईएपी भाई.
डॉक्टर तुम्हारी लेकिन अभी इस साल में या पिछले साल में पैसा आया क्या, ये बता दें.
जो मेंबर आया था मेरे टाइम पे 2016 में आया था.
अनुराग 16 को 4 साल हो गए.
सर तो उसके बाद उनके फाइनेंसेस अटके हुए हैं ना, बिकॉज ऑफ कॉन्फ्रेंस, इसलिए उन्होंने पैसा नहीं दिया.
जो भी कारण है, लेकिन
Sir, if you read the financial statement, we have received 15,000 rupees from Central IAP as membership contribution. We have received this year also.
है ना, आ रहा है सर.
15,264.
Dr. Smita,
CIP.
Central IAP contribution for the membership.
Yes.
इसका मतलब ये हुआ.
नहीं, एक मिनट, अगर मान लो यहाँ से हमने एक मेंबर बनाया, जस्ट वांट टू अंडरस्टैंड, आई डोंट नो, कि अगर हमने मेंबर बनाया, मैं मेंबर बनी सेंट्रल आईएपी की, तो ऑटोमेटिकली आई विल बिकम दिल्ली आईएपी मेंबर. दिल्ली आईएपी विल गेट मनी.
Yes.
No.
सिटी के भी.
No.
अभी नहीं है सर ये रूल. अलग बनना पड़ता है.
पर आईएमए का भी यही रूल है. it is the 3-tier system.
ऐसा कोई रूल नहीं है अभी.
That should be same.
अभी ऐसा
That
कोई
should
रूल
be
नहीं है, आपको
adopted in
DO का
IAP.
member अलग से बनना पड़ेगा.
3-tier system है.
नहीं, what I am saying this कि अगर इतना ही कंपलसरी है कि सेंट्रल और दिल्ली आईएपी दोनों मेंबरशिप लेनी है, तो why not to pay for central IAP and percentage of it comes back to Delhi IAP and you become member.
यही होना चाहिए, ऑटोमेटिक होना चाहिए, ऑटोमेटिक 3-tier system.
Dr. Nab, can I make a comment, Dr. Nab?
1,000 rupees comes back.
Dr. Nab, I think just give me 1 minute. Just give me 1 minute. I'll just clarify it. Dr. Smita, anybody, देखो हमारा दिल्ली में रूल है कि anybody who becomes member of the central IAP pays to every state or every branch who makes that member. That is very clear. That's number one. Number two, in Delhi, last 2-3 years, we have been encouraging that whoever becomes the member of the central IAP, we will give them the Delhi IAP membership complimentary, because some amount is already coming from the central IAP to us, and we are charging only 1,000 rupees, so we can compensate for that. We will have a dual membership, like somebody who goes to central IAP pays 10,000, automatically becomes the member of Delhi IAP also. He has the voting right in center as well as Delhi. But there are few members. So there are few members who have already become members of the Delhi IAP without becoming the central IAP members. We can only persuade them कि आप central IAP बन जाइए. We can't force them. Number one. Number two, if we continue this sort of a practice that आप central IAP member बनिए and Delhi IAP will give complimentary, will have dual advantage. Delhi IAP का भी member बनेगा और central IAP का voting member भी बनेगा. So our strength is going to increase. And that policy next year, Dr. Mehndi Ratta and Dr. Manish Gupta and the team can continue. And it is not mandatory, but if we propose that you become central IAP member, Delhi IAP membership comes free to you, I'm sure that members will be lured by it. But as a rule, if they are not members of central IAP, they are not entitled to take the advantages and all the perks and things of the central IAP.
Yes, that's what I'm saying.
That we know.
Sir, we did that because we wanted
sir,
free
I
seat
want
for
to
EB.
make a statement.
In Delhi IAP, there are branches. There are
Sir,
people
हमने
who are not members of central IAP.
I want to clarify on that, sir. When we offered free membership, we wanted 3 EB seats.
Yes.
That is when we offered that.
That is the reason we started off 2016 के अंदर to get the third EB seat. And that is the reason we got 50-60 members. We gave them
Yeah, and in my time also we got 50-60 and made it into more than 1,300.
Delhi membership.
And 16-17 में पैसा भी आया था, फिर वो कुछ पेडिकॉन के फंड्स का इशू था, वो सेटल हुआ है, तो जब अजय आया फिर आया है पैसा.
हाँ, yes, that is
Let
right.
me make a statement about this year's money, please.
Lot of money pending with the CIAP.
Excuse me. As a treasurer IAP Delhi, let me make a statement, please.
Yes.
This year we have got 15,000 rupees from CIAP. 500 rupees per member we are getting. In 2020, we have got 15,000 rupees from CIAP for all the members who have become CIAP members.
Yes.
Okay.
So how many members were there, Manish?
Okay. Numbers you can calculate it. If you get 15,000,
2,000 or 1,000.
you can
How much they are
calculate.
giving?
CIAP की फी कितनी है अभी मनीष?
10,000.
What about madam? I just had a talk with IAP Delhi office. We have got 15,000 rupees this year, 500 rupees per member.
You didn't get.
That is
मतलब मेरी बात नहीं
people, no?
समझे. मैं ये नहीं कह रही हूँ. मैं ये कह रही हूँ तो क्या मेंबरशिप पर उसके बेसिस पे हमें मेरा ये कहना है कि जैसे तुमने अगर हमने एक जमा किया उसके लिए सेंट्रल आईएपी के लिए.
I think all people are here. डॉक्टर वासुदेव का ये आइडिया ठीक है. दिल्ली आईएपी को 1,000-1,500 रुपए एक्स्ट्रा मिले दिल्ली आईएपी मेंबर बनने से. That is not important. It is important कि हमारा मेंबर सीधा सीआईएपी मेंबर बने 10-15 हजार दे के और हमारा भी मेंबर ऑटोमेटिकली बन जाए. And whether constitutional amendment to be done or all GPM to be passed, we can discuss that.
But 500 is nothing.
500 rupees में you are going to give.
तो आप 1,000 रुपए में तो बना रहे हो मेंबर.
No.
500 rupees में
आपकी इनकम मेंबरशिप फीस से एक वेरी स्मॉल अमाउंट. सर डॉक्टर वासुदेव जो कह रहे हैं उस बात को समझो सर.
नहीं डॉक्टर मनीष आप ठीक कह रहे हो, लेकिन डॉक्टर स्मिता जो कह रही है कि अब कॉन्स्टिट्यूशनल अमेंडमेंट कमेटी में ये अमेंडमेंट भेज दो, बात हो जाएगी. अब इसको आगे बढ़ाओ या जीबी
आगे बढ़ाओ. वही मैं भी कह रही हूं. ठीक है.
नहीं, बट आई वांट टू से
आंसर नहीं आया कि वोटिंग राइट का क्या होगा अभी. इस वक्त?
चलिए कॉन्स्टिट्यूशन
वो भी कॉन्स्टिट्यूशनल कमेटी में डिसाइड होगा।
अभी तो जो ऑलरेडी कॉन्स्टिट्यूशन है वैसे ही वोटिंग राइट होगा, अभी कैसे चेंज कर सकता है अनुराग?
बस ठीक है,
अभी नहीं कर सकते।
क्लैरिटी आ जाए ना कि दे आर ऑल वोटिंग मेंबर्स।
Yes,
Yes. After deliberation of annual.
और IAP Delhi. On this issue, I'll clarify one thing कि अभी जो आपने बोला कि अगर कोई आपका इलेक्शन डिस्प्यूट हो जाता है एंड इफ इट गोज टू सेंट्रल IAP फॉर एडजजिंग एंड उसमें ये प्रूव होता है कि जो सेंट्रल IAP के मेंबर नहीं है और उन्होंने वोट दिया है तो इलेक्शन नल एंड वॉइड हो जाएगा एज पर CIAP रूलिंग।
सर सेंट्रल IAP में नहीं जाएगा, हमारे कॉन्स्टिट्यूशन के हिसाब से
सर
हमारा कॉन्स्टिट्यूशन डिफरेंट है,
हमारे कॉन्स्टिट्यूशन से चलेंगे ना।
हम तो अपने कॉन्स्टिट्यूशन से चलेंगे, सेंट्रल IAP में क्यों जाएगा?
Sir, who will force
जाएगा?
us? Who can't force us? Who can force?
नहीं, हमारा
होगा तो इलेक्शन
हमारा कॉन्स्टिट्यूशन हमारी सोसाइटी है।
सेंट्रल
डॉक्टर
IAP
भंडारी
कोई डायरेक्ट अथॉरिटी नहीं है हमारे कॉन्स्टिट्यूशन में।
नहीं, हाँ, यस, आई एग्री विद डॉक्टर गौतम।
सेंट्रल IAP को एक अथॉरिटी है कि वो अपनी एफिलिएशन वापस ले सकती है अगर हम उनके कॉन्स्टिट्यूशन से ना चले तो।
ना चले, यस एग्जैक्टली।
सर एक बात बताइए, अभी जिस कैंडिडेट ने इलेक्शन लूज किया उसने सेंट्रल IAP को कंप्लेंट लिख के भेजी कि इलेक्शन फर्जी है। अब मान लो दिल्ली IAP के इलेक्शन के अंदर कुछ प्रॉब्लम हुई, उसने सेंट्रल IAP को कंप्लेंट डाल दी कि इलेक्शन में फर्जीवाड़ा हुआ, फिर क्या होगा?
नहीं तो सेंट्रल IAP हमारी अथॉरिटी नहीं है भाई। सेंट्रल IAP कैन नॉट इंटरफेयर।
एनओसी जो मिला
लूजिंग कैंडिडेट की इच्छा है डालने को लिख के, एक मेल तो डालनी है, कितना खर्चा आता है?
अरे लिखने को चाहे तुम प्रेसिडेंट ऑफ इंडिया को लिख दो यार, उसमें क्या फर्क पड़ रहा है?
They will check the authenticity of complaint ना।
They will not interfere. डॉक्टर अनुराग
नो डायरेक्ट ज्यूरिडिक्शन भाई,
आता है
उनका
ना,
ज्यूरिडिक्शन ही नहीं है।
जो उनका NOC आता है ना,
office bearers to clarify.
Let me clarify this.
उनका जो NOC आता है उसमें ये लिखा होता है कि यू विल मेक ए कॉन्स्टिट्यूशन इन द लेटर एंड स्पिरिट ऑफ CIAP, बस। उसके अलावा मेंबरशिप का क्राइटेरिया बनाया हुआ है ना कुछ और बनाया हुआ है।
दिनेश, लेट मी एक्सप्लेन यू, ये पॉसिबल है। अभी देखो वेस्ट बंगाल के इलेक्शंस जो है हम लोगों ने होल्ड कर दिए एज ऑफिस बेयरर्स ऑफ सेंट्रल IAP। रीजन वाज देयर वाज अ कंप्लेंट फ्रॉम वेस्ट बंगाल दैट देयर हैज बीन सम प्रॉब्लम विद द इलेक्शन। 103 वोटर्स आर फेक वोटर्स, दे आर नॉट एक्चुअली मेंबर्स, और उसकी वजह से वेस्ट बंगाल के इलेक्शन सेंट्रल IAP ने होल्ड कर दी हैं।
तो मैंने प्रीएम्प्ट कर दिया ना।
सेंट्रल IAP के बोल रहे हो तुम?
हाँ हाँ
वासुदेव, तुम सेंट्रल IAP के बोल रहे हो, स्टेट IAP की बात करो ना।
सेंट्रल IAP कैन इंटरवीन because there was
अगर इलेक्शन प्रोसेस में ही गलत है, पर अगर इलेक्शन प्रोसेस कॉन्स्टिट्यूशन के हिसाब से गया है फिर वो इंटरवीन नहीं करेंगे ना।
Sir, what I'm trying to say that if there is some problem and somebody makes a complaint from state, the center can intervene and the central IAP can intervene.
They can intervene. अगर इलेक्शन प्रोसेस नॉर्म्स में नहीं हुआ है,
we have separate constitution. There central IAP has no jurisdiction over the Delhi IAP.
Sir, we are under the
affiliation.
डॉक्टर दीपक वो they can intervene, लेकिन अगर आपके कॉन्स्टिट्यूशन में आप अपने कॉन्स्टिट्यूशन को ही नहीं मान रहे हो तो they can intervene.
They cannot intervene. Yeah, they can simply withdraw their affiliation. Yes. They can take away their affiliation. Otherwise, there is nothing.
Dr. Gautam, Dr. Vasudev, or Dr. Tamaria, or everyone. I want to say one thing, because still we are in the process of changing our constitution or reforming our
constitution. That is what I am saying. आप अब आगे बढ़ाओ इस GBM को।
तो इसलिए ये चीजें जो पॉइंट्स उठ गए हैं वो उसमें सेटल होंगे, है ना?
डॉक्टर मनीष, आप ये सारे पॉइंट्स लिख लो, we'll discuss in the constitutional review committee.
हाँ
सर मेल पे भेजो, डॉक्टर अजय मेल पे भेजो जिसके दिमाग में आ रहा है। आप सबको मेल जाएगी कल सुबह।
डॉक्टर अजय, times have changed, everything is being recorded on the Zoom. I will just review the Zoom recording.
Statutory thing, and आप against the constitution नहीं जा सकते, जो दिल्ली IAP का constitution है।
बिल्कुल सही कह रहे हो मित्र सर, बिल्कुल सही कह रहे हो। Absolutely correct.
डॉक्टर मित्तल, आपको जो चीज सही लगती है वो लिखिए कॉन्स्टिट्यूशन कमेटी को। कॉन्स्टिट्यूशन कमेटी उसको एक्सेप्ट और रिजेक्ट करेगी पूरे पॉइंट्स देख के।
डॉक्टर
मैडम अब आगे बढ़ाओ।
जो भी है फॉरेन अगेंस्ट वो हम नहीं लिखेंगे, वो आप अपने लेटर में लिखिए।
Please go to the next point. Please go to the next point.
स्मिता, प्लीज फॉरवर्ड करो।
हाँ जी बोलिए।
कॉन्स्टिट्यूशन का तो पता नहीं, तलाक का
हाँ
केस
जी,
लग
आप
जाएगा
आगे
मैडम,
बढ़िए
संडे
सर,
आगे करो।
क्लोज करिए इसको।
संडे हो गया
मैं तो
खत्म
यही
अब।
चाहती हूँ आगे बढ़ा जाए।
हाँ, तलाक
सर
का केस
इसके
लग
आगे
जाएगा,
और भी कुछ
ICC
प्रॉब्लम
आगे
है
पता नहीं।
सर। Adoption of audit statement account for the year 2018-2019. The audit report of the year 2018.
कहाँ पे मैडम रिपोर्ट?
रोहित शेयर करो
यार, रिपोर्ट तो 15 दिन पहले आनी चाहिए।
I agree with that. Report should come 15 days before. 1 मिनट में कौन रिपोर्ट देख
डाला हुआ,
पाएगा?
ठीक
इतने
है।
अच्छे एक्सपर्ट्स अगर हम होते हैं, चार्टर्ड अकाउंटेंट बन जाते हैं।
भेजा हुआ है यार।
चलो फिर पास है आगे।
नहीं पास नहीं है, रिपोर्ट देखो तो सही।
हाँ देखो ना भाई,
तो रिपोर्ट आई कहाँ है, कहाँ
आई
देखो?
कहाँ है रिपोर्ट?
वेबसाइट पे है।
हाँ?
वेबसाइट पे देखो भाई, वेबसाइट पे
सर,
पढ़िए।
वेबसाइट
मेल पे
थोड़ी ना
आती है
मेल
ये।
पे
वेबसाइट
कौन देख रहा है?
वेबसाइट क्या कोई इंटीमेशन है कि वेबसाइट पे है रिपोर्ट?
ऑडिट रिपोर्ट हमें भेजिए भाई।
किसको भेजिए?
किसको भेजिए मैडम?
And it is available on Delhi website also.
मैसेज आया,
हम लोगों
उसमें
ने
लिंक
पहले
था
भेज दी
उसका।
थी।
इट इज ऑलरेडी
मेल पे नहीं आया। किसको आया मेल पे भाई बता दो।
नहीं, मैसेज SMS
हमें
आया
तो
था,
नहीं आया,
उसके अंदर
हमें
लिंक
नहीं
था।
नहीं आया भाई।
मुझे भी नहीं आया।
SMS के ऊपर लिंक
कहीं
था।
लिखा था कि ऑडिट रिपोर्ट
कौन सा SMS? मेरे को भी आया था।
लास्ट ईयर भी ऐसे ही बोला गया था कि भेज दिए। बाद में कहा मैंने
अरे
आपको सबको लिंक भेजा गया है, वेबसाइट में
मेल
अपलोडेड
भेजा,
है।
उसमें लिंक है।
You can,
चलो ठीक है मैडम, पास
Dr.
करो।
Smita,
चलो
you can just brief.
नहीं
ब्रीफ
you
कर
want
दो
to
ना
see
क्या?
it physically है ना, डिस्कस इट। ऐसे कैसे ऑडिट रिपोर्ट पास हो जाएगी यार?
ये पास नहीं, ब्रीफ तो कर दें एक बार।
ब्रीफ तो करें, यहाँ पे डिस्प्ले तो करें। कहाँ है ऑडिट रिपोर्ट?
वही कर रहे
तो
हैं।
इसको भी पोस्टपोन करें मतलब।
नहीं
अगले पे चलो।
वेबसाइट पे लिंक किसने भेजा था? इसकी मेल पे आया है लिंक?
हाँ सुशील ने भेजा हुआ है
आया
भाई,
ना?
हमने उस पर
कोई
बहुत
लिंक
ज्यादा
नहीं आया
बात करी थी।
मैं कंप्यूटर खोल
मुझे
के
भी नहीं
बैठा
आया।
हूँ, कब आया है? उस पर लिखा है
मुझे भी नहीं आया, नहीं आया।
कोई लिंक नहीं आया
सुशील तो
मैडम।
कह रहा है कि भेजो। सुशील,
कौन सी मेल पे आया है मैडम?
से बात करो।
सुशील, सुशील प्लीज तुम ज्वाइन करो और उनको बताओ कि तुमने कब भेजी है। They are
ऑडिट
saying-
रिपोर्ट कब भेजी? मैं तो कंप्यूटर पे बैठा हूँ, बता दूं, मैं खोल लेता हूँ।
ज्वाइन करो और बोलो, क्योंकि हम लोगों ने इतनी बार तुम्हें बोला है।
ऑफिशियली
अनुराग ने बोल दिया तो मैम नहीं आई।
1 month
अनुराग तो पूरा दिन कंप्यूटर पे ही होता है।
और क्या?
बोला जा रहा था।
हेलो
सुशील, एनुअल रिपोर्ट वो कहाँ है?
लिंक है ना सर, जो कल भी SMS भेजा है, परसों भी भेजा है, आज भी भेजा है सुबह।
ऑडिट रिपोर्ट।
हाँ वो
Audit
लिंक
report का
भेजा
कब
है
आया?
जिसमें लिखा कि डिटेल्स आर अवेलेबल ऑन।
अरे हफ्ते पहले भेजा, 7 डेज पहले।
नहीं 3 तारीख को तो बनी है
तो
सर।
फिर बात ही खत्म हो गई।
अभी कहाँ
तो
पर है?
बात ही
बता
खत्म
तो
हो गई
दे।
ना यार।
ये लिंक है सर, आप अपने SMS में देखो, एक लिंक है उसमें।
अरे कल भी भेज दिया तो कोई बात नहीं। चल ठीक है, खत्म कर। 7 दिन पहले भेजना होता है, तुझे पता ही है बात।
हाँ सर 3 तारीख को तो रिपोर्ट
हाँ तो
प्रिपेयर हुई।
फिर आप तो हम सही तो कह रहे हैं फिर। हर बात पे लड़ क्यों रहे हो यार?
एक्चुअली
चलो पास करो और खत्म करो।
सर देखो तो सही रिपोर्ट को, पास कैसे कर दो?
अनुराग के पास भेज दो इधर।
लेटर सीधी स्टेटमेंट, ऐसे कैसे पास कर दो? फायदा क्या है? ऐसे ही पास मारना और चीज को जीबीएम की जरूरत क्या है?
डॉक्टर
जीबीएम कर लो फिर।
Yes, मैं कर रही हूँ।
The link has come yesterday.
शेयर कर दो, स्क्रीन शेयर कर दो।
7-page report, 6-page report. The link has come yesterday only. Normally it should be sent at least 1 week in advance. If people want more time, just give them 1 week and एक हफ्ते बाद जो है फिर दोबारा से आप लिंक लेके दोबारा कर लीजिए. Let people be satisfied. Doesn't matter.
ठीक है, ठीक है सर।
बिल्कुल।
That
कॉन्स्टिट्यूशन और
is
इसको दोनों को
better.
साथ कर लीजिए।
Dr. Smita,
done,
only
done.
one thing you can do this, but I just want to know the main issue of that income tax. Basically, what is the latest status? Because we have many committee members.
We have
Actually, Neetu is there.
Just that is a very important issue for us because
Neetu,
the latest
Neetu
situation.
is there, sir.
Yes, of course, of course will be followed in, but this is an important issue. I think we should discuss it. Just
Neetu,
this.
Neetu.
Now, if you can just highlight what is the latest status.
Just a minute. Neetu, we have brought CA along with, she was here with us till 6, and she was
अच्छा
there.
अभी चली गई हुई है, वो यहीं पे थी एक्चुअली।
बट बता दीजिए सर,
पता होगा ना क्या हुआ है?
ऑपरेशन के लिए आए थे।
कोई नहीं, डॉक्टर तमारिया स्टेटस बता देंगे। डॉक्टर तमारिया इज ए चेयरमैन, सर विल एक्सप्लेन नो इशू।
डॉक्टर तमारिया
बताता हूँ।
We received a notice again last month, and it has been replied. It is awaiting. We are waiting for the income tax to give us date and hearing. That's
Yeah.
the latest.
And they are pursuing the matter. The process is on, but it is slow because of COVID.
So I think just one thing to comment here, because this is going to be, this issue is going to continue because this matter has gone to into
because of unprecedented time.
So the committee, please listen.
Let Dr. Lalit please say that Dr. Lalit please say, please.
Sir, let me clarify, sir.
6 lakhs. They have revised our assessment and they reduced some amount. I think 3 lakh or 6 lakh.
5 lakhs
they have done this.
5 lakhs.
5 lakhs.
Dr. Lalit,
reduced.
So
and possibly will go
that
on.
was, I think, the amount paid to them.
Yes. Sorry.
Sir, my only thing is that this issue will take some time because next year may pass, the team may come. So this committee should be always be there with you being the chairman, and let the new president, as soon as it comes, will is part of that committee. Next year somebody.
Yes, definitely.
So this process should continue because it is our joint responsibility and it is an important issue. That's why I want to know the latest.
Agree.
Doctor, agree with this? Dr. Nab, you agree with
this? Yes.
And anybody else who disagrees with this? Anybody?
No, we all are agree, but
We are with you, sir, always.
We all agree, but Dr. Manish and Dr. Lalit, GBM ही ऐसी जगह है जहाँ पे ये privilege खत्म हो जाता है ऑफिस बेरर का, किस तरह वही बोलेंगे?
नहीं, but सर अब virtually कर सकते हैं ना अभी तो?
नहीं, ये वाला point दीपक very important ना.
मैं go ahead.
Anybody may come next year, so he will ask me, what is the latest? So Dr. Lalit, what is the latest? का क्या हुआ?
Sir, you are taking over as president. Manish will be.
It will take one more year.
That is the latest.
पता नहीं कितने साल लगेंगे.
सर मैं लास्ट ईयर की और मैं इस साल की ऑडिट रिपोर्ट देख रहा था
उसके
देखो
डॉक्टर ललित उसके बाद
एक मिनट ऑडिट रिपोर्ट हैज टू बी डिस्कस्ड
डॉक्टर ललित उसके बाद मेरे से भी पूछेंगे मैं बन रहा हूँ ना आपके बाद प्रेसिडेंट
ओ कांग्रेचुलेशन
बिल्कुल दीपक आई एम सीइंग द ऑडिट रिपोर्ट ऑफ दिस ईयर इसमें
Anurag, just one comment. Whatever Dr. Lalit Mandirata has said, this should be documented in minutes of meeting of this GBM.
Yes.
It is very important.
Everything
which it has to be minuted.
As a member. As by name.
Yeah. Thank you, ma'am. Okay, ma'am.
Dr. Yadav. Namaste, madam.
President sir, I want to make a comment on the audit report. I want to make a comment on the audit report. President, last year का जो expenditure है, it has exceeded 1,34,000 from the income, including the interest on FDs and rental income, जो मुझे समझ में आ रहा है 3 मिनट में देखने में. ये क्या मैं सही बोल रहा हूँ, गलत बोल रहा हूँ?
कितनी कमाई हुई है? अनुराग कमाई
कम हुआ है. इनकम
नहीं, डेफिसिट है.
1,34,000 का डेफिसिट है. माइनस
Anurag, this is not deficit. We will yet to get 3 lakhs, 4 lakh, about 5 lakhs still from the income tax as a TDS return. Right? So that we have 4 lakh positive.
Around 22 lakhs.
The Delhi government money came later. Delhi government money for the delegates of PCNI came later, and one GSK consumables also paid in this year.
So what I am getting to understand is कि 4-5 lakhs आने हैं जो कि इस साल में शायद आएंगे, but 22-21 लाख रुपए FD के भी इसी में स्पेंड हो गए हैं, यानी कि 19 लाख 96,000, 37,000, 67,000. This has all been included in the income. Even the rental income has been included in the income. वो सब खर्च कर दिया गया है. उसके ऊपर 1,34,000 का नुकसान है. 4 लाख में भी वापस आने वाले हैं.
चलो, ultimately it is positive. I think it is positive. Ultimately we are gaining.
Sir, we are not gaining. हम FD का इंटरेस्ट भी खर्च कर चुके हैं.
We cannot save more than 15% as per the.
15% तो सेव करो 5 करोड़ पे सर. 5 करोड़ 15.
सर हो गए ना. आज 4 लाख आपको आ रहे हैं अभी.
So 15% कितना होता है सर? कितना है हमारा
ज्यादा नहीं कर सकते.
60 लाख
60 लाख कॉर्पस नहीं है हमारे. 3-4 करोड़ रुपए एफडी में.
75 लाख नो कहाँ है हमारा? 3-4 नहीं है.
अराउंड 4 करोड़ रुपए होने चाहिए एफडी में मेरे हिसाब से। आई कुड बी रॉन्ग अगेन।
2 करोड़ रुपए फिक्स्ड एसेट है, दैट इज प्रॉपर्टी वैल्यू, और 2 करोड़ की एफडीज है।
कितने की
मनीष just tell-
मनीष?
2 करोड़ की एफडीज है और 2 करोड़ के फिक्स्ड एसेट है।
एफडी 2 करोड़ की है।
तो
2
कितना
करोड़
इंटरेस्ट आ
15
गया?
लाख 30 लाख तो यही हो गया सर, 15% के हिसाब से, और साथ में फिक्स एसेट्स भी हैं।
I think Manish, you need to recheck. Manish, you need to recheck. हमने 2.25 करोड़ रुपए तो पेडिकॉन से दिया था जो
Yes, sir. Yes,
सर,
वही तो
I may be wrong सर, जो मैंने असेस किया था उसमें मेरे को ये था।
पहले भी एफडीज थे और 2.35 CR जो हमने एफडीज करा के वो पेडिकॉन से दिए थे।
maybe what I could see।
ज्यादा होनी चाहिए।
जो भी है तो स्टेटमेंट में ना सर आएगा, तो स्टेटमेंट में ही आएगा ना।
तो सर स्टेटमेंट पढ़ो ना, आप स्टेटमेंट पढ़ने को कोई तैयार नहीं हो, कह रहे पास करो पास करो।
नहीं पास नहीं, तो आप पढ़ो।
पास करो आप। नेक्स्ट जीबीएम बुला रहे हैं ना भाई?
कब बुला रहे हैं नेक्स्ट जीबीएम?
एक तो हो गया
भाई, डिसाइड तो किया था, 1 हफ्ते बाद बुलाएंगे।
2 करोड़ 86 लाख है, 2 करोड़ 86 लाख की एफडी है
सर, 286
कितना?
2 करोड़ 86 लाख की एफडी है आईएपी दिल्ली की।
एंड हाउ मच इज द इनकम आउट ऑफ दैट?
उसमें इनकम हुई 21 लाख रुपए अप्रोक्सीमेटली। एफडी पे ब्याज आया है, वो ब्याज भी हमने स्पेंड कर दिया है लास्ट ईयर। एटलीस्ट ब्याज तो हमें स्पेंड नहीं करना चाहिए, बेसिकली वो डेप्रिसिएशन ही अगर मोटे तौर पे देखा जाए तो
1 लाख का घाटा है तुम्हारे हिसाब से?
1 लाख का नहीं है सर, 20 लाख का घाटा है। हमने एफडी का ब्याज भी खर्च कर दिया है।
कर लूंगा।
और हमारी जो
तो करना है भाई इनकम को।
एनी कमेंट फ्रॉम
रख नहीं सकते।
डॉक्टर स्मिता, एनी कमेंट?
डॉक्टर स्मिता का नहीं है, उससे पहले वाली टर्म का है ना।
सर हमारे
31 मार्च तक का हिसाब है।
डॉक्टर स्मिता ही तो ट्रेजरर थी।
डॉक्टर स्मिता ट्रेजरर थी।
डॉक्टर स्मिता ही तो ट्रेजरर थी तब। लेकिन यार ऐसा है कि खर्चा तो होता ही है, अब क्या हो गया?
ट्रेजरर के आदमी को जो था
घर में थोड़ी ले गया।
एसोसिएशन से खा रहे हैं, दे नहीं रहे।
डॉक्टर
कोई नहीं खा रहा यार, कोई नहीं खा रहा।
घर में नहीं लेके गया,
कोई घर थोड़ी ले गया।
लेकिन
होना चाहिए,
मतलब पैर उतने पसारने की बड़ी चादर हो।
अनुराग क्या मतलब कोई एक्टिविटी
डॉक्टर अनुराग
पैसा बचा के सेव कर दें
सर। चादर उतनी हो क्या, पैर उतने पसारने की इतनी बड़ी चादर?
अरे तो चादर क्या करेगी जब इनकम ही नहीं आएगी? तो रखा हुआ खर्च होता है।
एक्सपेंसेस पहले प्लान हो गए थे, द इनकम वाज लिटिल लेस। एक्सपेंसेस पहले से प्लान हो गए थे,
खर्च होगा ही।
अजय यू कैन से
आगे जो हुआ सो हुआ, पर आगे हमेशा के लिए होना चाहिए कि भाई जो इनकम है उतना ही खर्च हो।
एग्जैक्टली, ये पिछले 2-3 साल से ये ट्रेंड हो गया है कि एफडी कम खर्च कर रहे हैं।
नहीं, पॉजिटिव भी हो सकता है दिनेश।
अरे यार
पहले हमें लग रहा है 10 साल बाद 2 करोड़ रुपए की कोई वैल्यू नहीं होगी।
अरे दिनेश, इनकम गारंटेड थोड़ी है। इनकम आप पहले स्पेकुलेशन करते हैं,
प्लानिंग तो होती है सर, हर जगह हम अपने बिजनेस में भी कर रहे हैं।
डॉक्टर दीपक, आप ना 20-22 लाख रुपए डेफिसिट में नहीं जाते हो, 1,50,000 चाह सकते हो कोई बात नहीं, बट 20-22 लाख।
चल ठीक है यार, मेरे से
अनुराग, छोटी कॉन्फ्रेंस को मैनेज करना और बड़ी कॉन्फ्रेंस को मैनेज करना
जरूरी नहीं है कि 5 स्टार में कॉन्फ्रेंस करें। हम कॉन्फ्रेंस थोड़ी छोटी जगह भी कर सकते हैं, ऐसा कहीं लिखा तो है एकेडमिक में।
तो फिर करने भी क्या जरूरी है?
करने की क्या जरूरत है? बात बताइए।
कोई जरूरी नहीं है, हमारा एनुअल डे होगा तो 10 साल से
करने की भी क्या जरूरत है? खत्म करो।
देखो
इस लाख के लिए खड़ा था, मेरे को आधे लोगों ने पूछा कि कॉन्फ्रेंस करना भी क्यों करते हो? व्हाई डू यू वांट टू डू इट?
सर ऐसा है,
करना ही क्यों है?
सर मैं बात
पैसे को नहीं होना चाहिए सर।
हर कोशिश ये करनी चाहिए कि हर इवेंट अपने आप में सेल्फ सफिशिएंट हो।
वेरी गुड,
100% एग्रीड।
और
प्लस में हो, प्लस में।
रियल ऑर्गेनाइजेशन वो है जो हर इवेंट से कुछ कमा के एसोसिएशन को दे दे।
वेरी गुड,
अगर हम ऑफिस बीरर बने हैं, ईबी बने हैं, तो हमारे मकसद है कि जहां से हमने बैलेंस शीट ली है
उसको कुछ देके जाए,
10-15% देके जानी है हमें।
वेरी गुड, एग्री।
हमारे लिए इतना कुछ किया है, अब हम उसको स्पेंड करेंगे।
लेट मी कंप्लीट। वी आर कस्टोडियंस ऑफ दिस मनी।
यस,
ठीक है, वी आर कस्टोडियंस ऑफ दिस मनी। हम सिर्फ उसको रक्षा कर सकते हैं, उसको बढ़ा सकते हैं, उसको कम करने का हमारा कोई अधिकार नहीं है।
अग्रीड,
वेरी गुड, वेरी गुड, वेरी गुड,
वेरी गुड।
दैट इज व्हाट आई एम ट्राइंग टू से।
ये ना कॉन्स्टिट्यूशन अमेंडमेंट में आना
वेरी
चाहिए।
गुड, अनुराग के में भी
मैं ये कहना चाह रहा हूँ यार, बनिया आदमी हो, अग्रवाल सरनेम में आप खर्च करे जा रहे हो। बनिया वो प्याज से खाता है,
मेरी बात
तो बचा के
वो बनिया नहीं है।
कहना मैंडेटरी होना चाहिए, कॉन्स्टिट्यूशन में होना चाहिए।
बनिया नहीं है।
ये पॉइंट बहुत अच्छा रेज किया है कि हर प्रोग्राम सेल्फ सफिशिएंट हो. We should always try that. Yes.
मेरी एक बात सुनो.
नहीं 20 लाख का नुकसान है.
Dr. Anurag, I object. No casteism here, please. Dr. Anurag, I object. No casteism here, please.
अच्छा, एक चीज मैं कहना चाहूंगा.
बनिए, हमारी तरह बनिए.
Dr. Anurag Ek and other people, just one thing, it depends on the situation, you know, like it's going on a quarantine.
Right, Ajay, no
able to earn
casteism.
revenues. Then second, Mukesh is saying
नो सर, इस साल आपको कोई वो नहीं मिलेगी डेफिशिएट. आपको अभी करना है.
आप गलतफहमी में मत रहना कि आप नुकसान लगा के जाओगे. मैं नोट करवा रहा हूँ, जीबीएम के मिनट्स में नोट किया जाए.
हम गोल्डन टाइम
नुकसान लगा था, इस साल के प्रेसिडेंट को बताया
नहीं होगा. Just listen to me.
I am just
Anurag, do you really think me and Dr. Lalit can give you losses? You would remember the lifetime profits this year. Just note my 10 minutes. You are going to have lifetime profits.
बना देते हम. इसका एक रूल बुक्स में कहीं ना कहीं कुछ क्यों नहीं बना देते?
You have seen the North Delhi में क्या हुआ है?
Actually, I have experience. One more thing, I had a past experience of being IAP Vice President, right? I did not have any account, sir. Our branch account had some problems. So me and our secretary run all the programs, and without taking a single balance sheet was there. We did not have account for.
सर मैं भी था. 1 लाख रुपया मैंने दिया था.
कोई
नाम ले दो सर. सर नाम ले दो सर.
1.5
हमारा भी ले दो सर.
एक मिनट, हम कहाँ गए सर बीच में?
डॉक्टर मुकेश इज सेइंग
सर मुकेश था, मैं था, विपुल था, हम सबने पैसा
IAP platform. Move the GBM further. Dr. Naab sir.
अच्छा, दूसरा मुकेश का पॉइंट ठीक है कि ब्रांच को दे के जाना चाहिए.
अगर पंकज आपका स्पीकर ऑन करो, आप म्यूट हो.
डॉक्टर नाब,
मैं अपनी तरफ से तो ऑन हूँ यार.
भाई आगे बढ़ो. ऑन है ठीक है.
कैसे बोलो फिर यार, सब चिल्लाने वाले हैं.
डॉक्टर सर में दर्द हो गया.
डॉक्टर नाब,
Any other agenda left? Any other agenda?
डॉक्टर नाब, मैं कुछ कह सकता हूँ 1 मिनट के लिए?
बोलो महाराज.
2 मिनट ले लो सर.
2 मिनट पक्का.
मैं ये कह रहा हूँ सर, ये सारी बातें जो हम जीबीएम में कर रहे हैं, एक्चुअली हमें ये सारी बातें ईबी में करनी चाहिए. देखो अनफॉर्चुनेटली नहीं सर, नहीं डॉक्टर ललित, आप उसको डाइल्यूट मत करो प्लीज. 1 मिनट सुनो मेरी बात. देखो हमें ये बताया गया है कॉन्स्टिट्यूशन में कि साल में 6 ईबी होनी चाहिए. कितनी ईबी हुई? अब ये जो 1 मिनट सर, मेरी पूरी बात सुन लीजिए. अब ये जो अकाउंट्स हैं, अकाउंट्स की डिटेलिंग जो है, अनफॉर्चुनेटली इस वक्त जो हमारे पास मेंबर्स हैं, ज्यादातर मेंबर जीबीएम में इससे बहुत ज्यादा मेंबर होते हैं, लेकिन इस वक्त बहुत कम मेंबर हैं. लेकिन ये जो सारी डिटेलिंग है, ये हमें अपनी ईबी में डिस्कस क्यों नहीं करते हैं? 3 दिसंबर को डॉक्टर एक मिनट सर, मेरी पूरी बात सुन लीजिए सर. इवन इतनी बड़ी कॉन्फ्रेंस हुई, पीसीएनआई कॉन्फ्रेंस हुआ, सब कुछ उसकी साइंटिफिक कमेटी है, सब कुछ है, सब कुछ डिसीजन हुआ, इतने सारे अवार्ड्स आज आपने दिए, हम अप्रिशिएट करते हैं आपको. लेकिन ये सारी बातें ईबी में डिस्कस क्यों नहीं होती हैं सर? ये ऐसा क्यों लगता है कि सारा का सारा काम हमारे आईएपी दिल्ली के काम जो है वो डॉक्टर नाब, डॉक्टर स्मिता, डॉक्टर ललित और डॉक्टर मनीष ही कर रहे हैं? तो ईबी मेंबर्स जो हैं, तो ईबी मेंबर्स हैं, उनका क्या वैल्यू है सर हमारे पूरे फंक्शन के अंदर? क्या सिर्फ सुनने के लिए है सर? हमसे पूछता है कि अवार्ड कब डिसाइड हुआ था, कब ये पता लगा था, कब नॉमिनेशंस गए थे, कब किसने डिसाइड किया कि कौन सा अवार्ड देना है? ये जो अकाउंट्स है, ये कॉन्फ्रेंस हुई, तो इसमें हमारा रोल जूम मीटिंग्स के थ्रू हो सकता है ना सर? बाकी भी तो हम पीसीएनए अटेंड कर ही रहे हैं इतने दिनों से, पर उससे पहले या उसके बाद ये ईबी मीटिंग्स कब हुई हैं सर? मुझे ये बताइए सर. थैंक यू सर, इतना ही करना.
वैलिड पॉइंट है.
We have done it whenever it was required. EB group
नहीं सर, इतनी बड़ी कॉन्फ्रेंस हुई है, उससे पहले ईबी मीटिंग हुई है सर. अकाउंट स्टेटमेंट है, वो ईबी मीटिंग में डिस्कस हुआ है सर.
पंकज की बात को मैं सेकंड करता हूं. आई एम रियली सॉरी फॉर इंटरफेयरिंग.
ये मैं भी सेकंड करता हूँ. मैं भी सेकंड करता हूँ. I also appreciate this point. Right. I also appreciate this.
But
मैं थर्ड करता हूँ.
But what is the? I want to know for the general knowledge. I want to know for my knowledge how many EBs, how much is it?
डॉक्टर ललित सर, डॉक्टर नाब को बोलने दे प्लीज सर. सर आपका मैटर नहीं है सर. डॉक्टर नाब और डॉक्टर स्मिता.
नहीं, I am asking. I'm
Yes,
asking
six.
him.
According to Constitution of IAP Delhi, we should have minimum 6 EB meetings per year. So how many we have had this year?
We had a number of meetings, but
बताइए
I can't tell you, the reason is very clear. Because of COVID, we could not meet each other. That was the reason, and our IAP EB group was the biggest group in which the whole information was dispersed from time to time. And as far as the your involvement is there, we try to include you in everything.
नहीं सर, मैं इंडिविजुअल की बात नहीं कर रहा हूँ सर, प्लीज ये इंडिविजुअल पे मत लीजिए सर। मैं कह रहा हूँ कि पीसीएन नहीं हुई सर, उससे पहले ईबी मीटिंग हुई। अवार्ड्स कौन से डिसाइड होने हैं, कौन से दिए जाने हैं, किसको दिए जाने हैं, क्या उसमें हमारा इन्वॉल्वमेंट था? क्या अकाउंट स्टेटमेंट आप डिस्कस यहाँ पे हो रही है? क्या मुझे पता है?
डॉक्टर ये हमारे आने वाले प्रेसिडेंट प्लीज डॉक्टर ललित हमारे साथ ये गलती हुई है, अब आप अगले साल मत करिएगा, यही मैं कह सकता हूँ।
चलिए
सर, मेरी एक और क्वेरी है। अकाउंट खोलिए, इसमें 2,37,000 मीटिंग एक्सपेंसेस हैं। 2,37,000 की कौन सी मीटिंग्स हुई थी, मैं जानना चाहता हूँ।
नहीं, कब हुई है ये
सर, मुझे क्या पता, मैं तो स्टेटमेंट पढ़ रहा हूँ फोन के ऊपर बैठ के। अब
ये पिछले साल में हुई होंगी।
आप तो पिछले साल वाले बताएंगे सर कि 2,37,000 की क्या मीटिंग। इसलिए तो मैं कहता हूँ कि एक हफ्ता पहले अकाउंट स्टेटमेंट आना चाहिए, हम क्वेरीज पोस्ट करेंगे, रिप्लाईज लेंगे।
अजय प्लीज,
ये
अकाउंट सर 3 दिसंबर को
इसमें कुछ
साइन है
तो
सर।
नहीं, इसमें कुछ तो मंथली मीटिंग्स हैं, क्योंकि उसमें जैसे हमें लंच स्पॉन्सर करना पड़ता है कई जगह पे, और उसमें बैनर देना पड़ता है, बैनर और मोमेंटोस। और
उसकी कोई लिमिट फिक्स की थी ना कि हम 10,000 रुपए करेंगे स्पेंड।
उसमें 10,000 ब्रांच को देंगे, 10 से 15,000।
10,000 का फिक्स किया था, आप कितना लिमिट है? 5,000?
नहीं, अनुराग, अजय सही कह रहा है, 10 से 15 किया था, डिपेंडिंग ऑन द इंस्टीट्यूशन।
नहीं, अब जो है even for the digital platform also we had to spend around 15,000 on each meeting. We had to spend because the physical meetings are not possible to have the backup team, and we had to spend this much of money.
और इसमें कुछ पीसीएनआई से रिलेटेड भी मीटिंग्स हैं थोड़ी सी।
15,000 में भी 1.5 लाख होता है सर।
15,000 नहीं था, 10,000 था। पहले 5,000 देते थे।
हाँ, पहले मैं 5,000 दिया करता था, फिर 10,000 हुआ था, तो 1,20,000 होता है ये। इसलिए
नहीं, वो तो हम उसको देते हैं ना,
नहीं
जो
सर,
ब्रांच है, पर उसके ऊपर जो मोमेंटो वगैरह होते हैं।
ये सर मैं देता था, क्या मतलब है ये मैं क्या होता है?
मैं मतलब जब मैं सेक्रेटरी था सर, गुरुदेव मैं सेक्रेटरी था तब की बात।
अगर आपने दिया तो फिर एसोसिएशन में मतलब जमा करा दीजिए बाकी। अगर
अच्छा सर, आप दिया करते थे सर, आप दिया करते थे।
डॉक्टर अनुराग 1 वीक के बाद में जब नया वाला ये अकाउंट्स के लिए मीटिंग बुला रहे हैं, तो तब तक आप स्टडी कर लो जो पॉइंट्स
करेंगे सर। मेरा पर्सनल लिए अकाउंट सर प्लीज,
बिकॉज ये पार्ट्स में तो कोई फायदा ही नहीं होगा ना।
हाँ, मैं भी यही कह रहा हूँ सर, दैट इज द रीजन।
अनुराग यार, अब आगे बढ़ने दे प्लीज, नहीं तो फिर हम लीव कर रहे हैं। कोई और इम्पोर्टेंट मैटर है क्या?
डॉक्टर समिता, कोई और एजेंडा है इसके आगे?
इलेक्शन का क्या हुआ भाई?
मैं एक एजेंडा में एक बोलना चाहता हूँ।
पहले एजेंडा खत्म तो जाने दो।
That full appreciation for the team of Dr. Nav and Smita. They have done exceptional work in very trying circumstances, and it has really made IAP Delhi proud of all the activities.
चलो सर, हो गया, आगे चलें।
ओके, हो गया सर, बाय।
सर हो गया,
कर दिया कि they will have to
सर, वो अभी खत्म नहीं हुआ, एंड में आपको दे देंगे वोट ऑफ थैंक्स, आप बोल लेना। अभी चलने दो मीटिंग सर।
नहीं, ये रेजोल्यूशन
वोट ऑफ थैंक्स देंगे
सर। आगे इलेक्शन भी तो करवाना है।
डॉक्टर स्मिता, अनम्यूट योरसेल्फ।
हाँ, आगे चले सर, नेक्स्ट एजेंडा।
नहीं, इलेक्शन का ये है,
ये कह रही हूँ डॉक्टर पंकज, आई एम सो सॉरी, हम लोगों से जो भी गलतियां हुई, अनफॉर्चुनेटली वी वर फॉर लास्ट 3 मंथ, हम लोगों में से एक ना एक कोविड में पड़ा हुआ था, तो देयर वर मेनी इश्यूज।
आपने हमें कहा था, हमने मना किया
देयर आर सारे, और इनमें से जो भी चीजें हैं वो सारी हमने व्हाट्सएप ग्रुप में हमेशा डिस्कस की।
हमेशा डिस्प्ले
सिंगल थिंग, इवन अगर एक हमने एम्बलम भी बनाया है तो वो हमने व्हाट्सएप ग्रुप में,
वी हैव टेकन द ओपिनियन ऑफ ईच एंड एवरीवन कि ये फोटो ये लगाए, ऐसा लगाए।
अगर आज शहर को आज हमने अगर कुछ अवार्ड किए हैं तो वो हमने टीनेजर डे के अवार्ड को एक्सटेंड किया। टीनेजर डे पे उसने जो वो किया था उसी को
मुझे
किया
कोई
है
ऑब्जेक्शन नहीं
और
है,
सिर्फ
मुझे
एक मोमेंटो दिया है, दैट इज नॉट ए मनी एट ऑल।
नहीं मैम, मुझे ऑब्जेक्शन नहीं है।
अनीता शर्मा को मैंने अलाइन कराया है, डॉक्टर वासुदेव के साथ कराया है, डॉक्टर तनीजा के साथ कराया, बिकॉज हमने उनको वो सब एपीएमएस से मुझे इंफॉर्मेशन आई थी कि दे वांट ए स्कूल प्रोग्राम, सो आई ट्राई टू जस्ट कीप ए बॉन्ड देयर एंड ए स्मॉल मोमेंट, दैट्स इट मैम, इट इज नथिंग
मैडम जो डॉक्टर पंकज गर्ग का
मैम आपको कोई क्वेश्चन नहीं कर रहा ऑन योर,
मैडम ये आपके लिए नहीं है, दिस इज नॉट फॉर यू,
पर्सनल वो नहीं है,
ये एक जर्नल इशू है मैम, जो सही कह रहे हैं।
जनरल इशू बता रही हूँ मैं, जनरल इशू बता रहे हैं कि हमने व्हाट्सएप में डिस्कस किया है, हमने एक मैंने अगर डॉक्टर्स देखा है कि वो बनाए तो वो भी सबने, जब डॉक्टर गाबा ने कहा ये ग्रीन नहीं अच्छा लगता, पिंक होना है,
वो
तो हमने वैसे किया है, हमने जो
बहुत बढ़िया काम किया आप लोगों ने,
वर्किंग ऑन जो
कैन वी मूव अहेड, चलिए आगे चलिए, बहुत बढ़िया। स्मिता प्लीज डोंट टेक पर्सनल।
Dr. Dubey is there. Dr. Dubey is there or he is left?
So agenda 5 is the revised draft submitted by Constitution Amendment
Dr.
Committee.
Dubey, I think is not there, sir.
क्या कहना चाहते हो?
The revised draft submitted by the Constitution Amendment Committee was discussed point wise and adopted after few correction and unanimously, तो उसमें हमने वो कर लिया, adopt नहीं किया।
एक मिनट।
Dr. Dubey sir, this time the elections we could not hold physically because of COVID-19 it is not possible. We tried to make consensus in the people so that the elections are not required, but somehow the people are not agreeing to it. So we have to go in for a electronic module which will be available with us within 15-20 days. We'll let you know, and within 3 weeks time we'll hold an election in the last week or third week of December.
Right. Doctor, now what about
VP? We have to complete before 31st. We should try to complete before 31st, so that at least we can declare the result on 31st.
Doctor, now what about
where
VP?
the status of VP?
Vice President.
Dr. Dubey will tell that.
Dr. Dubey, please tell us what is the status, how can it be done, you know? What is the status of executive members and vice president? इनको हम कैसे, मतलब हम कैसे आएंगे इलेक्शन में, कैसे होगा? वीपी का तो बताइए, एग्जीक्यूटिव मेंबर्स सब वी कैन टेक, और यू वांट कि सारा इलेक्शन हो, प्लीज गाइड अस।
नहीं, जो ऑलरेडी नॉमिनेशंस आ चुके हैं हमारे पास वैलिड,
सर वीपी का नहीं है कोई,
नॉमिनेशंस के ऊपर इलेक्शन होगा। बाकी जो पोस्ट बची होंगी वो हम एग्जीक्यूटिव बॉडी को कहेंगे कि भाई वो अपने हिसाब से कोऑप्ट करें या नॉमिनेट करें।
सर
नॉर्मली जनरल आईपी में होता है जी, किसी स्टेट से कोई
जीबीएम में नहीं होता सर, इसी में तो होगा।
जीबीएम में इनवाइट करते थे नॉमिनेशंस,
जी कोई नहीं आया तो वो भी
nominating by executive board, general body meeting should have the power because GBM is having more value than EBM.
Yes, exactly.
अगर कोई भी नॉमिनेशन है या कोई भी
कॉन्स्टिट्यूशन में कहीं ऐसा नहीं है, और हमको जनरल बॉडी मीटिंग अभी फिजिकल कर भी नहीं पा रहे हैं, और हमने बाकी लोगों का यदि मान लो इलेक्शन प्रोसेस पूरी करनी है, ऐसा नहीं कि आज हम एक व्यक्ति को नॉमिनेट कर दें और बाकी प्रेसिडेंट के लिए हम इलेक्शन कराते रहें। तो इसलिए बेहतर तो यही है कि हम कर लें इलेक्शन के बाद जो बॉडी आए, वो बॉडी यदि मान लीजिए चाहती है कि भाई हम नॉमिनेट करें, कोऑप्ट करें, जो भी करना चाहे वो ज्यादा अच्छा होगा, बजाय इसके कि हम वाइस प्रेसिडेंट के एग्जीक्यूटिव कुछ के आज कर लें और बाकी लोगों का तुम इलेक्शन प्रोसेस बाद में चलती रहेगी। वो मेरे हिसाब से
सर वाइस प्रेसिडेंट के लिए नॉमिनेशन बन सकते हैं
सर? कैन वी इनवाइट द नॉमिनेशंस फॉर वाइस प्रेसिडेंट?
वाइस प्रेसिडेंट का
सर दोबारा
ये तो ऑर्डर नहीं है भाई।
जब इलेक्शन हो,
जब कोई सीट खाली है तो फ्रेश वो लेने पड़ेंगे ना।
जब इलेक्शन हो ही रहा है तो उनका भी मंगा लो सर।
I agree to Dr. Dubey sir.
It cannot be done.
नहीं, आप ये कह रहे हो कि अभी हम दोबारा बना रहे हैं,
कैसे लेंगे?
I agree with Dr. Dubey. I agree with Dr. Dubey.
नहीं सुनो डॉक्टर मारिया, ऐसा है कि यदि मान लो
बोलिए सर।
आपकी आवाज
इंटरनेट आप एक अलग से नोटिफिकेशन उस पर्टिकुलर पोस्ट के लिए निकाल सकते। आप यदि मान लो, हेलो,
हाँ जी बोलिए सर।
हाँ जी बोलिए सर।
मान लो किसी एक पर्टिकुलर पोस्ट के लिए कोई नॉमिनेशन आपके पास वैलिड नहीं है, तो यू कैन इश्यू another notification that applications are invited for this particular post and you can give the date that is a second nomination, second you can say notification.
सिर्फ एक हफ्ते की
यस सर थैंक यू सर।
नहीं, नोटिफिकेशन तो जो है, जो नोटिफिकेशन में जिस तरह से वो पूरा प्रोसेस है ना, प्रोसेस तो वैसे ही होगा। उसमें कितने दिन का टाइम जो है वो देखना पड़ेगा। वो जो 1 हफ्ते का टाइम, 10 दिन का टाइम है, फिर उसमें कोई विड्रॉल करेगा, कोई वो वैलिडिटी देखेंगे, वो सब होगा। लेकिन ये है कि आप चूंकि उस पोस्ट के लिए आए ही नहीं है, तो दोबारा आप नोटिफिकेशन कर सकते हो।
सर ऐसा कॉन्स्टिट्यूशन में है क्या?
ये सब जगह होता है यार, सुनो, सब जगह होता है। अभी तक तो हमारे कॉन्स्टिट्यूशन में जो था वो ये था कि भाई फिजिकली हम वहां कर लेंगे, लेकिन वो फिजिकली हम कर ही नहीं पा रहे हैं। तो अब नहीं कर पा रहे हैं, और कोई पोस्ट खाली रह जाती, मान लो कहीं इलेक्शन जैसे काउंटरमार्ट भी होता है ना, सेंट्रल इलेक्शन भी, तो क्या होता है कि भाई या तो हम ये है कि दोबारा नॉमिनेशन से दोबारा नोटिफिकेशन कर दें कि नया नोटिफिकेशन।
सर आज कर सकते हैं ये
सर? वन मोर थिंग,
कल मैडम कल निकाल देंगे ना, कल निकाल देंगे।
नॉमिनेट करना है, नहीं करना चाहते हो तो आप दोबारा एक नोटिफिकेशन, दिस इज सेकंड नोटिफिकेशन बिकॉज़ नो पोस्ट, nobody was found eligible, you can have a second notification, कोई दिक्कत नहीं है।
तो जीबीएम नहीं इलेक्ट कर
सेकंड नोटिफिकेशन सिर्फ एक पोस्ट के
सर
लिए
आज
निकालना
जीबीएम
है।
इलेक्ट कर सकता है
एक पोस्ट के लिए और खाली ईबी के लिए मैडम, जो ईबी
हाँ,
नहीं,
जिस पोस्ट के लिए
ये भी खाली है।
जो
भी
जो
खाली
तो
पोस्ट
करती है,
खाली
हर
रह
साल तो
गई
जीबीएम करती है सर।
उन्हीं पोस्ट के लिए निकलेगा सेकंड नोटिफिकेशन। फिजिकल करते थे ना हम वहां पर बैठ के सारा कुछ,
हाँ, यही करते
नॉर्मली
थे।
ऑफिस बेरर का नहीं करके हम एग्जीक्यूटिव मेंबर की करते थे। इस बार हम कर ही नहीं पाए। एक्चुअली उसमें सारे डिसाइड हो जाता था उसी दिन जीबीएम में, लेकिन अब हम बाकी तो डिसाइड कर नहीं पा रहे हैं। जैसे मान लो इलेक्शन होना है, प्रेसिडेंट का इलेक्शन होना है, अभी सेक्रेटरी का होना है, तो ये मान लो इलेक्शंस होंगे तो फिर ऐसा थोड़ी ना करेंगे कि हम बाकी आज कर लें और बाकी लोगों के इलेक्शन जो बाद में कराते रहें। इलेक्शन प्रोसेस तो सेम ही
बिल्कुल
चलेगी
सही
ना।
बात है, इलेक्शन तो एक से
दूसरा नोटिफिकेशन कर सकते हो।
यस सर, यस
You
सर,
can have a
बिल्कुल
second
सही।
notification.
जैसे हमेशा
सर,
कराते रहे हो,
कॉन्स्टिट्यूशन में एक डेट है।
मेरा एक
आपके पास
क्वेश्चन
पूरा
है।
टैलेंट है, आप जैसे हमेशा कराते रहे, आज भी करा दीजिए वैसे ही।
नहीं, ये अभी तक कभी
बिल्कुल
ऐसी
सही
सिचुएशन
बात है।
आई नहीं यार। सुनो आलोक, वी हैव नेवर फेस्ड सच सिचुएशन इन द पास्ट।
सर
जब भी हमारा हुआ है, कभी इलेक्शन भी हुआ है तो हमने वहीं करा लिया फिजिकल उससे। तो ये हमेशा हुआ है, पहली बार ऐसा हो रहा है, पहली बार ऐसा हो रहा है कोविड सिचुएशन के कारण कि हमें ई वोटिंग करानी पड़ रही है। तो अलग अलग टाइम में हम नहीं कराएंगे कि भाई आज हम वाइस प्रेसिडेंट का कर लें और बाकी का बाद में। हाँ, नोटिफिकेशन करके हम ये कर सकते हैं कि वो इलेक्शन उसके साथ ही हो जाए या उसके साथ अलग भी हो सकता है, लेकिन वो एक नोटिफिकेशन अलग से निकाल दो, दिक्कत क्या है?
कॉन्स्टिट्यूशन में एक डेट है, लास्ट डेट, नॉमिनेशन की लास्ट डेट है, उसकी हर चीज की लास्ट डेट है, बिफोर दिस डेट।
हाँ, तो प्रॉब्लम क्या है?
सर हम आज ही कर लेते हैं, मतलब नहीं मुश्किल है
सर। आई वांट
निकाल दो नोटिफिकेशन,
कल निकल सकता है, उसमें क्या बात है?
मैं कह रहा था कि वाइस प्रेसिडेंट का आज ही सॉर्ट आउट हो जाता, और जो शायद ईस्ट सेंट्रल के 2 ईबी
ऐसा नहीं हो सकता अनुराग।
वो सर आप देखिए,
अनुराग ऐसे
बहुत
नहीं
आइडिया नहीं है इसमें, मैं बोल
करेंगे।
सर आज क्योंकि जो जीबीएम का एजेंडा था उसमें लिखा हुआ था इलेक्शन विल बी एट ए लेटर डेट, तो अगर आज नॉमिनेट कर देंगे तो फिर कोई कंप्लेंट डाल देगा।
यस,
आई वांट टू नो वन थिंग, डॉक्टर दुबे सर एंड डॉक्टर दुबे सर,
हमें नहीं बताया, ये तो एजेंडा में था नहीं।
सर एक चीज मैं कहना चाहूंगा सर, डॉक्टर दुबे टू यू।
नहीं, एजेंडा तो ऐड हो सकता है प्रेसिडेंट की तरफ से।
सर डॉक्टर
नहीं,
दुबे
ऐसा
सर,
नहीं यार,
भाई आज नहीं हो सकता ना।
हाँ डॉक्टर दुबे सर, हमारा जो कॉन्स्टिट्यूशन है, दिस इज मेड बाय अस ओनली, वी ऑल पीपल आर द पार्ट ऑफ इट, राइट? नाउ दिस इज द प्रॉब्लम व्हिच हैज जस्ट अराइज बिकॉज ऑफ कोरोना और व्हाट अदर थिंग्स द कैंडिडेट्स नीड देयर। सो व्हेन वी कैन हैव ए कंसेंसस इन दिस जीबीएम, इट शुड बी ओवर, बिकॉज सर हम ही तो हैं बॉडी, और कौन है सर? बाहर से थोड़ा ना कोई आएगा। वी कांट।
नहीं यार सुनो, ये 10, 12, 15, 20 लोग जो भी हैं
सर, ये दोबारा से प्रोसेस होगा।
मेरी बात तो सुनो, मेरी बात सुन लो यार। कल को फिर कोई डालेगा चिट्ठी, फिर कोई लिखेगा कि साहब हमें मालूम नहीं था कि वहाँ वाइस प्रेसिडेंट का इलेक्शन होना है, कि इलेक्शन प्रोसेस के लिए वहाँ लिखा हुआ है नीचे डायरेक्टली कि इलेक्शन प्रोसेस विल बी डन लेटर। जो हमने एजेंडा भेजा है उसके अंदर लिखा हुआ है।
और डॉक्टर ललित,
I just have a feeling still people can mutually adjust. I think I have tried hard. I still have a feeling election may be not be.
वो तुम्हारी बहुत अच्छी।
If you allow us कि अगर हम GBM में करें,
very positive attitude, very good
Sir,
thinking
always
and very positive attitude.
I still have a feeling it may not be possible.
Lalit, for having the GBM, for GBM we need a quorum, and quorum minimum 50 people should be there in the quorum to make any decision.
Sir, virtual में कैसे आएंगे?
Things which will be questionable later. Best is
50 तो हम 50 तो अभी कर लेते हैं सर, फोन करते हैं, 50 तो अभी जुड़ जाएंगे।
ऐसा कुछ मत करो जल्दबाजी में, जो कि बाद में लोग परेशान हो,
बाद में क्वेश्चनेबल करें। और
ऐसा कुछ नहीं करते।
डॉक्टर अनुराग सबसे ज्यादा लीगली बाउंड है, वही
सर एक्चुअली
सजेशन दे रहे
अनुराग ही
हैं।
तो कह रहा है सर, अनुराग ही तो कह रहा है, ही इज वन ऑफ द कैंडिडेट।
सर
वही कह रहे हैं, अनुराग सबसे ज्यादा लीगली
वो
साउंड
सबसे
है,
ज्यादा
वही
तो वो कह रहा
सजेशन दे
है।
रहे हैं।
प्रेसिडेंट इलेक्ट है सर, प्रेसिडेंट इलेक्ट बनना है उसने।
वो कह रहे हैं अभी सर काम हो जाएगा, आपका भी टेंशन खत्म, हमका भी सर।
नहीं,
वो अपना
नहीं,
वैलिड
ऐसे
हम
नहीं करा
इलेक्शन
जाता।
नोटिस निकाल
आप
दें।
मुझे बताओ।
अच्छा,
को
डॉक्टर
प्रॉपर
नाग
नोटिस निकाल के प्रॉपर
नॉमिनेट कर दो, अनुराग को नॉमिनेट कर देते हैं
सर
सर।
आई कैन डू इट राइट नाउ, बट आई डोंट नो आई हैव कॉन्स्टिट्यूशनल
नहीं।
पावर्स।
देखिए ऐसे
वेदर आई हैव कॉन्स्टिट्यूशनल पावर्स, आई डोंट नो।
नहीं, अनुराग को
अच्छा,
वाइस प्रेसिडेंट
ऐसा नहीं
नॉमिनेट
अनुराग को
करा
वीपी नॉमिनेट कर देते हैं सर।
अनुराग आप
डॉक्टर
वाइस
नाग,
प्रेसिडेंट
मैं
नॉमिनेट
तो वीपी बन चुका
अनुराग
हूँ।
आ जाओ, अनुराग आ जाओ ऊपर।
डॉक्टर
मैं
नाग,
वीपी बन चुका हूँ।
ऐसे
दोबारा अलाउड है तो बना लो
डॉक्टर
तुम।
नाग,
Just a
मैं
minute.
सोचता हूँ कि
Dr. Samita.
हाँ, मैं ये कह रही थी कि आप इन लोगों को वो भी बता दीजिए कि अगर कुछ वो इलेक्ट्रॉनिक ऐप चाहिए होगा तो उसका पैसा लग रहा है, तो वो भी सबको पता होने, फिर बाद में हम कैसे।
सबसे ले लो मैम, कैंडिडेट से ले लो पैसे सबसे।
इलेक्ट्रॉनिक ऐप बनाया जा रहा है, सॉफ्टवेयर।
सर कितने पैसे आएंगे?
40,000
आएंगे नहीं, लगेंगे।
हाँ वही लगेंगे।
पर वो नहीं लेगा।
अब आपकी आवाज क्रैक हो रही है डॉक्टर साहब, आपकी आवाज सुनाई नहीं दी, दोबारा से बताइएगा लास्ट से।
नहीं, ये सॉफ्टवेयर कंपनी वाले को बोला गया है, जो हमारा वेबसाइट डील करता है, वो कह रहा है कि एक सॉफ्टवेयर बन जाएगा जो हमेशा के लिए आपके इलेक्ट्रॉनिक काम आएगा। It will be an asset for the unit IAP office and it will cost around 40,000 rupees.
Very good, sir. Clapping.
I have also talked to the central IAP person जिन्होंने सेंट्रल IAP का किया है, so I think tonight he will let us know कि for small
We
body
have already given order to them.
Okay, sir. Very good. Very good.
IAP वाला
Clapping,
सब
sir.
क्योंकि सर चक्कर क्या है कि वो 3 हफ्ते लगते हैं उसको ना पूरा।
एनएनएफ वाला अच्छा था सर वैसे।
एनएनएफ
डॉक्टर
वाला
नाब,
आसान था, लेकिन
डॉक्टर नाब, डॉक्टर तनेजा,
हाँ सर,
ये जो ई वोटिंग के लिए आपने जो वो लिया है, जो भी प्रोडक्ट आपने लिया है, इज इट बीन टेस्टेड एल्सवेयर? क्या उसका वेरिफिकेशन है, क्या सर्टिफिकेशन है उसकी?
टेस्ट तो IAP दिल्ली के लिए बना, टेस्ट करो।
वो बना के और टेस्ट करेंगे, इसलिए इसमें टाइम लगता है।
देखो ये प्रोसेस क्या होता है।
सर मैं आपको ये बता रही हूँ कि हमने 2 जगह से पता किया था। एक जगह में 1 लाख का वो मिला था और 40,000 पर ईयर का उसका मेंटेनेंस इतना था इनका।
I don't think we will
Madam,
require
that is
every
too
year.
costly. Anurag, you have at MEMC, what is the cost there?
सर हमें तो 200 मेंबर थे तो बहुत सस्ता पड़ा था। अब मुझे आइडिया नहीं है एग्जैक्टली, हमने ही कराया था इलेक्शन। बट
And I have one more
और मैं
suggestion
एक
कि
बात बोलूं?
आजकल डमी कैंडिडेट्स बहुत ज्यादा फॉर्म भर देते हैं। इस बार लोगों ने 4-4 सीटों के लिए फॉर्म भरे हैं। अगली बार से क्योंकि इलेक्ट्रॉनिक खर्चा हो रहा है, हर कैंडिडेट जो भी सीट के लिए भरे उनसे 2,000 1,000 कुछ पैसे लिए जाए, कम से कम ये इलेक्शन के पैसे निकलेंगे कुछ।
मैं एक सजेशन दे सकता हूँ सर, मैं एक
I
सजेशन दे
think
सकता हूँ।
Constitutional Amendment Committee can note this
Constitutional
point
amendment में
कि
जाएगा सर।
10,000
डालो
लेना
ना,
चाहिए।
मेल में डालो यार, सारी
nomination
यहीं
तो
पे
सर
लिखवाओ।
ज्यादा है, 2-3
डॉक्टर
हजार ले लो।
मनीष मेल में डालो ना
pediatrician।
कल।
वो उसको
सर
अरे यार
एक बार एक
unnecessary मत
सजेशन मैं
extend
देना
करो
चाह रहा
GBM
हूँ,
को।
एक सजेशन मैं देना चाह रहा हूँ। मेरा फ्लैट है नोएडा के अंदर और वहाँ वो NCLT में है, उसमें वोटिंग होती है और कोर्ट ने एक ऐप को उन्होंने अपॉइंट किया हुआ है। दे चार्जेस जस्ट 5,000 रुपीज, उसमें सीक्रेट वोटिंग होती है। बाकी आप देख लीजिए जैसा भी
वहाँ
है,
जाना
इन्होंने
पड़ेगा।
इतना खर्चा नहीं आपको
हाँ।
ऐप मिलेगी।
नहीं आप ले लो ना।
हाँ
पर डॉक्टर नब तो कह रहे हैं ना, ऑलरेडी
हायर
ऑर्डर
कर दो
कर
ना।
चुके हैं वो।
यार
लेकिन
ये
40,000 रुपए
अनम्यूट कर दो।
मैं
कर चुके तो
नाम
बात
कर दो।
अलग है, बट इट इज जस्ट 5,000 रुपीज।
नहीं, it is already done and that will be maintainable by them every year. It will be an asset for the IAP.
नहीं, but why do we
सर
need
40,000 रुपए पर ईयर बहुत ज्यादा कॉस्ट है
नहीं,
सर।
charges are only one time investment.
और बाद में कितना है पर ईयर सर?
वो क्यों पड़ेगी
बाद
हमें?
में वो वेबसाइट वाला मेंटेन करेगा,
No,
अभी
don't
वो
they will
वेबसाइट के बाद।
maintain.
अगली बार इलेक्शन नहीं होगा फिर।
सर
ऐसा थोड़ी अगली बार हो जाए तो फिर
चेयर सर,
सर पर ईयर वो पैसे तो लेगा ही ना, कितने लेगा? फ्री में थोड़ी
नहीं लेगा, नहीं लेगा, नहीं
सर,
लेगा।
ऐसा थोड़ी होता है सर।
नहीं लेगा।
सर आपकी मेंबरशिप लिस्ट अपडेट
उसमें
करेगा
ना-
वो, उसके बाद
उसमें ना
वो
बस
आपको
ये देख लेना
रिजल्ट्स
सर,
पब्लिश
40,000 की
करेगा,
बात नहीं है।
आपको बैकएंड सर्विसेज देगा,
उसको
कितनी
cancel
हेल्पलाइन
कर
कॉल्स
सकते हैं।
जाएंगी वो मैनेज करेगा, उसका भी खर्चा होगा सर। 40,000 में कितने साल का दे रहा है? 10 साल का, 20 साल का? इट इज नॉट पॉसिबल।
दिल्ली वेबसाइट डील कर रहा है, वही मेंटेन करेगा।
सर अगर कोई इलेक्शन का प्रोसेस, मॉड्यूल, एप्लीकेशन या सॉफ्टवेयर ट्राइड और टेस्टेड नहीं है, उसकी क्या वैलिडिटी है कि उस पे जेन्युइन और ट्रस्टवर्दी इलेक्शन होंगे? फिर तो सर गूगल फॉर्म पे डाल दो सबके सब अपनी अपनी ऑप्शन।
मैं यही कह रहा हूँ, अगर
बना रहा है वो टेस्टेड तो है ही नहीं।
अपना सॉफ्टवेयर नहीं बना सकती। यू हैव टू अपॉइंट थर्ड पर्सन जिसके पास वैलिड सर्टिफिकेट्स हैं, और वो आप डॉक्टर तनेजा की बात को लाइटली ले रहे हैं। यू कैन नॉट हैव योर ओन सॉफ्टवेयर एज ए बॉडी एंड होल्ड योर ओन इलेक्शंस बिकॉज ऑफिस bearers can rig that.
Yes, I
Office
agree.
bearers cannot hold a software and hold their own elections. It is illegal.
So what
Please
do we
mind
do
it.
in this
Sir, I have a
circumstance?
suggestion. Sir, I have a suggestion. If you just want to listen to me, IAP, Central IAP का जो करता है election for 33,000 members, he is charging us 3 to 4 lakh rupees. पिछले साल उसने 4 लिए थे, इस साल हमने 3 लाख दिए उसको. And 1,000 members, and it is a validated platform which we have been using it for last 3-4 years, and it has been tried and tested. If you want, I have already talked to him. He will get
पैसे दे चुके हैं ना डॉक्टर नाब तो पैसे
नहीं डॉक्टर मेंडी रहता, आई टॉक टू हिम, उन्होंने अभी 15,000 दिए हैं, वो एक्सपेंसेस मैं बियर कर लूंगी, और मैंने कहा कि अगर वो कैंसिल कर सकते हैं वो कैंसिल।
नहीं, आप क्यों बियर कर रहे हैं?
नहीं, कोई प्रॉब्लम नहीं सर, मैं ये झगड़े में नहीं पड़ सकती। आई एम वेरी टायर्ड नाउ।
Dr. Smita, that can be adjusted in website maintenance. It is the same company. You don't have to bear that, madam.
जिस पर्सन ने सेंट्रल आईपी का इलेक्शन कराया उसी ने हमारी मैमसी फैकल्टी एसोसिएशन का कराया था। हमारे सिर्फ 250 मेंबर हैं। That is the same body.
और हमारे सिर्फ अनुराग 13 मेंबर्स हैं। For 1,300 members, I have asked.
Dr. Smita, emotional ना हुआ करो, process discuss होता है।
very tired now and I
मैडम
can't
सिर्फ प्रोसेस डिस्कस हो रहा है मैडम, थोड़ा सा बुरा नहीं मानना, मैं ट्रेजरर हूँ, लेकिन मेरे को भी नहीं बताया गया कि ये इलेक्शन के लिए 40,000 रुपए दिए गए हैं। प्लीज
पता है बहुत सारी चीजें नहीं, क्योंकि
है
हम
ना,
लोग की
तो
हालत
मैडम
इतनी
प्रोसेस
खराब चल
डिस्कस
रही
होता है।
है।
नोबडी इज पॉइंटिंग फिंगर्स एट एनीवन मैडम, ये सिर्फ प्रोसेस डिस्कस हो रही है। मैडम तनेजा, डॉक्टर वासुदेव एक्सपीरियंस लोग हैं, दे आर टेलिंग अस द राइट थिंग्स, तो वी शुड लिसन एंड फॉलो फॉर फ्यूचर।
दैट इज व्हाई आई एम डूइंग राइट थिंग, आई एम कैंसलिंग इट। कोई प्रॉब्लम नहीं है।
इमोशनल ना हुआ करो, रिलैक्स करो, जस्ट रिलैक्स।
मैडम कैंसिल कर रही है।
You can talk to that guy. I think website maintenance के लिए तो पैसे जाएंगे।
We'll do that, but I am just telling कि जो बात है थोड़ी ना discussions are missing, कि जो CIAP और वो है तो वो processes discuss हो रहे हैं हमारे, that is more important.
Dr. Taneja wanted to say something.
Yes, Dr. Taneja sir.
सर उससे पहले मैं एक बात बोलूं, मेरा मतलब बहुत अच्छा रहा प्रोग्राम। डॉक्टर नब 3 cheers to you एंड डॉक्टर स्मिता, आपने तो पूरे साल बहुत अच्छा काम किया। क्लैपिंग एंड प्लीज एक्सक्यूज मी, आई एम लीविंग दिस मीटिंग।
हमारे लिए भी चीयर्स कर देना, हमारे लिए भी तो चीयर्स करो।
आपके लिए अगले साल करेंगे सर, आपके लिए अगले साल।
और क्या, जिसने काम किया डॉक्टर स्मिता और डॉक्टर नब ने और डॉक्टर मनीष,
अगली बार अगले साल
उन्हीं की क्लैपिंग होगी।
डाल रहे बीच में
ऐसे आपके लिए अगले साल सर, आपके लिए अगले साल।
तो मैडम ने
किसको विश करते, बेस्ट विशेस दे दो।
ऑल द बेस्ट सर, ऑल द बेस्ट।
घर का ही है तो घर का ही है।
इसने पहले प्रॉमिस किया सबको 2 डालेगा इस साल।
अरे दीपक, चीयर्स किस चीज से कर रहे हो?
अच्छा, मैंने थोड़ा लेट ज्वाइन किया, मुझे कोई अवार्ड मिला है क्या?
हाँ मिला है ना, रायतेबाज सर, ये ले लो।
डॉक्टर वासुदेव इज गिविंग अवार्ड। डॉक्टर वासुदेव,
we have cancelled the order. Whatever loss will be, will bear.
नहीं सर, नहीं सर,
Don't take personal.
मेरे ख्याल से जो प्राइजेस डिक्लेयर थी वो भी कैंसिल कर देते।
Vasudev to go ahead and do it fast.
No sir, this is wrong.
So we can just hire the services whenever required. We may not have it regularly.
ठीक है, we are with it.
सर देख लेते हैं, डिस्कशन है ये तो।
डॉक्टर तनेजा इमोशनल नहीं होना सर,
डॉक्टर
नाब
सर आप इमोशनल मत हुआ करो।
नहीं सर, आपके तो दम पे चल रहा है ये भी।
I recommend suggestion है to please find out today and let us know by tomorrow from the central agency CIAP.
Let us Dr. Dubey know.
कमेटी बना दो सर, एक कमेटी बना दो 3 लोगों की।
कमेटियां बनाओगे
कमेटी कितनी बनाओगे सर? डॉक्टर नाब तो कह रहे हैं अभी फाइनल है।
इलेक्शन कमीशन का काम है सर,
अभी फाइनल ये हुआ है। We have cancelled the previous order. डॉक्टर समिता, हम अपने आप उसका कर लेंगे जो भी निपटारा करना है। अब Dr. Vasudev, please take the responsibility. Ask the central IAP people what is the charges they will be having from us for the 1556 candidates, and we'll pay accordingly. इसमें क्या
एक बार डॉक्टर तनेजा की बात सुन लें सर. डॉक्टर तनेजा सर. डॉक्टर
देखो नहीं, मेरे को और कुछ नहीं कहना. जस्ट ऑन द पॉइंट ऑफ दिस इलेक्शन जो प्रोसेस की जो बात हो रही है, उस पर मैंने जो पॉइंट करना था मैंने कह दिया कि एक सर्टिफाइड थर्ड पार्टी सर्टिफाइड वेंडर से लेना चाहिए हमें कोई प्रोडक्ट. इट शुड नॉट बी ए न्यू प्रोडक्ट. एंड जैसे डॉक्टर विपुल ने कहा है कि the executive team cannot design the process, design the software or get it designed from a third party. वो थोड़ा सा एक ऑब्जेक्शनेबल होगा, क्योंकि अगर किसी ने उसमें ऑब्जेक्शन उठा दिया तो उसको सॉर्ट करना बड़ा मुश्किल हो जाएगा. वन हैज टू बी वेरी केयरफुल अबाउट दिस. एंड जो सेंट्रल ऑफिस का जो सीआईए
रिस्पांसिबिलिटी,
सर आप सजेस्ट तो कर दो वो नाम.
बता रहा हूँ सर. सेंट्रल ऑफिस में जो नित्यम करके सॉफ्टवेयर करके जो हमारे 4-5 साल से ई वोटिंग करवा रहा है, उसी को दिया जा सकता है और वो बड़ा नॉमिनल सा चार्ज करेगा. दैट इज व्हाट आई बिलीव. एंड उसके कॉन्टेक्ट्स हैं, डॉक्टर वासुदेव के पास भी हैं, मेरे पास भी हैं. वी कैन आस्क दैट पर्सन एंड गेट कोटेशंस फ्रॉम हिम.
आलोक, एनएनएफ का किसके पास है आलोक?
सर मैंने के पास नित्यम से भी बात करी थी और उसने कहा था जी जैसे आप कहोगे उस तरह कर देंगे. फिर डीएमए में डॉक्टर गिरीश त्यागी ने किसी से बात करी थी तो उसने 5000 का कोड दिया था.
बस 5000. जो भी सर, आई वांट टू जस्ट गिव वन आइडिया. जो कंपनी के पास ऑलरेडी ऐप होता है ना, उसको बहुत सस्ता पड़ता है, और जो कंपनी नया ऐप बनाती है उसको महंगा पड़ता है.
बहुत फर्क है.
आलोक, एनएनएफ का क्या खर्चा हुआ है?
एनएनएफ का अभी 28 रुपीज उसका कोटेशन आया था. 28 रुपीज पर मेंबर.
बहुत सस्ता है ये तो.
बहुत महंगा है सर.
6000 नहीं एनएनएफ वाला अच्छा है.
30 रुपए इंटू 1500 कितना हुआ?
45,000.
1500 नहीं है, 6000 6500 मेंबर है सर. क्या बात कर रहे हो? 6500
दिल्ली के आईपी दिल्ली
के क्यों गिन रहे हो? नेशनल इलेक्शन है सर.
अरे अभी दिल्ली के लिए सोच रहे हैं. खर्चा हो गया.
हाँ कितना?
2 लाख.
नहीं 2 लाख
मेंबर के हिसाब से
45,000
होगा.
45,000
वही तो हो गया.
ऑल ओवर दिल्ली इंडिया है ना.
लेकिन सर
नहीं दिल्ली के लिए सोच
बहुत
रहे
ज्यादा है.
दिल्ली
ईबी
के लिए
और कितनी सारी पोस्ट है. हमारे यहाँ तो पोस्ट भी कम है.
डॉक्टर वासुदेव हैं?
हाँ मैं हूँ. मैंने अभी नित्यम से बात की है. जस्ट टॉक टू हिम. ही इज एक्चुअली इन द गिर सेंचुरी. तो उसके सिग्नल्स कट रहे हैं. वो कह रहा है मैं जैसे ही सिग्नल्स ठीक आते हैं मैं आपको कॉल बैक करता हूँ.
वो जंगल का राजा चुनवा रहा है, वहाँ पे शेर का इलेक्शन करवा रहा है गिर के अंदर.
सीरियसली हो गया हमें. फाइनल करो, खत्म करो जो भी है.
ठीक है डॉक्टर नाब, डॉक्टर वासुदेव को रिस्पॉन्सिबिलिटी दे दीजिए आप ये, और इसको खत्म करिए. वासुदेव एंड डॉक्टर तनेजा. डॉक्टर वासुदेव एंड डॉक्टर तनेजा.
अरे खत्म क्यों करनी है? दोस्त बैठे हैं सारे. अच्छा बीवियां पीटेगी पीछे से सारे.
क्या तुझे यही बैठ रहा है? खत्म कर.
नहीं तो एंड करेंगे.
4 दिन से कॉन्फ्रेंस सुना रहे और ईबी जीबीएम में जल्दी बज रही है.
नहीं कोई जल्दी नहीं है, लगे रहो यार इसमें.
रात सर अपनी बंदूक निकालो सर.
क्लास और रख लो सर.
नाब सर बंदूक निकालो. डॉक्टर नाब सर बंदूक निकालो.
अरे 10 दोस्त बैठेंगे, ग्लास रख लो सामने.
मैडम इज सफरिंग फ्रॉम कोविड.
डॉक्टर वासुदेव ने बोतल दिखा दी और क्या?
बोतल दिखा दी बस.
ऐसे ही परेशान हो रहे हो सर. डॉक्टर मनीष मनीष नोट मत कर लेना कि अनुराग ने कहा कि बोतल दिखा दी गई है, अब सब शुरू हो जाओ.
सब कुछ रिकॉर्ड हो रहा है.
प्लीज ऐसे बातें नहीं करो, बंद करो यार.
और कुछ एजेंडा खत्म.
डॉक्टर दुबे सर.
डॉक्टर दुबे सर. डॉक्टर नाब, जो भी करना है डॉक्टर वासुदेव करें, जो भी करें जल्दी करो ताकि हमें अगले 3 वीक्स में आई थिंक वी शुड बी एबल टू कंप्लीट द प्रोसेस.
हो नहीं पाएगा सर फिर ऐसे तो.
आपको रात तक जो है, आपको अभी रात तक फाइनल मैसेज मिल जाएगा कितना खर्चा हो रहा है, कितना टाइम लगेगा. अभी आई थिंक another couple of hours he will call back and he will give us all the details.
Very good sir, very good.
Very good sir. अनुराग, आनंद and Dr. Taneja.
Dr. Samita is there or gone? She was not feeling well, I think. है ना?
Actually exhaustion हो जाता है post covid ना. We feel exhausted.
सर पोस्ट कॉन्फ्रेंस इतनी एग्जॉस्शन होती है.
Is there any other agenda? कोई और एजेंडा?
No agenda. I am leaving then.
No agenda now.
चलो जी, ओके, बाय बाय बाय।
Sir, best
Okay,
of
bye.
luck.
Good
All of
night.
you have fun.
Pranav,
Great.
conclude करो.
Good night.
Bye bye.
Continue.
Thank you.
लास्ट में
Clapping and all three.
मेरी तरफ से अपील सर।
वोट ऑफ थैंक्स डॉक्टर नाब और स्मिता के लिए।
नहीं प्लीज
नहीं, एक मिनट
एक मिनट।
Dr. Naab, एक date decide कर लो।
Appointment of auditor of society. The president of society briefed the AGBM on termination of contract Mr. Sharma, account of unsatisfactory services and carelessness on his part. After deliberation, the executive board decision dated was adopted and K. Chaudhary and Co. is appointed auditor of society financial year 2019-20, 2020-21. So this is that. This is adopted ना, इसमें तो कोई problem नहीं है. Agenda seven.
Adopted.
I want
Agenda
just
seven,
one request.
locking and securing the society corpus fund.
Actually, one request I want to make before closing. We want to felicitate our president and secretary.
No.
अरे सर बहुत हो गया।
नहीं, एक सेकंड लूंगा। रोनित
महेंद्र छोड़ दो यार, बस हो गया। आप घर जाके कराना उनको दोनों को, बस हो गया।
रोहित एक मिनट।
अरे नहीं सर, बस नहीं। बहुत फिनिश करो यार, पिटाई होने वाली है।
Thank you.
एक मिनट,
आप ना उनको फोन करके कर लेना अलग से यार, दोनों को व्हाट्सएप
एक बड़ी इम्पोर्टेंट चीज रह गई डॉक्टर नाब सर, आज के जो अवार्ड प्रेजेंटेशन थे उसके रिजल्ट्स डिक्लेयर नहीं किए हमने सर।
हाँ, मैं भी यही कह रहा था, काम की बात।
हाँ,
आज जो अवार्ड हुए थे उनके वो डिक्लेयर करने हैं डॉक्टर नाब सर।
जीबीएम से पहले होते हैं डिक्लेयर।
कोई बात नहीं।
मैं बता रही हूँ आगे।
जो बंदा शांत होता है, ही इज नोटिंग द थिंग्स। क्या रह गया?
अनुराग,
पोस्टर प्रेजेंटेशन के भी अवार्ड्स होंगे। पोस्टर प्रेजेंटेशन
वही तो कह रहा हूँ सारे
पोस्टर के अवार्ड्स नहीं आए हैं।
के लिए नेक्स्ट डेट
डॉक्टर स्मिता, मैंने आपको व्हाट्सएप किए हैं। मैंने व्हाट्सएप किए हैं आपको डॉक्टर स्मिता, मेल भी किए।
डॉक्टर स्मिता डिक्लेयर कर दीजिए।
हाँ, एक बार वो शेयर कर दो दोनों।
सर मैं तो कर रहा हूँ, करनी क्या देंगे सब।
कोई नहीं, कर दो आप, एक मिनट कर दो।
क्या कर रहे हैं?
हाँ, पहले डॉक्टर नाब और फिर डॉक्टर स्मिता का।
क्या चीज? तो डॉक्टर जूही गुप्ता इन पीएन तनेजा अवार्ड. Dr. Jui Gupta got 126, and the second position is Dr. Puneet Kumar Chaudhary got 110. Okay. So first and second, and Alpana Meena got 96.
ये क्या दिखा रहे हैं सर?
हाँ सर, ये हमारी तो एक छोटी तरफ से फेलिसिटेशन है, क्योंकि बिफोर वी आई डोंट नो हाउ मेनी पीपल विल बी लेफ्ट. ऑफ कोर्स फिजिकली वी विल डेफिनेटली मीट. दिस इज माय आवर मनीष एंड मी फेलिसिटेटिंग डॉक्टर.
सर ये 1 तारीख को करना जब आपका टेक ओवर हो जाए. अभी वही प्रेजेंट सेक्रेटरी है.
नहीं, आई थिंक राउंड ऑफ अप्लॉज प्लीज.
राउंड ऑफ अप्लॉज तो कर सकते हो.
राउंड ऑफ अप्लॉज कर लो. ये मोमेंटो आप 1 तारीख के बाद दे सकते हो. अभी तक वही है.
डॉक्टर मनीष प्लीज फेलिसिटेट डॉक्टर स्मिता आल्सो. रोहित, सेकंड स्लाइड.
चलो हो गया.
Thank you, Dr. Smita,
for working under such tough conditions. Really appreciate your willpower, madam. Thank you, madam.
देखो मैम, मनीष ने एंडोर्स कर दिया.
Charity work and everything superb.
चलो अच्छा. हाँ मैम, वो अवार्ड्स बता रहे थे आप.
सत्या गुप्ता में there was only one person who participated.
That is the best award.
So he won. So Satya Gupta was there's no competition.
नाम बता दीजिए डॉक्टर स्मिता. नाम बोल दीजिए इसका नाम.
हम बता रही हूँ.
नाम बोल दीजिए डॉक्टर स्मिता.
हाँ, एक मिनट बता रही हूँ. ये हाँ, तो सत्या गुप्ता इज डॉक्टर डॉक्टर सौरदीप बानिक, BLK हॉस्पिटल. And the third one, there is the Dr. Chintana was not there, and Dr. Asma and Dr. Sujoya, there is a tie between two.
Tie? Okay.
चलो, congratulations.
कैसे वो बाद में डिसाइड करेंगे क्या करें.
चलो ठीक है.
नहीं, दोनों को देना पड़ेगा.
Congratulations.
तो this is AIMS and UCMS के बीच में tie.
दोनों को दे दो.
दोनों को देना पड़ेगा.
हाँ, दोनों को देंगे और अवार्ड मनी दोनों को डिवाइड कर देंगे.
हाँ, परफेक्ट.
यस, बिल्कुल.
और दोनों को
एग्री.
अवार्ड मनी भी अलग अलग दे देंगे जी. इसमें क्या जाता है?
नहीं सर, वो हिसाब करना बहुत मुश्किल होगा बाद में आपके। अब मुझे समझ आ गया आज की उसका ना 500 रुपए का भी हिसाब करना ही ठीक है।
अनुराग पूछेगा भैया कितना खर्चा
300 रुपए का एक मोमेंटो पे
पूछेगा
इतनी बात
300
हो
रुपए
गई।
कहाँ चले गए?
300, 600, 1000 रुपए का मोमेंटो है, उस पे इतनी बात हो जाए तो फिर क्या बात। ठीक।
But physically,
नेक्स्ट
physically will be
जो
felicitating, ma'am.
हाउस
This
का
is just
मीटिंग होगा ना डॉक्टर
virtual.
अनुराग के साथ जरा फाइनल कर लो डेट।
सुमिता आपको व्हाट्सएप किया था पोस्टर प्रेजेंटेशन, या मैं दोबारा भेजूं?
दोबारा भेज दो।
अच्छा, मैं व्हाट्सएप कर।
Dr. Dubey, you have final comment?
No, it's fine. I just wanted to say that election process we should, do it early. So
Right.
if by tomorrow, if necessary for vice president and other posts, you can issue.
मिल गया अजय। अजय, first
And for
Ketan
the
Singh।
election
minute, ma'am.
process, Dr. Vasudev can tell us that what is the arrangement. So we can proceed, so that we can proceed and complete it before 31st.
So we want to
Dr. Mila,
just make
आपको
sure this
मैं
should be
भेजूं?
a legal process, constitutionally कोई problem ना आए, नहीं तो फिर पूरी साल हम यही election में ही लगे रहेंगे। I really want कि not why 3 weeks, why 10 days, मैं तो आज ही चाहता हूँ, लेकिन अब नहीं हो रहा, तो anyway, but it should be as rapid as possible. But there is no point in saying it, sir.
सही बात है, ठीक है, जल्दी करें।
ठीक है सर।
सर 3 चीयर्स कर दो अब, नव सर और
ठीक है,
स्मिता मिल
मैं वो डिक्लेयर कर रही हूँ पोस्टर प्रेजेंटेशन के रिजल्ट। डॉक्टर
दस कर रहा हूँ, 10
मदर केयर एंड रेटिनोपैथी
कर रहा हूँ मैं।
वैसे
अरे सर रोहित को बोलो क्लैप ही खोल दो बैकग्राउंड में।
I'm thankful to all of you for all the support, but
पोस्टर सर 1 मिनट रिजल्ट डिक्लेयर कर रही हूँ। चेतन सिंह फर्स्ट एंड सेकंड है डॉक्टर सुधीर कुमार। Prognostic significance of serum procalcitonin level in critically ill patient 2 months to 12 years, admitted in pediatric intensive care. So this is second, and the third is Dr. Aparajita Raghav. Role of serum inflammatory marker in predicting bacterial meningitis among the neonate with sepsis. अच्छा, और एक और ये है कि हम लोगों ने यही डिसाइड किया था कि जितने लोगों ने भी अप्लाई किया है पोस्टर और दी पेपर्स रिजेक्टेड आर एक्सेप्टेड बट विल बी गिवन ए सर्टिफिकेट ऑफ पार्टिसिपेशन।
Yes,
एंड
that
एप्रिसिएशन।
has to be given.
ठीक है, ठीक, बिल्कुल ठीक है।
हाँ, बिल्कुल परफेक्ट है, क्योंकि 2 साल पहले एक हमारी पीजी को नहीं दिया गया, वो ढूंढती रही एंड तक ना।
डॉक्टर समिता वोट ऑफ
देना चाहिए सबको।
एक चीज वो मैं एक चीज हो रहा है कल्चरल प्रोग्राम में अभी तो मैम प्राइजेस दो, सबने पार्टिसिपेट किया है टू
थैंक यू ऑल।
वो तो देना है आप
डॉक्टर ललित मेहंदी रहता हुआ
मैम सबको दो, सबको।
डॉक्टर ललित को मैडम आज ही चार्ज दे दो, ये चार्ज है फुली, आप लग चुके हो, हमें पता है।
अच्छा भाई, मेरी एक रिक्वेस्ट है, एक 2 शब्द बोलने दो, चाहे हिंदी में बुलवा लो चाहे इंग्लिश में, जो लैंग्वेज आपको अच्छी लगे।
इंग्लिश
बोले यार, इसमें जो
दोनों भाषा समझ आती है।
पूरे साल में बहुत सहयोग रहा, and I am extremely thankful to all of you. Dr. Samita had been a great support to me, I'm telling you, and I am really thankful to Dr. Lalit.
वही तो कंप्लेंट है सर।
डोंट टेक पर्सनल।
दोनों और डॉक्टर ललित एक दूसरे को थैंक कर लेना फिर।
नहीं, सुनो मेरी बात, मैं डॉक्टर ललित को मैं एज ए प्रेसिडेंट इलेक्ट आई हैव टोल्ड हिम ईच एंड एवरीथिंग, right, whether it's a financial matter, whether it's an administrative.
I agree sir, I agree.
I was kept in dark, but I told you each and everything.
That's true sir, that's true. And that's true.
And if you still think that our term was not appreciable up to that level, next team will try to do better.
सर दिल पे मत लो सर।
अरे सर क्या बोलते हो आप सर?
सर 2 शब्द मेरे लिए भी कुछ बोल दो सर।
कृष्ण जी ने कहा अपना कर्म फल की चिंता मत करो, बस अपने दिल से काम किया है।
वेरी गुड सर, ग्रेट।
ऐसे डॉक्टर अनुराग ने हमारे डीवर्मिंग वाली बुकलेट लिख दी और मैंने परमिशन ली नहीं, पेमेंट भी किया है। अब पता नहीं किस का पेमेंट का मुझे वो देना है।
अनुराग की जेब से काटो मैम। वैसे मैम एक चीज है, इलेक्शन के पैसे कैंडिडेट से क्यों नहीं
कटवाएगा?
अब 2 शब्द आप बोलो और खत्म करें जी मीटिंग।
अनुराग आप अपना डेट फाइनल कर लो, कब आपने मीटिंग करनी है फाइनेंशियल वाली, अभी इसको क्लियर करके एंड क्लोज इट।
नेक्स्ट संडे रख लेते हैं सर।
संडे मत रखो यार, संडे हमारी 2-3 मीटिंग्स है।
नहीं सैटरडे रहने दो सर,
संडे मीटिंग्स है, उसके बाद रख लो।
we want to keep it on working day, not on Sunday.
Friday,
आफ्टरनून में रख लो, फ्राइडे
Friday sir, Friday.
ये फ्राइडे जो आ रहा है 5 दिन के बाद, मेल डाल दो सारे मेंबर्स को जो भी अटेंड करना चाहता है, ऑल दी
तो
मेंबर्स।
7 दिन हो जाएंगे क्या सर, अगर हम लेटर फिर भेजेंगे? अभी लेटर जा चुका है, ये लोग मान
मेल
के
मेल
चला गया।
मेल
मंडे रख लो 14 तारीख को।
तो फिर 7
मंडे रख
दिन
लीजिए,
चाहिए ना,
मंडे।
फिर अगला
मंडे
हफ्ता
रख
होगा।
मंडे
Next
14
week ना?
14 तारीख मंडे रात को 8 बजे।
No. We don't like that.
सर आफ्टरनून में रखो सर,
Have around in the afternoon when we are free.
3 to 5.
2 to 5 सर, 2 to 5
2 to 5 sir, ठीक है सर।
ठीक है।
और भी कुछ एजेंडा
क्या मीटिंग
एक्स्ट्रा
करोगे?
फाइनेंस
1
कमेटी
घंटे आधे घंटे का मैटर है,
हाँ,
4 से 5
15 मिनट
नहीं। इसमें बहुत बच्चे हैं, हम लोग थक गए इसको सॉफ्ट वो करते करते, इसमें बहुत।
अनुराग रहेगा तो 15 मिनट का मैटर
नीतू
नहीं
से
है।
भी पूछना
कह रहा हूँ कि मैं
पड़ेगा,
अकेला क्या
डॉक्टर
करूंगा?
ऑफिस से भी पूछना
We'll
पड़ेगा
request
कि
Dr. Anurag to be there. All
I'll be there sir।
अनुराग रहेगा तो सर 15 मिनट में खत्म नहीं होगा मैटर।
अच्छा
15 दिन लगेंगे, उसके अगले के 15 दिन भी लगेंगे।
उसमें
there might be another meeting planned
and
after
Dr.
that.
Tamaria must be there. Dr. Tamaria must be there in that meeting.
और ये भी होगा सर, जो इनकम टैक्स का है वो भी मैनेज बताएगी वो क्या हुआ है।
14th Monday 3 o'clock is okay with
इसलिए मैं कह
everybody.
रही हूँ कि 16 में तब
दोपहर को 2 बजे।
जब कोमल
Okay, sir,
उनके,
okay.
मतलब चौधरी के ऑफिस से आ
3
जाएगा।
बजे।
सीए शुड बी देयर कि उसने क्या किया इनकम टैक्स का भी बताएगी, वो प्रेजेंट करेगी।
बिल्कुल बिल्कुल
ठीक
क्योंकि
है।
ऑडिट भी वही
But
समझाएगी।
afternoon,
आई एम वेरी
afternoon.
पुअर इन फाइनेंस, आई डोंट अंडरस्टैंड फाइनेंस एट ऑल।
थैंक यू।
Okay.
डॉक्टर स्मिता आप एक सर्कुलर निकाल दीजिए मीटिंग का।
हाँ
हाँ 16 तारीख को, पर पहले वो कोमल चौधरी से वो कर लेना कंफर्म कि उनके
हाँ, उनसे कंफर्म करके फिर आप निकालिएगा।
14
cheers for the IAP Delhi team।
चलो
Cheers.
सबकी एक फोटो तो ले लो, सबकी एक
Happy
फोटो ले
birthday.
लीजिए,
Happy
सबकी
birthday.
एक फोटो ले लो।
Happy birthday.
चेहरा फोटो लायक नहीं
Happy
रहा।
birthday. 3 cheers to।
Thank you.
सर आपका चेहरा हमेशा चमकता है, आप ये मत बोलो आपका चेहरा खराब हो गया।
नहीं, पर यार मजा बहुत आया भाई। We enjoyed thoroughly working for IAP Delhi.
सर आते रहेंगे,
Oh,
मजे
yes,
चिंता
you
मत
have.
करो, मजे आते रहेंगे।
नहीं अब
पर हो गए सर।
You are always with us।
सर you will be past president, you are a part of OB next year also।
अरे ओबी नहीं कह रहा मैं, विदाउट ओबी कह
अगले साल की वो भी सामने डिस्कस होनी है।
You will be past president and OB member, सारे डिसीजंस आपके साथ होंगे सर।
हमेशा साथ रहेंगे यार वो तो।
हाँ वही मैं कह रहा हूँ।
चलो सर आपके लिए अब 3 cheers हो गए।
ओके बाय बाय।
बाय सर।
Okay.
तो घर से निकाल दिया जाएंगे अब।
Bye bye.
अगली बार ना ओबी रहेंगे ना ईबी रहेंगे।
घर में तो बैठा है, बैठा तो घर में ही है।
घर में तो बैठा हूँ सर, तो किसी को ध्यान थोड़ी दे रहा हूँ।
वैसे बड़ा ध्यान देता है तू।
कह रहा है
सर देना पड़ता है आपको, पता है।
बीवी तो रहेगी ना ओबी ना ईबी, बीवी तो है ना घर पे, बस
वो भी छोड़ देगी सर।
वो भी छोड़ रही है क्या?
अरे डॉक्टर भंडारी सर,
अनाथ हो गया।
अनाथ हो जाऊंगा सर मैं बिल्कुल।
डॉक्टर समिता वोट ऑफ थैंक्स करिए और चलते हैं जी।
थैंक यू वेरी मच डॉक्टर नाग, डॉक्टर वासुदेव, डॉक्टर तमरिया, डॉक्टर पीयूष, डॉक्टर अनुराग, डॉक्टर प्रशांत, डॉक्टर पंकज और डॉक्टर मेहंदी रता, डॉक्टर मनीष, डॉक्टर आलोक भंडारी, डॉक्टर देवेंद्र गाबा एंड हु इज डॉक्टर आर्यन श्रीवास्तव, डॉक्टर शिव कुमार, डॉक्टर। तो I am really thankful to everyone. It was a nice session and we have learned more about the finance finally. So we will try to learn even more in the next meeting, and I really wish all the best to Dr. Mendi Rata and Dr. Manish and the next TB. I'm really enjoyed, but 1 year I really I worked very with interest. I am not saying you very hard, but I really worked with interest, and there were certain shortcuts which I took, like the deciding on these small memento to few of the children, or these things sometimes help to IAP Delhi also in having a better listening.
होता रहता है मैम, ये
तो थोड़ा listening में अच्छा ही रहेगा, that's what.
फास्ट डिसीजन लेने पड़ते हैं मैम, कोई बात नहीं, दिल से मत
कोई डिसीजन लेने ही पड़ते हैं, उसको हर चीज को आप क्वेश्चन करोगे तो मुश्किल ही हो जाएगा।
कोई क्वेश्चन नहीं।
3 cheers for the team. Hip hip
Thank you.
hooray!
Hooray! Hip hip hooray!
Hip hip hooray!
Thank you.
Okay,
ये
bye
मुझे
bye.
positive energy.
Good night. Bye bye to everyone.
Stay fine.
Positive energy.
Dr.
Bye.
Bhandari sir,
Thanks, Smita's.
you want to say something, Dr.
Thank
Bhandari?
you. मैम आप
care,
थी
get
और
well.
मुझे दिखी नहीं हो. अच्छा अच्छा आप भी हैं तो मैडम संगीता यादव. Thank you very much for
So
being
good.
here. Okay sir.
As a
Okay
team.
ma'am.
Wonderful.
Okay.
Thank you. Okay.
Thank you everyone. Bye bye.
Bye. All
Thank
the
you.
डॉक्टर भंडारी कुछ बोलना है सर? डॉक्टर
हाँ
भंडारी
सर, अब मेरी आफ्टर द मीटिंग इज एंडेड मेरी रिक्वेस्ट एनएनएफ इलेक्शंस में वेंचर के लिए प्लीज टेक इट अप सीरियसली और जरा
आपको
वोट
डाल दिया वोट मैंने सर, डोंट वरी, डाल दिया मैंने आपको.
नहीं बाकियों
ये वोट डलवानी है.
officially closed, Dr. Knapp.
आगे तो पॉलिटिक्स में सोचूंगी नहीं मैं, आज मैं बहुत चट गई हूँ. आई एम रियली टोटली ड्रेन्ड ऑफ.
Close, madam.
आई एम टोटली ड्रेन्ड ऑफ. मैं तो अब सोऊंगी तो कल उठूंगी.
Please close the meeting now.
6 बजे. Thank you.
Okay, all
Thank
the
you very
best
much.
and thank you.
Thank you.
Smita,
Thank
you
you
are
very
with
much.
us.
Huh?
Always. Always.
Thank you.
Chalo.
Okay. Okay. Rohit,
Take care.
Yes, ma'am.
please